together for this marvelous chirurgical retina section with people from very different countries, from US to Brazil to North Africa and Turkey. And we're gonna be very interesting things. We're gonna compare different techniques. We're gonna learn a lot. And for starting, the kickoff gonna be Dr. Garrett from New York. Dr. Garrett, welcome.
Good morning. Thanks for having me. I greatly appreciate the opportunity to speak, and it's nice to be back at one of the international QOIC meetings, even if virtually. I'll share my screen now just to show some slides. So this is presenting a case. I've been using an IOL rescue technique for about 10 years now, and it's a bit of a mashup of other techniques that have been presented and published. It sort of originated because I was doing these cases in Buffalo, New York, and really only were MA60 lenses. But this was just an interesting one because of the lens type that was involved. So this was a 67-year-old man. He had a dislocated IOL, which is something that we face in a kind of standard way these days. But it was a 3-piece multifocal IOL that had been implanted about 20 years ago per the patient. It was a proprietary lens. I really didn't know what kind it was. I'm sure there's someone in the meeting who's familiar with them or has seen them, but it wasn't one that I knew. His pre-op vision was count fingers and pinhole to 20/50. This picture is just of the IOL. I couldn't get a good anterior segment photo because we just don't have the camera at that site, but you can see the multifocal rings, and this is during partial replacement of the lens. But this is just showing what we were working with. I'm gonna switch to the video now. So I always start, it's sort of a scleral fixation and a scleral shelf technique. So I always start with peritomies at 6 and 12, but it really can be placed in any meridian. So here's the first peritomy. You can see the lens kind of dangling in the anterior vitreous. I always make the peritomies first, just so that it helps guide where I'm going to be putting the trocars. The trocars I like to place a little more at 180 degrees from each other to keep them out of the way of the lens implantation sites, but this can also be modified based on where you want to fixate the lens. This is just, I always use 23 gauge in case I have to remove any lens fragments. I've just found that's much easier to use than 25 or 27 gauge. Here I've stained with Kenalog to sort of relieve some of the vitreous from around the lens. I'm usually careful not to remove all the vitreous at this point because I want to support the lens so it doesn't fall back against the macula. That reflection is a little annoying, but just Kenalog that's drifted to the bottom of the eye. And here, just cleaning up the anterior vitreous around the lens. Sometimes I'll fixate the lens on the iris by hooking the haptic to it. This is just using a Kugelin to see if there's any lens capsule. I was trained to remove the lens capsule. I've talked to some colleagues these days who have said they like to leave it. And you know, since showing videos similar to this one, this is the first time showing this one, but since showing videos similar to this one, I've had some of those conversations, and it might be something to talk about or something that people can weigh in on, whether or not to remove the capsule. But I was always taught to remove it to prevent scarring and phimosis that might affect the lens position later on. I think some people now find it might be protective of the iris, and I think that that's a good point and maybe something worth considering. I use a 20 gauge MBR blade to make a sclerotomy. It's basically a straight incision, maybe 5 degrees inferior, or pointing 5 degrees posterior from the plane of the iris. And I extend it in the direction that the haptic's going to go. And I've always done this because externalizing some haptics can be fairly traumatic to them, and they can kink or break. And using a larger sclerotomy prevents that, or at least prevents kinks that can't be re-straightened. So this, then I make a scleral shelf through the corner of the wound and extend it a little bit towards the limbus, because haptics tend towards the limbus when you externalize them, and also if they kink, they're going to bend more towards the limbus, or just tend to do that. In terms of marking, I've tried marking with a toric marker, and I just haven't been as comfortable as just kind of directing my marker across the center of the pupil to make sure I get good centration. And obviously marking is important. I don't use a heavy marker because it just, to me, that is not as accurate as depressing enough to get a good indentation of the sclera. The marker tends to bleed, especially if you've got some fluid around it. So here's just making the other sclerotomy. You'll notice I bent the MVR blade here in left eyes in particular to make the scleral pass. You've often got to bend the MVR blade to prevent it from getting in the way of the nasal bridge or being interfered with by the nasal bridge. So here, just making another scleral shelf. It doesn't matter if you go through, this is a shallow shelf, basically. And if you go through a little bit, that doesn't matter, because really all it's doing is protecting the conj from the haptic. And this one, so I externalized it. I couldn't get, it wasn't in view in the video, so I apologize, but I've externalized the inferior haptic here, and you can see a little kink on it. I used a max grip forceps and tried to grab as close to the edge as possible, but it was kind of hanging under the iris, and so I must have grabbed it just a little bit off the tip of the haptic. And in this case, I was a little fortunate, and it straightened back out again. Sometimes if you do that and manipulate it too much, those can break off. And then these are just angle time forceps. So now once the lens is secure, I'll clean up the vitreous more and basically finish the vitrectomy. I always go back once the lens is implanted fully. Here I'm grabbing the superior haptic directly through the sclerotomy. I'm moving the lens out of the way while I'm holding the haptic, and then externalizing it through the superior sclerotomy. And if you grab the very edge, you really shouldn't get any kinking at all. And this one didn't have any kinking. An alternative, you can use, when I first started this, I was using 20 gauge Eckert forceps. Those are harder to find these days, which is why I've kind of modified it. So here is tucking in the haptic using angled time forceps. Those are McPherson's, seem to be the best. They slide the haptic right into the shelf, and the superior haptic sliding right into the shelf. The benefit of this is that there's a little bit of room to adjust the haptics or adjust the position of the lens if you need to. So I really don't have many problems with lens tilt. Occasionally, if my sclerotomies are off angle, but lens tilt really is not a big problem because there's a little room to move the haptics and adjust their position to get the lens in the appropriate position. And then one of the features here is I looped the haptic with a 7/0 vicryl. So that first pass of a figure of 8 suture around the sclerotomy is underneath the haptic, and then the second pass is right across the corner of the sclerotomy. And then when this tightens, it both closes the sclerotomy so it's watertight and locks the haptic in position. And that's just going to tighten in a second. And then to close, I've always liked using 6/0 plain gut because it's much less inflammatory and patients are much more comfortable. I'll switch back to the PowerPoint now. So the advantage of this technique is that it's been extremely versatile. I've really had no trouble refixating or saving any 3-piece lens. It uses very common instruments, so no matter where you are or what OR you're in, most places have a 20 gauge MVR blade, different kinds of forceps. It's a fairly straightforward technique, so there's not a large learning curve for it, and less chance of tilt, which allows for some adjustment of the lens if you need to. Some of the disadvantages, it is a little slower than the Yamane technique, especially once you've worked up the learning curve and gotten good at Yamane. It's definitely faster, but I think that the versatility of this makes up for that. And then obviously it's, it requires peritomies, and so there is a little more bleeding, and it's not as slick or cosmetically nice as Yamane either, but I think that it's served me well over the last about 10 years. And these are just 2 other lenses. This one on the right, bottom right, was a single piece PMMA lens that had long enough haptics to externalize them. It was a wonderful surgery, but within a couple of weeks, one of the haptics slipped, and so I had to replace the lens anyway. But it was just sort of showing the versatility and the ability to try to save lenses that may be atypical. So thank you very much.
Dr. Gart, amazing technique. Do you think that technique is more stable than Yamani, and you can use in any type of lens optical? You can use in different, because you just fixate one multifocal lens, and looks good because was very center and very stable, and we can use this for fixate this multifocal, no?
Yeah, so that's really been the benefit, is that I haven't really needed to worry about what kind of lens is in the eye. So patients coming with a lens that was implanted at some remote time period hasn't really created much of a challenge, which has been really nice. I hadn't thought much of this. I've just been using it, and now that I'm working with more fellows, they seem to ask to learn it, and so I thought it was worth showing. But that is the major advantage. Someone asked how far back I'm going with the sclerotomies on the chat, and that's 2.5 millimeters from the limbus.
From the limbus, 2.5. Good. Very nice. For the sake of the time, we have to move on. And now we have from Brazil, Dr. Leandro Zacarias. I'm gonna present different approach for subretinal PVR.
Hello, everyone. Good morning here in Brazil. Good afternoon. How are you guys? And it's a pleasure to be here in this fantastic meeting and to learn with you. And today I'm going to talk about different approaches for subretinal PVR. Subretinal PVR is a condition that sometimes we don't need to deal with. We can leave it there, but sometimes, as I'm going to show it to you, we have to remove it, and there are a few ways to do it, and I'm going to show them by showing a few cases, sharing with you a few cases. The first case is a 22-year-old male with progressive visual acuity loss over 7 months. His visual acuity was 20/70, and as you can see here, he had a chronic retinal detachment caused by some lattice in the supratemporal area, and he developed these strains of PVR that look like a web and went through the macula. As you can see here, it's in the OCT, you have this very sharp angle, and I thought I would have to remove these PVR bands in order to have a good anatomical and visual outcome. So I'm going to show you the video. I started putting a band, a 360 band in this case. You can see how the PVR affects the macula. And that's why I thought in this case I had to remove it. So first of all, I threw a band. I want to make sure you understand, most of the times we don't have to deal with some strains of PVR, but in this case I thought it was relevant. As this is a very young patient, we assume the vitreous is really attached. So I used some triamcinolone to create the PVD. So I'm doing the posterior vitreous detachment right now. And you'll be able to see in a few minutes the lattice where the small holes created the detachment. And after the vitrectomy, then we go for you can see the lattice right now. Then we go for the removal of the bands. This is the approach I use most of the time. I do some endocautery and create a small retinotomy. And by doing at the nasal side, I could pull the bands that went through the macula without having to deal with the macula. I thought that was nice in order not to poke on the macula. As you can see, I removed some strains. There was some traction in the inferior area as well. So I did a second retinotomy, and by applying this tangential traction, I could remove this band. And after those bands were removed, the retina got much more mobile. I used some PFO to stabilize the posterior pole and to trim the peripheral vitreous. Now you can see a very thick subretinal fluid that is leaving from the retinotomy, this Schlering, showing that this detachment was very chronic. I had a little bit of subretinal PVR in this nasal area, so I decided to do a third retinotomy and remove it. And then I could flatten the retina, do a fluid exchange, laser, all those three small retinotomies that I created, and also laser the peripheral retina where the lattice degeneration created the detachment. I tamponade this with C3F8, and the final visual acuity after a few months was 20/25. So a very good outcome for a complex case. I'm going to move on to the second case. This case is another case where I had significant subretinal bands. It's a 32-year-old, only eye, high myopic female. She had -18, and she had a MAC-on retinal detachment that was treated with a buccal a year before. And after a few months, she redetached the inferior retina with macular involvement due to this circumferential subretinal band that I think you can see here. In this case, I was afraid to do a small retinotomy, and I was afraid of the risk of a chronic retinal detachment due to this very poor RPE that this patient had. So I decided to do a vitrectomy and a large retinectomy and flip the retina over in order to dissect this the circumferential band. And this band was very adherent to the retina, so I had to use the light pipe as a second hand in order to do a blunt dissection and release this band, as you can see here. So I'm using the light pipe in order not to damage the inferior retina. I could remove this band, add on some PFO. It's very important to shave, to trim this retina when you do a retinectomy. I lasered it, fluid exchange, and left with silicone oil. This patient remained stable with a vision of 2100, and I could remove the silicone oil after a few months, and she did fine as well. But this is another approach. It's not the most common approach, but in this case, I thought it was a nice approach. And finally, I'm going to show you another case, a very special case. It's a 52-year-old female that had a complaint of a sudden visual acuity loss over the last 2 weeks, especially in her inferior field. And her visual acuity was 20/20 in both eyes. And we could see those bands, those subretinal bands here. In a wider angle picture, you can see that she had superior subretinal bands, and it was caused by a very small hole in the superior periphery of the retina, and she had this chronic retinal detachment coursing with subretinal bands. And probably she realized she had this inferior field when it progressed a little bit. We can see OCT here. We can discuss how OCT looks like for subretinal bands, but always these very hyper-reflective bands below the retina. And I have several views of it. And in this case, we decided we had to treat this patient, but how to treat is a challenge. And we decided to try a pneumatic retinopexy and laser the tear. And this patient did very well without having to remove subretinal bands. And so I have this follow-up. There's a small area where the bands maintained very non-significant retinal detachment there due to distraction, but the patient did very well. So I showed you three different cases. In most of the cases that I have to remove the bands, I do small retinotomies, as you could see in the first case, but we have several ways to deal with subretinal bands, and in most of the times we don't have to remove it. So we need to individualize the approach based on the characteristics of each patient. Thank you for the attention. Obrigado. And that's what I wanted to show it to you.
Leandro, so nice to see your cases, and it's very tough sometimes to remove all the subretinal band. But the question that came on my mind is, as you said, we don't need to remove all the bands, and how to decide to leave or to remove the subretinal band. Sometimes it's not easy decision.
It's not an easy decision. The first case that I showed you, the band was very close to the macula. So I thought it would cause chronic traction even if I solved the detachment. So I thought it would be very nice to remove it in order to have a nice macula for the patient. In the second case, the band was the cause of the redetachment. So it was clear that I had to remove it. Well, those are very special cases. In most of the cases, we have some subretinal bands, and we can flatten the retina even by having a small traction that is left over there. You don't have to deal with that, because in order to remove the band, you have to do a retinotomy or a retinectomy. It's invasive. So most of the times you can leave the subretinal band there.
Okay, thank you so much. Now I'm gonna move to the giant retina tear. Don't worry, just make it flat. From Dr. Mustafa Shabu. Hi, Dr. Mustafa. Good to talk to you, and my pleasure to have you here.
Thank you very much. Good afternoon, everybody. It's a pleasure to participate to the nice meeting. I'm Dr. Jabbour from Algeria. Okay. Giant retinal tears are defined as a vertical circumferential tear of more than 90 degrees of the peripheral retina. In the majority of cases, the posterior there is a posterior vitreous detachment. They can be spontaneous or occur as a result of number of conditions. Surgical management may be challenging due to its high risk of intra and post-operative complications. They count for approximately 1.5% of regmettanous retinal detachment, and the average age of incidence is 42 years. There is higher incidence in males than females. Although general retinal detachment can occur spontaneously, and they're often associated with a number of conditions. About 12.8% of patients develop bilateral general retinal detachment. This pathology occurs from liquefaction of the central vitreous associated with peripheral vitreous condensation. Concomitant actions in the region of the vitreous base will result in circumferential tearing of the retina. In these conditions, the vitreous remains attached to the anterior flap of the retina, while the whole posterior retina moves freely and can fold upon itself. This increases the risk of PVR because RPI gains success to the vitreous. Let's you show my video. Here we are using 23 gauge sclerotomy, and you can use the 25. We prefer using a valved cannula system to decrease the incarceration of the vitreous and the retina in complicated cases. So we've done a third vitrectomy, and it's important to do the vitrectomy, the anterior vitrectomy, as fast as possible, because in the majority of cases, spontaneous PVD is already present. The vitreous base is doubled to the maximize extent possible using high cut rate and low vacuum. Here we can see that the posterior flap of the tear is inverted and the edge is unrolled. The anterior flap of the tear should be completely removed with adherent vitreous to avoid the circumferential anterior PVR. When the flap is inverted, we can unfold the retina using PFCL. We gradually inject it over the optic disc as an enlarging sample bubble to avoid small fish eggs to cross under the retina. Here, as you can see, the edge of the posterior flap is unrolled and contracted. So we decide to proceed with endodiathermy to ensure the hemostasis before trimming the posterior edge of the giant retinal tear. Then we are trimming the posterior flap with the vitreotomy. And we performed the laser along the posterior edge in 2 or 3 rows of burns. In our practice, we also prefer to do 160 degrees of laser. Cryopexy is done along the retinal tear horns. And finally, we prefer doing direct PFCL silicone oil exchange to avoid the slippage for the posterior flap. So the comparison using the gas versus oil, silicone oil, while some studies demonstrate that gas has a better visual outcome with fewer complications like uveitis. Direct PFCL oil exchange is useful in cases of giant retinal tear because of minimizes the risk of retinal slippage. Using the buccal or not, some authors find that scleral buccal, in addition with vitrectomy, may decrease the peripheral traction, especially in phakic patients, while others consider that when the general retinitis is up 180 degrees, it acts like a retinectomy with a decreased traction of the vitreous. And concerning the ILM peeling seems to prevent postoperative epiretinal membrane develop. In conclusion, the management of general retinal tears poses significant challenges due to the many complications and technical difficulties involved. The most important pills in the management of giant tear retinal detachment include trimming the edge of the tear well, injected PFCL as a single bubble, drying the edge of the brick thoroughly to prevent slippage. Thank you for it, your attention.
Thank you so much. It was a very good talk, and it's a challenge to operate patient with giant tear who have so many difficulties during the surgery. You just explained that we use direct PFO and silicone oil exchange to prevent slippage. That's something that's very frequently. And we know that's one of the problem of the giant tears is the anterior flap that's we have in the left, and this anterior flap can cause many problems. How to deal with this anterior retina that's left behind?
We do we took off the retinal flap, the anterior retinal flap, faster and possible during the vitrectomy to avoid the incarceration in the in the sclerotomy.
Yeah.
So we can use indentation with my collaborator, for example.
Yes, as you said, that's very important to trim it, all the anterior flap of the retina, because we can have incarceration, and also we can have PVR that connects this flap with the ciliary body, and this can contract, and we have chronic hypotony, and this is very important. But your technique is superb. I like very much, and I think many people learn a lot with your talk, that you explain everything from the pathogenesis to the treatment. Thank you so much.
Thank you.
But we need to move ahead to keep on time. And now we're gonna have the next talk from Dr. Ahmed Beda, and giant retinal break, unusual presentation. Please, Professor.
Yes, good afternoon, everybody. Thank you very much, Dr. Roca and the organizing committee for giving me the chance to participate in this meeting. Now, this is can you see my slides now? Can you see my presentation now, Dr. Roca?
No, not yet.
No, not yet. It's not shared yet.
I'm trying now to let you see it.
Okay, thank you.
So I still cannot see it. So can you give me the chance to return back to the Zoom meeting in order to share my screen?
Somebody for technical support, please help us.
Hi, sir. Are you on your Zoom screen? Can you see a green share screen button on the bottom panel in the center of the screen? green color button that says share screen. Yeah,
So, but now?
now we can see. Thank you so much.
Okay. Okay. So this is about another joint retinal break. Actually, this is a case of joint retinal break retinal detachment with unusual presentation for at least myself. So this is a patient who presented with this retinal detachment, which is present in the inferior nasal part of the retina. You can notice the presence of this fold. Can you see it here? And the retina temporal to this fold is attached. When I went to the periphery of the retina, can you see the full picture of my my detached retina? You can see a giant retinal break in the periphery of the retina. Can you see it, Dr. Rocca? Is it clear, or the bar prevents?
Yes, clear. You can see.
Clear. Yes. So if you notice here, this lateral edge of the giant retinal break is somewhat centrally displaced, and this part is attached. This fold is formed here. So the question is actually, how did this fold form? No other retinal breaks are present. It's only this giant retinal break and detached retina. So the explanation for me was that this part of the retina was probably totally detached, and then it's spontaneously reattached in the wrong place. So this part, which was temporally located, is displaced nasally and formed this fold here. So the question now is, can perfluorocarbon liquid injection solve this problem? Can perfluorocarbon liquid flatten this fold of the retina? The answer to me was that if I inject perfluorocarbon liquid in this situation, this will not displace the retina temporally, because this part of the retina is attached in place. So if you inject perfluorocarbon liquid, this will make a compression fold of the retina, which actually will be very difficult to treat later on. So how can we solve this problem? I thought of two things. The first is to use a 41 gauge needle to inject fluid under the retina in order to elevate this part of the retina and then displace it with perfluorocarbon liquid. However, I felt that injecting injection of subretinal BSS here with a 41 gauge needle might lead to escape of the fluid in this part of the retina, which is detached already, and will not, this fixed fold will not allow the fluid to detach the part of the retina which is attached in this part. So I thought of another thing to do. Actually, this was my first time to see such a fold with giant retina breaks. So this is the video showing the part of the fold here, and the part which is attached temporal to it. I decided actually to mechanically detach the retina. So I used the forceps to catch the edge of the giant retinal tear, starting to detach it from the periphery to the center. It actually worked in the beginning. It was easy to detach this part. However, exerting traction manually after some time started to create tears at the periphery of the joint retinal break edge. So I shifted to use the back surface of the vitreous cutter itself to mechanically separate this retina from the retinal pigment epithelium you can see here. Unfortunately, the use of the back surface of the vitreous cutter led to some traumatic damage of the RPE. You can see it here. I continued actually to detach mechanically this part of the retina until reaching the temporal edge of the optic nerve head. You can see here some trauma to the retinal pigment occurs heterogeneically. However, you can not see it. This is the optic nerve head. I have just reached it. At this point, I felt sure that this fixed fold now is unfolded, and I think it's safe now to go for injection of perfluorocarbon liquid. And you can notice that injecting perfluorocarbon liquid actually led to flattening of this fold, and the retina got flattened, and I continued as usual with laser treatment and then air perfluorocarbonate with exchange of silicone oil template. So this is the appearance probably 1 week after surgery. The central retina is attached, and this is the periphery. If you compare the image before surgery and this is after surgery, the fold has disappeared. And if we compare the composite fundus photograph, the retina was totally flattened and attached. And this is the appearance 1 week later, where everything was finally attached. So thank you very much for allowing me to share this experience of this patient with you. Thank you very much.
Thank you, Professor. Very unusual case for sure. And you make this with a lot of skills and has a very good result. And do you think that if you just attack the giant tear and leave with oil and position, the fold will not open with time, just with the pressure of the gas or oil?
This fold is present between the macula and optic nerve. And if this fold is unfolded, this will lead to a terrible fold, which will definitely affect the final visual outcome of the patient. This will produce definitely metamorphopsia, and the patient will definitely be unhappy. I felt I should have unfolded this fold before proceeding with completion of the surgery.
Yes, I agree. Very nice. Let's move because we are almost the end and we have more beautiful talks to see. And now our friend from Turkey, Dr. Nur, is going to present the chronic retinal retinal detachment in a child, read technique to choose. Hi, Dr. Nur, you are very welcome here. Thank you for joining us, and it's all yours.
Thank you. It's my pleasure and honor to be here with you with such a nice talks. Thank you for the kind invitation. I'm from Istanbul. I'd like to share my screen now. So I think you see my screen now. Just a minute. So there has been many talks related with the subject also, but in a chronic rheumatogenic child, this is our case now. It's a 7-year-old boy referred from abroad, and it's the left eye. It is like -13 dioptry myopic eye. And the mother talks that the chronic retinal detachment maybe since 3 years, but since 6 months, the vision is affected. So the vision was worse. We know this from the history. And when we examined, as you can see here, there's demarcation lines. Only the upper nasal side is attached, but the rest is detached. Macula is off. With some thin subretinal membranes. Maybe this is not the periphery now, but also under the fovea, there's some kind of membrane formation. And the big tear, big horseshoe tear infra temporarily. So which technique to choose? For young colleagues, we have we already know that we have 3 options, and sometimes we combine the techniques. In Turkey, we have a saying that every man or every brave man has his own way of eating yogurt. So this is to show that, of course, we should pick the technique that minimum morbidity and complications, and with the highest first surgery success rate and functional recovery. So, and also regarding the technique to choose in a detached eye, of course, we consider many factors like the eye of the patient, and also the experience of the surgeon. Sectoral buckling, as we all know, that has a single operation success rate and also visual acuity higher in phakic eyes already in the studies, and especially young myopic phakic eyes, inferior breaks, dialysis, pediatric cases, especially, which we all see some cases already, chronic inferior detachments, and even some subretinal bands, and even some PVR, we can go for the buckling surgery. It's an extraocular surgery, preserving the lens, of course, but needs experience, and the learning curve is a bit higher. So we can pick the conventional method, but we need the good use of indirect ophthalmoscopy. And there's always, there has been chandelier-assisted buckling has been very popular since its publication because of the better visualization and because it's educative. And we may find small tears in small pupils if there's a media opacity, and even we may increase the indication in antidactyl or even some posterior tears. So the case, when I go back, so I picked a scleral buckling in this case. It is a surgery now. It's a bit fastly edited, but I will just stop in between sometimes, because first we should have a plan in every buckling surgery, considering especially young colleagues if they are watching us. We put the scleral band first and suture, because when we put the chandelier, we may just touch the lens when we just turn around the eye. And then this is the band sutured, where we will not use for a drainage or something. And this is the chandelier. This is the trocar. We may use 20. Smallest is the better, actually, 27, 3, or 5. And the trocar, I prefer valve, because we sometimes and get in the eye. And so this is the retinal exam. As we can see, it's like the vitrectomy, wide angle visualization. We can see there is a large tear infratemporally. It needs a radial buckle, of course, because to prevent the fish mouth phenomenon. And then the retina is detached, some membrane. So the radial buckle is placed, is marked. I sometimes use diathermy just in the middle, because the marking point just cannot be so sharp and in the wet area. I put the radial sponge, and I mostly drain subretinal fluid, except very shallow detachments. I prefer the conventional method, which I'm very happy for. And I don't push for the drainage area, but I just lift the area to the from back to front, so it makes, and you can in this way make the posterior fluid come to the periphery and drain readily. So exceptionally in this eye, I preferred, exceptional in this eye, I prefer to do with the curved laser probe with light illuminated. So as the surgeon uses the laser, we have to move very slowly in the vitreous, of course, and it's good focus. You can do very nicely your laser. You can see very well, like in the vitrectomy, but of course in the video it's not shown very nicely. So you can see those macula is already attached. It is membranes. There's a cyst in the nasal area, but the band is located covering all these areas. So I take out the trocar. We should always clean the vitreous, and scleral entry must be sutured, because there may be some vitreous wick and risk for endophthalmitis and detachment, peripheral tear, of course. So the band tightness is checked, and this is the end of the surgery. So of course, we sometimes do the cryotherapy if we have at hand, or indirect laser ophthalmoscopy. So this is the retina. It is attached to first postoperative day. As you can see, the demarcation lines, some thin membranes down, especially the macula even, and the radial sponge is placed at the right place, and the macula is attached with a visual post-op recovery of 20/200. So why I picked this case, because I have to give the message, my take-home message for especially young colleagues, especially in young, high myopic eyes, pediatric eyes with subretinal bands. We should always go for buckling first, because of the many technical problems. The posterior hyaloid is very tightly attached, mostly in these eyes, and the vitreous is formed. It makes a good tamponade effect, and we can preserve the lens. But we should teach and learn the technique, of course. And chandelier-assisted vitrectomy buckling gives us the opportunity to increasing the usage of this nice technique. So thank you for your kind attention. And I would kindly like to invite you to the 20th European Vitreoretinal Society which can be registered also online at the end of August in Cappadocia, Turkey. Looking forward to meeting you there. Thank you.
Noor,
Hi.
it's amazing as always. And thank you so much for this wonderful talk. And I think your message is very important for the young surgeon. Buccal is still a very good option, in special in young children, because the vitreous is very attached. Go for vitrectomy is not easy, and sometimes have so much complications, and sometimes kill the eye. And then you have shown something that's very unique. You just place a circumferential band, and underneath you put a sponge, radial sponge, to make sure that we have a very good indentation in the right place, and make sure that you protect all the vitreous base. And do you think, my experience with sponge not too good, but your experience, you think that sponge in that position gonna not be strewed and have complications?
Actually, I have many experience with the buckling and radial sponges, and also sometimes circumferential sponges with grooves. For example, if you make your sclerotomies deep enough and you suture, for example, I don't make the knot in the beginning. It is maybe a trick, of course, maybe we all do. After drainage, the eye become a bit hypotenuse, and then you make your knots very nicely. And whenever we making the knots, always my assistant just holds the suture and indents inwards. Not I don't do it myself. I just ask my assistant to indent the knot. So I suture one and then one and make a tight suture, of course. And the second one, the conjunctiva, if you close the tenon and the conjunctiva, I also make it important to close. Whenever I open, I close, like I open the door, open the eye before I touch the eye. So, and so what I do, radial sponge, I just trim the ends and make it not like a strict hole, but I just trim the ends, for example, make it like an oval or a bit, whenever the sponge is close to the conjunctiva, the limbus area, I trim it. It's half, for example, half thickness. And so it is the buccal, radial, and that comes to the limbus area, it is less in thickness. I think it is the tenon just closes on top, and it becomes, the surface is a bit not so smooth. So the tenon is attached very nicely. So I didn't have any case with, how to say, it is always in its place, let's say.
It's good. And you has shown as well the chandelier technique. That's pretty nice. And what tips you can tell about this technique? And the specific question is, do you have any specific chandelier brand that's better than the other for use in buccal chandelier?
Mm-hmm. Actually, we can, the less is better, because we have one company like with Twin Light, for example, because it needs two entries. We can use only one of them if you like. And smaller gauge is more, actually, the smaller is the entry, the less vitreous can come out. So, but trocar, I think, is nice to have, because in other cases, we have to be, it can touch the, for example, the Twin Light, we use the Twin Light without the trocar, it can touch the lens. So when you have the trocar, it can be 27 even. I don't recommend especially one brand. The light should be nice, and it should be one that you are used to using in the vitrectomy setting also. And the valve support, because in some maneuvers, I just take it out and I take it in, take it out. So because, for example, the drainage, you just turn the eye. So you have to, again, take the light off. I think these are, and the area to make the chandelier should be at least 9 degrees, 120 degrees apart from the primary break. It can, the nasal, inferior nasal is usually a nice area for the superior breaks. But in this case, the break was down inferiorly, so temporal area has a lot of space to move. I think temporal area, superior temporal or inferior nasal are good places. And we must always suture and check the vitreous whenever, if it is small or not, for the vitreous.
That's great. Very good tips indeed. And then I think buccal is still a very good option. People has to learn this. And maybe we have here Dr. Mohammed, and that's the president of MION. Maybe he can organize a buccal course in MION this year. That's pretty nice. And thanks so much. I think EVRS in Turkey, Cappadocia, gonna be a great meeting, and I hope everyone can go there and have a good time there. And I think we're gonna have some last words of the President Mohammed Anhi. That is the guy that's behind the stage and organize all this. Thank you so much to be here with us.
Thank you.
Thank you very much, George, for moderating these sessions, and thanks for all our great speakers, friends. Thank you, Noor. Thank you, Dr. Ahmed, Leonardo, and Dr. Gareth, and Dr. Jabour from Algeria. So all of you, you have done a great. I don't have anything to say. That I would like only to thank you for accepting our invitation and be with us and give us a chance for everyone they are listening to learn from your experience. And we hope to see you also in MIOM conference in October 19 to 21 in Dubai in physical. Thank you very much and have a nice day.
Thank you very much, Mohammed.
Thank you.
Thanks so much, everyone. Was a great section. I think we learned a lot. I think all the audience is very happy with all the techniques and new ideas that you just have shown us. And thank you so much to have your time and appreciate that. Thank you all. Bye.
Thank you. Bye-bye.
Thank you. Bye-bye.
Assalamu alaikum.
How are you?
I'm good, alhamdulillah.
Glad to see you. How's everything is good?
Good, all good, doctor. How about you?
Fine, alhamdulillah. So the mic with you is on time. We are on time.
I'm all time, yes. Yeah. Can you see my slides and is my voice clear?
Yes, sir.
Well, welcome to you all. Good afternoon. Assalamu alaikum. Welcome to QOIC Buyer Symposia. At the outset, I would like to thank Dr. Mohammed Al-Amri, the organizing committee of QOIC meeting, and the buyer for giving this opportunity to speak for the symposia. So I'm going to speak on the pearls in the management of macular edema, reflecting on a decade of achievements. What are our learnings and accomplishments with aflibercept? Most of you know me. I'm Dr. Madhav Rao. I'm a consultant ophthalmologist, vitreoretinal surgeon at Burj Al Hospital in Abu Dhabi. I was supposed to be joined by Dr. Ahmad Al-Kashaf. Unfortunately, he had some personal issues. He has apologized for the same. So I would be, in fact, going through the clinical trials initially, and I would also try to present some cases later on. So what do we know about the aflibercept in the last decade or so? Now, we had an extensive experience with aflibercept, probably one of the highest used anti-VEGF in this part of the world and the worldwide. And it is the first anti-VEGF which was marketed, which came as a dual mechanism of action. It is known for its efficacy, durability. It is one drug which taught us how to treat and extend. And also with the recent label change, there is also an update. I'm going to talk about it much in the later. Now, what does it mean to our patients as a physician and to our clinics and hospital? It improves patient outcome by reducing the treatment burden, and it also improves with the efficacy. It also improves the vision. As far as the physician is concerned, it deepens our knowledge on retinal diseases. It reduces the burden, and for the clinic and hospitals, it supports the goal of optimal clinic management and resource utilization. So how did we achieve this? Now, this is possible because the aflibercept is comprehensive and highly durable, targeting dual mechanism of action. It not just acts as an anti-VEGF across A and B, and then it also is an anti-inflammatory, by which it causes meaningful vision gains in various indications. And it also be used as a proactive, individualized treatment with treat and extend, which reduces the treatment burden, as we said in the previous slide, both on the clinic, to the patient, and to the doctor himself. We can achieve RCT-like outcomes in a real world with an established safety profile. And also it's a long-term maintenance of visual gains could be achieved by aflibercept. Now, why do we call it as aflibercept as a game changer and has been delivering standard of care outcomes in the last 1 decade or so? Now, if you look at this slide, this was the registration trial for aflibercept in the indication of wet AMD. You can see the view, which was extended to another couple of years. Now, this study is called ARRANGE. ARRANGE showed a maintenance of visual acuity with aflibercept over a period of 5 years. Now, if you continue with the proactive dosing as per the study protocol, probably you can achieve the similar visual results with aflibercept. Now, again, not in many meetings we talk about the role of anti-VEGFs in treating PCVs, polypoidal choroidal vasculopathies. Now, this is one of the good slides which shows aflibercept monotherapy versus aflibercept with the rescue PDT. Now, with aflibercept monotherapy, 80% of the patients treated with aflibercept in PLANET study did not require a rescue treatment with PDT. So very important study, even though this is important because most often we don't have a PDT available with us. So even if you see a submacular hemorrhage because of a PCV, you can consider doing a monotherapy with aflibercept. The next is about the diabetic macular edema. This is again a registration trial for the indication of aflibercept in diabetic macular edema. The initial part, the left half, you can see the vistas, which was extended to a couple of years, and the study is called Endurance. The Endurance study shows, demonstrate that the vision gains could be maintained in the long term in patients with diabetic macular edema, with probably we require to inject 4.5 injections on an average in the 3rd year and 3.4 injections in the 4th year to maintain the similar visual acuity. And we also have to understand aflibercept label change now permits flexible individualized dosing in the year 1. Unlike in the slide, which is in the year 2 onwards, we can probably do a flexible individualized dosing in the year 1. Now, we all have seen these slides of protocol T, which shows demonstrated superior vision with versus ranibizumab at year 1 primary endpoint, and it was showing a superiority to bevacizumab over 2 years. Now, what is important to understand here is the area under the cover over 2 years and the vision gain. The aflibercept shows 17.1 as against other molecules. Now, area under curve is important to do certain activities which probably would not be possible otherwise. Now, protocol T influenced us in many which ways. Now, this was also the reason why the EURETINA guidelines and American Academy of Ophthalmology guidelines were changed, and aflibercept was said to be the drug of choice when the baseline best corrected visual acuity was less than 69 letters or 20/40. So if it is less than that, probably you consider aflibercept as a drug of choice. Aflibercept 2 mg has demonstrated RCT-like outcomes in our real-world clinical practice across indications, whether it is neovascular AMD, diabetic macular edema, retinal vein occlusions, or PCV. With proactive, it gives meaningful visual gains over many years with the individualized dosing. Now, this also says that we have a growing wealth of evidence with more than 20,000 patients across 20 countries treated with the real world, with the real world studies. Now, what is the influence the treat and extend regime has brought in on our patient experience? Now, this can be looked at with the Altair and ARIES study, which was a treat and extend study for the management of wet AMD. At week 96, up to 60% of the patients were maintained at interval of 12 weeks or beyond. What is important to understand is even if you extend by 2 weeks or to the 4-week group, the 60% of the patients were maintained beyond 12 weeks or beyond. Again, a very important clinical trial, prospective randomized study, which showed that we can probably by doing a treat and extend in the first year, we can provide a clinically meaningful visual outcomes over next 2 years in diabetic macular edema. This is a JADE study done in Taiwan, and we showed 8.3 vision gains at the end of 52 weeks or the end 1 year. 90% of the patients could achieve a more than 12-week interval. The next is VIBIM. This is a Korean study, again, to look at the treat and extend with aflibercept initiated in the first year and to provide a meaningful visual outcomes over next 2 years. It was a prospective multi-center single-arm study, and the vision achieved was 9.4, which is comparable to the initial studies, and 12.4 injections for next 2 years, and 60% of the patients had a last injection interval of more than 12 weeks. The third is Hirano, which was done in Japan, again a prospective multi-center single-arm study assessing the efficacy of a treat and extend regime with aflibercept in patients of diabetic macular edema over 2 years. A mean number of injections was 11.4, with a mean change in best corrected visual acuity from the baseline to year 2 was 6.1. And nearly about 70% of the patients could achieve more than 16 weeks interval. Very important, we less often again discuss on the retinal vein occlusion. This is one of those studies similar to a protocol T, where aflibercept is compared to a bevacizumab and a ranibizumab. It showed significant visual improvement with 15.1 letter gain as against the competitors, the bevacizumab and the ranibizumab, with fewer number of injections at 10 at the end of 2 years. So aflibercept in the clinical practice continues to evolve with the result or outcomes. Now, DME label change, it is available, it is ethical committee has approved in November 2022, and we can probably treat and extend in the year 1 for diabetic macular edema. So how could the recent label change affect my treatment journey for patients with diabetic macular edema? It gives a long-term meaningful visual gains. It can achieve RCT-like outcomes, flexibility with proactive individualized treatment intervals, reduction in treatment burden. We all know it is very safety, which has got a huge safety profile and for other reasons. So with this, I would move on to a couple of my cases. I will talk about first the diabetic macular edema, retinal vein occlusion, and the PCV. Here is a 62-year-old gentleman who came with a blurring of vision in both eyes for the past 1 month. He's diabetic for 12 years on insulin. He had undergone a laser and an intravitreal injection a couple of years back, and it was done elsewhere. HbA1c was 7.8. His visual acuity was 0.1, improving to 0.8. Left eye was 0.05, improving to 0.6. There was early cataract, which corresponding to his aging changes. Intraocular pressure was 16 and 14 millimeter of mercury. OCT showed increased central thickness in the right eye, whereas in the left eye showed spongy macula with a large intraretinal cyst with a central macular thickness at 639 microns. So with this, I would often do a OCTA in their first visit, just to give me a complete idea about their vasculature, the vascular supply, the foveal avascular zone. If after a couple of injections, if they are not improving, we definitely know that there would have been a widening of foveal avascular zone. That could be documented well from the beginning. Now, often in diabetics, we see a loss of a deep vascular plexus, which is very important for the visual gains. Now, this is not mandatory, but in my practice, I always include a OCTA. So the diagnosis was clinically significant diabetic macular edema with a moderate non-proliferative diabetic changes. A standard of care would be a bilateral intravitreal injection of anti-VEGF. I prefer to give aflibercept in this case. I would also counsel them to have a multiple monthly consecutive injections, and we would definitely discuss on the intravitreal complications, including the uveitis and the various other complications, which could be intraocular inflammation, vascular occlusions, but not in these medications with other medications. So the patient received the first dose of intravitreal injection of aflibercept in both eyes in March of 2021. And subsequently, you could see the next visit, the vision had improved in the right eye and the OCT showed a foveal contour was maintained. The left eye also had a definitive improvement with the cyst being smaller than the previous visit. The central macular thickness was reduced to 343 microns. So we stopped the injection in the right eye, but continued with the second eye. It was at 1 month interval. So he took it in April. The third injection again done in May of 2021. And in July 14th, after probably 5 weeks, there could be a small difference of 1 or 2 weeks because we see them and often try to get the approval from the insurances, which might take sometimes a week or 10 days. So he took a fourth injection after 5 weeks in July of 2021. And the sixth injection in January, there was a gap. And subsequently, he was probably lost for follow-up. He came back in March. By then, it was 8 weeks. And we could see a right eye maintaining a foveal contour. Left eye had still a small cyst with a central macular thickness as 377. We injected the sixth time, and the interval was Q8. It actually coincided with the practice of diabetic macular edema with aflibercept. And since the next follow-up in May 2022, he had the swelling in both the eyes. So he received the third dose of aflibercept in the right eye, which could be PRN. But we extended in the left eye the dose, the 8th dose in the left eye. Again, the right eye was stopped as a PRN. And you could see by extending, he was maintaining the foveal contour. We extended further to 12 weeks in the left eye. And subsequently, we extended to 16 weeks to maintain a good visual acuity, corrected visual acuity of 1 in the left eye, in fact, in both the eyes. The next case is about interesting case of 47-year-old Filipino was seen in 2020 April with sudden loss of vision in the right eye since 1 week. He was hypertensive and dyslipidemic for the past 6 years. His visual acuity was counting fingers, not improving further in the right eye. Counting fingers at 3 meters, improving to 1 with correction. Slit lamp was unremarkable. Intraocular pressure was normal. Retinal examination showed on the right side, you may not appreciate much with the opto's view. There was a small submacular hemorrhage covering the almost the macula. You can see autofluorescein. It's showing a block autofluorescein corresponding to submacular hemorrhage. On OCT, you could see multiple PEDs, a large peak PED with a submacular hemorrhage and a subretinal fluid, which obviously denotes it is a polypoidal lesion, which was confirmed on an ICGA. By doing an ICGA, we could see a hot spots and the block fluorescein corresponding to the hemorrhage, which was again confirmed with the IVFAs, which showed late leakage corresponding to the polypoidal lesions. A diagnosis of a PCV, since ICD-10 do not show a PCV, we always have to say it as an exudative AMD to get the approvals. And the other eye was showing a drusen. So in this case, we decided to inject intravitreal injection of anti-VEGF. Now, most likely in the audience, people might wonder why would I chose not to inject a gas or a TPA. Since it was smaller in diameter, I thought of injecting anti-VEGF as a monotherapy. And there was no availability of PDT by then. So we just went ahead and injected aflibercept. We also counseled him for a multiple monthly consecutive injections. And the first injection was done in April of 2020. And you could see a reduction in the RPEDs height, as well as a disappearance of the submacular fluid in the first injection itself. Following the 4 weeks, we injected the second time in May 2020, and the third injection in June 2020. The vision kept improving from counting fingers to 0.1 to 0.2. And in the subsequent visit, the vision had improved to 0.7. So we went ahead and injected the fourth injection at Q4 interval in July of 2020. The fifth injection, probably he came a little late. It was an interval of 5 weeks. It was in August 2020. The vision had improved significantly to 1 parts. So what is important to understand in all these is why I kept injecting, though it was a significant improvement, is I could still see some vascular pattern on an OCTA in a vascular region. One more important thing I had noticed in this patient is he had a similar vascular network in a vascular zone in the left eye too. Now, all of us know that if there is no symptom, no subretinal fluid, no subretinal hemorrhage, there is no need to inject. So we kept observing in the left eye. He had this pattern all throughout. His vision was maintained always at 1. Coming back to the right eye, he received intravitreal injection of aflibercept at 1 more injection at a Q5 interval in September of 2020. And then subsequently, this again shows a neovascular pattern in a avascular zone in both the eyes. The right eye was significantly shrunk. So we decided to do a treat and extend. He received after probably 10 to 12 weeks, the 7th injection in the right eye. And then we went ahead and we followed up and we extended it to 16 weeks and he's doing absolutely fine. Last of my case is a 57-year-old gentleman, came with complaints of blurring of vision in the left eye for past 3 months. There was no history of diabetes or hypertension or a history of trauma. His vision was complete in the right eye with correction, whereas in the left eye was 0.15 improving to 0.6. Early lenticular changes on the slit lamp, pressures were normal. Retinal examination of the right eye was essentially normal. Left eye showed a dilated tortuous blood vessels, hyperemic disc, retinal hemorrhages in all the quadrants, and a cystoid macular edema, which suggests that he has got, you can see a OCTA, which showed a large cystoid changes. a diagnosis of central retinal vein in the left eye. And we decided to inject anti-VEGF, aflibercept, 2 milligrams in 0.05 ml. The first injection was done in February of 2021. And subsequently, he came back. You could see a foveal contour was maintained. His CMT had reduced significantly to 315 microns. Now, in this case, I have my own way of managing CRVOs. It is not just the OCT which guides me for the further injections. I look at clinically, I look at the retinal pattern. So what guides me is the retinal hemorrhages, the caliber of the retinal veins, whether it has come back to normal or it still looks dilated, tortuous, and the macular hemorrhages and the macular volume. In this case, the macular volume was still more, and there are a lot of retinal hemorrhages and macular hemorrhages and a dilated tortuous vessel. So I did not stop after one injection, though the foveal contour had come down to normal. So I decided to inject the second and the third dose of aflibercept in consecutive months. After that, he was followed up again the following month, wherein the foveal contour was maintained and there was less hemorrhages and the macular volume also was less. So we deferred intravitreal injection in this visit, and he came back with a recurrence of swelling. His vision had dropped to 0.7. So it was, fortunately, it was around 4 months or a Q16. So we injected him in September 2021. Again, he was followed up every couple of months or once in 3 months. And at Q18, again, he had a drop of vision. Vision was 0.4, improving to 1 pass. We gave him an injection at Q18 interval. And then again, no injections offered for a couple of visits. And the last injection was given in June of 2022. I think the patient did extremely good with no further injections, and he's still being followed up. So with all these things, with all these results with aflibercept 2 milligrams, do we still have an unmet needs? The answer is yes. We still get probably some percentage of patients coming with suboptimal or the refractory diabetic macular edema or suboptimal responses. And with a high treatment burden, there is still unmet need which remains. So, and the journey with the anti-VEGF continues, and we have a new molecule. Probably it should be available with us the next year. And the first year results of aflibercept 8 milligram is available, and we're looking forward for the second year results of PULSAR and PHOTON. The PULSAR is a aflibercept 8 milligram in treatment naive neovascular AMD, whereas the PULSAR is aflibercept 8 milligram with the diabetic macular edema. So in conclusion, so aflibercept 2 milligrams is a standard of care. It helps in meaningful visual gains, durability, and a huge safety profile across indications. It not just works against VEGF, it also acts against it acts as an anti-inflammatory, and with the label change in diabetic macular edema included, a flexible treatment regime with aflibercept in the year 1 can be achieved. Now it is approved in UAE. Thank you for the patient hearing, and it's time for any questions. Dr. Amri?
I have a question. How are you doing? It's this is an amazing presentation, Dr. Rao.
Oh, thank you so much.
So let me just start my video.
Please.
Yes. No, this is lovely. I have a question. So how do you extend? Let's talk about, for example, diabetic macular edema. How do you extend your treatment? What do you do in your practice? Do you do like 3 consecutive 4 weeks and then see if they're improving, you start extending. What do you do for diabetic macular edema?
So based on the registration trial, we know that aflibercept either can be given 5 times or in protocol T 6 times. So most often, if they are improving, there is a both over with the visual acuity and on the OCT. I keep injecting possibly the 5 injections and then treat and extend. With the new label change, probably I can move on to either 12 weeks or 16 weeks in the first year itself. So far, otherwise, to make it Q8 the first year and possibly Q12, Q18 in the second year, based on how the response is.
Okay, excellent. And do you base, the problem is with the thickness, sometimes it's hard to be sure that the thickness is accurate, because especially when they have like a lot of macular edema early, the machine, the way the machine measures it is not really very accurate. Do you base your judgment on the OCT on, how the thickness is, or like what you can just eyeball about cyst and fluid, or what's your main point on the OCT? Is it the thickness or what you can eyeball?
So in my clinical practice, I take a comprehensive eye examination as a criteria to re-inject any patients, be it wet AMD or a diabetic macular edema. You can err probably on a safer side. Even if you postpone, especially with the diabetic macular edema, you're not going to lose much as against the wet AMD. So I would take a comprehensive examination in terms of visual acuity, slit lamp biomicroscopic examination, and then take them up for the OCT. Even if there is, issues in reading the thickness of macula, you can repeat. If it is a different machine, obviously there could be inter-machine issues. But if it is the same machine, we can always repeat the, the scans.
Thank you so much, Dr. Rao. This was an amazing presentation. Thank you.
Thank you so much, Doctor.
Lovely seeing you as always.
As usual. Thank you. Same here. Thank you.
All right. Thank you. Thank you so much. So Ahmed, I wonder if you're there. I think we'll go ahead and start the uveitis session then. So we're starting in time. Let me have here.
Hi.
All right, we have here, let me just introduce the session. We got it. Okay, excellent. Okay, well, welcome everyone, and it's a great honor to be here. My name is Ahmed Salam from the University of Arkansas, and I would like to thank Al-Qasimi meeting and Dr. Al-Amri for the kind invitation. We have the first uveitis session here, and we have a great panel of world leaders in uveitis. So I'll introduce the panel. So our panel, our first speaker is Dr. Hassan Al-Dibi. He's a senior academic consultant and the chief uveitis consultant at Pekash Eye Specialist Hospital in Riyadh. And then we have other speakers who are with us here. We have Dr. Shri Kurup, and he's a vitreoretinal and uveitis specialist and the head of the retina and uveitis in Cleveland Hospital in Ohio. And then we also have Dr. Rola Hammam from Lebanon, and we have Dr. Lamri Hasna from Morocco, and sorry, I apologize, and Dr. Armando Oliver from a uveitis specialist, and he's the head of the department in Puerto Rico, and Dr. Samir Chowki, uveitis specialist from Egypt. I hope I didn't miss anyone. And is Dr. Yes. And I can see Dr. Al-Amri here. Dr. Al-Amri, do you want to say something before we start? Thank you for the kind invitation.
Thank you very much, Dr. Ahmed. Just I'd like to say hello to everyone and thanks everyone for giving us the chance for learning from their experience and thanks a lot. The mic with you, please.
All right, excellent. So our first speaker, Dr. Hassan Al-Dibi. So we'll have the case, and then after that, we can have a few minutes of discussion, and we keep moving on. I think the important points are always comes up in the discussion. Dr. Hassan, great to see you, and thank you so much for being here.
Me too. Good afternoon. Thank you, Dr. Ahmed Salam and Dr. Al-Amri for your kind invitation and give me the chance to participate with you in this webinar tonight. So I'm gonna to give you a case that need to have some attentions and integrations between different subspecialties, including uveitis, medical retina, and surgical, and rheumatologists. So let us to go without any ado. So my patient is 17-year-old, medically free. His referral cause was vitreous hemorrhage, occlusive vasculitis left eye, with complaint of decrease of vision left eye for 1 month. He is known to have asthma symptoms on and off, not on any treatment. He had a history of positive tinnitus, hearing loss 1 month, otherwise negative systemic review. His vision, ocular examination showed that vision in the right eye is perfect 20 and left eye 2400. The pressure was within normal, and his color vision as well in the right eye is normal and reliable in left eye. Examinations of the anterior segment was within normal in both eyes with occasional cells in the left eye. And his posterior segment examinations of the left eye showed that mixed vitreous hemorrhage, extensive neovascularizations, fibrovascular membrane at the disc and extended to the inferior temporal with sheathing, as you see in these pictures. The picture looks like a bit ugly with the vasculitis, as you see in the inferior temporal area extending from the disc. And striking feature is in this picture. If you can focus in the mid of the macula, there is an area. It looks like and retinitis rather than to be an cotinal spot. So this patient at this times, and this is the fluorescein angiography of that patient. You see that area of the fibrovascular proliferations with the vitreous hemorrhage offer and non-perfusion of the inferior temporal area. Again, you see just only mid-face, and you see how much that an aggressive fibrovascular membrane proliferation with the non-perfusion inferior temporal. And you see a little bit of staining and the area between the perfused and non-perfused retina with little bit staining and leakage. This is an obvious late phase, and there is an all of that diffuse leakage from the background of choroid. Other eyes completely normal. This is the OCT of the left eye, and as you see, there is elevation of the retina with subretinal fluid. So the patient at this time starting to be investigated through labs where BBD negative, CT scan of the chest were normal, MRI brain were negative, angiotensin converting enzyme, HLB 51 and 27, syphilis, ANA were negative. So at that point, the patient underwent BRB left eye, but was limited by vitreous hemorrhage. In the same times, other investigation which is taking time were performed and showed that anticordiolipin negative and B2GB1 is negative as well. Factor V leading polymerase mutation is done as well in this patient and absent for mutations. Protein C function was within normal, and B ANCA to C ANCA were negative. The patient referred to rheumatologist to rule out connective tissue disorders, and the feedback was no signs visible from the present from the connective tissue disorders. And this is his pictures just only after 2 months of that, and you see that the progression of the disease with more vitreous hemorrhage and proliferations at this stage, as you see here. So this is 17-year-old with the poor vision now in the left eye. This is the his FA, and show that limited, bad retinal photocoagulation, inferior temporal, and more proliferation of the fibrovascular membranes. Again, so on 1st of March, this patient vision deteriorated as well with diagnosis of occlusive vasculopathy, most likely related to TB based only on quantiferon test. So the patient started in 1 agent of anti-TB at that point. Later on in May 11, 2023, the patient situations were get more progress, and there is traction retinal detachment at the macular area, as you see in his OCT, as well the finding of the V scan. So what was the putting of the different, so it was case of TRD, vitreous hemorrhage, macula on with no clear diagnosis yet, vision stable, vitreous hemorrhage present since 4 months. So the patient underwent urgent BRB by the medical team, no need for surgical intervention as feedback from the vitreoretinal surgeons. Later on, if you see his picture is getting more ugly with more perforations and vitreous hemorrhage, and mostly the macula is now almost destroyed in this patient. So surgical retina was consulted again, but no intervention was advised, and because according to their justification is that the reason is not known. Well, the case seems for us as uveitis people, this is mostly a case of idiopathic vasculitis with ischemia, proliferations, and mostly with positive quantiferon could be labeled as an Eales disease. So at that time being consulted at this point where I say this patient need an urgent PBV with pre-op intravitreal Avastin, 5 days pre-op, and to start steroid in 40 milligram with other medications. So this is the picture pre-op. After that intravitreal Avastin injections, and patient underwent barzaplan vitrectomy, and the picture as you see here, mostly the area that involves showing subretinal oxidates with remnant of retinal fold, and BRB were applied to all area of that. The vision of the patient improved to 2300 in the first post-op, and this is the OCT starting to see that settle down of the subretinal fluid with just folds of the retina because of long tractions. And this is just only 3 weeks post-op. The vision improved to 2100 with residual, suboxidates and some retinal, folds. So in conclusion, this is a case of vasculitis of unknown origins, only with one signs of quantiferon in the labs, were a little bit, delayed in the management because, there is different feedbacks from different groups. So when there is, vitreoretinal having, specialty in uveitis, mostly is having the ability to judge such cases, because leaving this patient without any early intervention might lead to very, poor prognosis. So that's what I would like to say about what the case that I presented, and open for any questions. Thank you.
Thank you so much, Hassan. This is a great case, and I think it underscores why uveitis and surgical retina should be combined. I think it's because yes, I think I totally agree with you. I think earlier intervention may have been better. So any questions from the panel? Dr. Shri, you have something here to say?
I was thinking, have you thought of Cogan's syndrome in this case?
Well, it will be difficult to think in that manner, because the patient's situation is progressing
rapidly,
as rapidly, and to put the diagnosis of Eales disease with all finding ICU negative, so we'll go in that directions. I've been consulted in the last minutes, so I say no, we cannot wait. We have to go in and continue. The most important that, as quantiferon is sensitivity is high, but it's not to the level that you can say. The patient doesn't have contact with TB. It doesn't have, somebody in his, as a care provider, so that we can see there is an exposure. So quantiferon, but, we're trying to cover him with one agent and with steroid and surgery. Now the situation is getting acceptable. This case is, I was thinking about in different situation, as there is a spot of retinitis, thinking about possibility of Bahjat disease. It could be as presented as
yes, of course, of course. But I think you did the right thing. Obviously, this patient still can get more treatment with steroids and anti-VEGF. That would be a great combination. And it's amazing that you had to push the surgeons to do this, because probably any one of us would have been in that eye way like you would want us to be in as soon as possible. That's amazing, amazing recovery, though.
And
Fantastic.
I think so. What's happened is that, vitreoretinal surgeon usually are not dealing with these cases as usual.
Yeah.
So they get when they see the mass, it might be going in the opposite direction. So, how much the people looking to have more, better prognosis. So this
Right.
is why, so experience with some knowledge about UFATs might help in these cases.
Very good.
May I ask a question, Hassan?
Yes, please.
Great case. Alhamdulillah. So you decided to treat this as with the quantiferon positive, and you're thinking that TB has something to do with this. You decided to treat it as latent TB and not give a full treatment because you're thinking that mostly this is inflammatory, or?
Well, it's question mark to be, we label it as idiopathic, first of all, vasculitis as based on all the investigation. The only one that coming is positive is the quantiferon. But looking for other, possibility of sign that could help, like, positive PBD, CT scan of the chest, an obvious inflammation in the eye, because the vitreous wasn't that badly involved in this case, apart from this vasculitis, as you see. So for that reason, till now, there is no an obvious, document that 100% this is going with tuberculosis. That could be, as we say, that, hypersensitivity to, tuberculin proteins. It could be one of the possibilities. And the treatment here mostly steroid rather than to be the others,
Hassan, here we would have pushed for a full TB treatment. So we see
yes,
these types of patients sometimes, and we label them TB delayed hypersensitivity uveitis, which I think is just the name, again, another name for Eales disease. And
and my opinion was, as you say, I would like, but it was just only a few days ago, because I just got consulted in the last minute, and the patient already started in one medication. So I started him in steroid to prepare him for surgery, which is important, but anti-TB definitely it is part.
Yeah, and sometimes you get pushback from the TB people. They don't want to give them full treatment because, like, the only evidence you have is just based on the gamma interferon assay. So
myself usually I go with full medications, I just only accepting that giving ethambutol. I give 3 agents apart from the ethambutol.
Excellent. So our next speaker is and our friend is Dr. Rola Hammam, Associate Professor of Ophthalmology, American University of Beirut, Lebanon. Rola, before you start your talk, can I ask you to summarize or to maybe give us like 4 or 5 causes for in your mind, the most important of occlusive vasculitis or occlusive retinal vasculitis? So I think from those we had TB-delayed hypersensitivity. Dr. Kurup said Behçet. Anything else you can think of, again, for those who are following us?
I can think of lupus.
Yes.
And sarcoid. We always think of sarcoid. And an entity I'm going to discuss next.
And maybe maybe antiphospholipid syndromes.
Yes, of course.
Okay, yes. So that's okay. Rola, please go ahead.
So this is a case of a 43-year-old male who presented with blurring of vision, bilateral, 1 week duration. It was associated with redness, photophobia, and pain. 10 months prior to this presentation, the patient was diagnosed with HIV and EBV related large B-cell lymphoma. The patient was on treatment for his HIV and received chemotherapy for his lymphoma. The last follow-up was 4 months prior to his presentation to us. And at the time, 4 months earlier, the CD level was high and the viral load was undetectable. The current CD level was unknown, and his last chemotherapy cycle was 4 months prior to his presentation. The patient also had was hepatitis positive, and also on his investigation 4 months earlier, the viral load was undetectable. On exam, the patient had decrease in vision, 20/80 on the right side, 20/200 on the left. Pressures were within normal. The eyes were injected. They had inflammation in the anterior chamber. 3+ cells on the right and 4+ cells on the left with some posterior synechiae. And in the fundus, you can see that there is vitreous haze, and there is this large area of retinitis, looks like granular retinitis with vasculitis as well. This is the right eye. The left eye had worse haze, but you could see also an area of retinitis that you could see temporal that is more hazy here, but most likely similar to the other eye. The FA showed vasculitis in both eyes and a disc hyperfluorescence in addition to the retinal involvement. The OCT, the deep retina was spared. It's clear on the right side because of less haze, so it's a better image. But it seemed that the outer segments of the retina were fine. We knew from the screening history that the patient was PPD negative, VDRL negative. The serology for CMV and toxoplasma were positive for IgG. So given this, the patient was started on valganciclovir oral treatment with Bactrim, and also given intravitreal ganciclovir injections with the impression that this is very likely CMV retinitis. A week later, the patient's picture, we felt that the retinitis might have been a bit better, but the haze was getting worse. Still, the deeper retina was still acceptable on OCT, still was okay, and steroids were added to the regimen, and we had requested with the medical team caring for him a current CD4 level, PCR level of CMV in the serum, another VDRL TPHA, and all those are pending. They were now not out yet. A few days later, there was further deterioration, 2400 vision now, and the clinical picture changed. You can see these distinct lesions in the retina, this obliterative vasculitis. There's worsening of the condition and a change in the clinical picture from the presentation. You could also see that the areas that presented with retinitis, and now you just can't see it there anymore. The deeper retina now is involved. There's macular edema. There's disruption of the deeper retinal layer, and the fluorescein angiography now shows a typical leopard spot pattern on the FA. By now, and this is 2 weeks later, the results came back, and VDRL is positive, confirmed with a TPHA, and with the diagnosis of new diagnosis of syphilis. The patient underwent LP, looking for involvement, evidence in the CSF, and VDRL was negative in the CSF. The patient received treatment. Penicillin was not available, so he received ceftriaxone, intravenous infusions for 15 days, and after treatment improved significantly the vision to 20/40, and the clinical picture, the fundus looks much better. So does the OCT. I have a little bit of a revision of the topic. I don't know if we go ahead with that or we go for discussion. Or what do you think?
Well, do you want to show maybe if you have like 1 or 2 slides that you really feel like these are the main ones, and then we can have lots of discussion because it's a fascinating case.
Right. So syphilis was first described by an Italian poet back in 1530 in a poem where he spoke about a shepherd with the name syphilis and had that disease. And the poem talks about how he angered the goddess and she inflicted him with this disease. And the disease gets the name from this shepherd. It was about 1500 later that it was the organism, the spirochete Treponema pallidum, was isolated in 1905. In 1910, Wassermann was able to by complement fixation, test the blood or identify the blood that is positive for the antibodies for treponema. And it was about 30 or 40 years later that penicillin was discovered, and we had the treatment, and still the main treatment for this disease. Usually the ocular involvement is in the secondary, tertiary stages. However, it can affect the eye at any level, at any stage. And it's a great imitator, and that's the important point here. It's the great mimicker. It has multiple clinical patterns of presentation. It can affect all the retinal layers. It can affect also, can present with anterior uveitis, but most commonly it presents with posterior uveitis. And it can be any type of posterior uveitis, retinochoroiditis, multifocal choroiditis, multifocal retinitis, retinal necrosis, macular placoid lesions, which are typical. Also, it will be associated with vitritis, papillitis, vasculitis, phlebitis, occlusive vasculitis, and CME, like what we saw in this case. There are the non-specific tests, which are non-treponemal tests, including the VDRL, which is the most common. This is the screening test. We have to keep in mind that it is negative in 30% of latent or tertiary syphilis. And in this case, we had a negative VDRL when it presented to us. Then the repeat testing was different, and also the clinical picture, we were thinking that this is CMV, but then later turned out to be syphilis, this great imitator with a negative originally VDRL. The more specific assays would be the FTA antibodies, and these, when they're positive for life. And this is the confirmatory test, and some people, including me, and I think most of the UVI specialists, when we test for syphilis, and we do that on almost all our patients, we do VDRL and TPHA or FTA antibodies, so that we make sure that the patient, this is on the differential or not. The treatment, as we said, is penicillin. Ceftriaxone is another treatment if penicillin is not available, and if there's allergy, then doxycycline may be given. Systemic steroids for the prevention of the entity called Jarisch-Herxheimer reaction. It's advocated to be started 3 days prior and a day to be given for 3 days, and to be started before the treatment for syphilis. There is a meta-analysis that discussed the factors associated with the poor visual prognosis in these patients. The longer the time between the onset of uveitis and treatment is a bad prognostic sign. The prolonged ocular symptoms, also macular edema, long-standing optic neuropathy, co-infection with HIV, also is a poor visual prognosis and poor initial visual acuity. Higher success rate of treatment and preservation of vision would be vasculitis, anterior uveitis, and neurosyphilis. Again, the main learning points is that the testing for syphilis, you need both. VDRL is not enough. And look again if the response is not expected, as we all do with these cases of uveitis. Thank you.
Rola, thank you so much. This is a fantastic case. Can I just open the discussion? So we have here a patient who has HIV, Hep B, and lymphoma. And so was there a risk? So how did things happen, Rola? Did he was at high risk for HIV from sexual practice? And then after that, lymphoma happened, or he had lymphoma and he just got HIV and Hep B for bloods, or?
Yeah, he presented with lymphoma. It's EBV associated large B-cell lymphoma. So he had probably HIV undiagnosed, and then end up with lymphoma. And he presented with the symptoms of lymphoma, and he was discovered to have HIV at the same time.
And was there a history of men having sex with men?
Yes.
Yeah, right. So this is an important point, because then it makes you think of the possibility of syphilis later on when things are not adding on. So although that might be a critical part of the history, but Dr. Rola pointing out here, it's important to know these things, and sometimes it's difficult in the Arab world to know these things, of course. So again, maybe a question to Dr. Kurb here on Dr. Rola's fascinating case. So a patient was in this situation, presenting with retinitis. So what's your differential diagnosis in this
So if
situation.
think of the lymphoma coming back, but the pattern doesn't support, then you see these granulomas. They have to be sarcoidosis or syphilis, is one or the other, typically.
Right.
That's
So sarcoidosis
or
would be something
syphilis.
like another diagnosis.
Yeah,
Syphilis
yeah.
maybe in relation to the MSM, and then
Yeah.
of course
Yeah,
viral.
the shifting patterns and where there's no destruction, because syphilis, those organisms infiltrate, they don't destruct. And the testing, I think the testing, what we do now is different. We go to the immunological tests and go backwards. And
So reverse sequence.
Correct, reverse sequence. That has been a little bit more, I mean, you hit the nail on the head. You got the diagnosis, you suspected it. It's saved his life, basically, not just his eyes, right?
And Dr. Hassan, so in this context, I would put also toxoplasma in the differential diagnosis, because we know toxoplasma in immunosuppressed patients can present like viral, and actually it may present also like the bit like syphilis, where the lesions heal, where viral retinitis usually do not heal without treatment. Dr. Hassan, would you put toxoplasma in this context in the differential as well?
Yeah, I put it because a typical case in a double shot immunocompromised patient, in chemotherapy for lymphoma, as well is known to have HIV. So this is make the atypicality of the. But even though Dr. Hammam, she did VDRL in the first shot,
yes.
But even though VDR maybe at the transitional stage, not reflecting the disease itself, but patients with these situations, syphilis, especially nowadays, we have surge of these cases over. I thinking that when I saw it, that's about possibility of posterior syphilitic blacoid lesion, not that typical of posterior ball involvement, just only in the embryo. So if that chance to have wide field OCT, it might be shown, especially inner retina is not that obviously involved in the early stage. So syphilis is there, even though cannot be ruled by labs, but I will put it in my mind.
Excellent.
One point in this angiogram is that there's so much inflammation that it's unlikely that this patient is not immunocompetent. Because if you're immunocompetent, you wouldn't expect so much inflammation and the optic nerves bilaterally to light up for, say, toxoplasmosis or something like that. It would not add up in my experience. I think Armando, you had some experience with this, right?
Yes, definitely. But I agree with everything that's absolutely been said. But it's also always important to remember that pretty much every case of uveitis should be screened for syphilis. That's pretty much it. It can always be syphilis.
Now, JP Dunn published a very ugly looking syphilis, I think 2 years ago, as a case diagnosis, and it was hemorrhagic, just like your case here. But those granulomas are typical for infectious disease, and it's very difficult, right? What does Rift Valley look like in an immunocompromised? Could you tell us a little bit about those conditions?
I think we have to move for the sake of time.
Okay.
So I think that's a good point. We probably will need to touch on that Rift Valley and Rift Valley on the right.
Yeah,
so our next speaker is Dr. Sri Kurib. And Dr. Sri is a great friend, and he's the retina uveitis head in Cleveland Hospitals, Cleveland University Hospitals in Ohio.
Are you able to see?
Not yet. Yes, we can see your second slide. Yes.
Okay, let me get this first. How about now?
Yes, fantastic. If you can just make it bigger.
All right, it's slides. Let's start the slide.
Press the little presentation button there, then.
You got it?
Yes.
There you go.
Good.
Yes, excellent. Thank you so much.
So thank you for allowing me to be here with friends and your family, right? Literally. So I saw this patient because I was walking in the corridor, and a cardiothoracic surgeon told me, a very well-known guy, I have this patient who's having these visual symptoms. Can you take a look at this? And I said, okay, let's do that. So she's a 45-year-old female artist, and she does landscape. So she's very cognizant of the periphery, peripheral vision, etc. And she has been getting treatment for chronic endocarditis, bacterial, on IV antibiotics at home for 3 months. 3 months. And she has cycled through 7 cardiologists in various hospitals in Cleveland. So the last one referred this patient to the cardiothoracic surgeon because he is probably one of the best surgeons there to do a valvectomy. Now we're talking about the aortic valve valvectomy. So it's a big deal, right? In a patient of this age, because you need a synthetic valve. So this is a corridor consult. I saw this patient. I don't know how much you can see here, but infratemporal in the right eye, there's a little retinal hemorrhage. And I'm going to make it a little left eye is not so much. Do you see that now? Infratemporal in the macula. It's a retinal arterial hemorrhage. So I saw this. And the left eye, the vessels in the periphery, a little tortuous. So this was during COVID, like was ending in this, so to speak. And I asked her, how did you come here? Because she looked very fine, you know. A chronic endocarditis patient is typically quite sick. So she said, I walked up. I said, you walked up 3 flights of stairs? She said, yes. So I told her, you don't have bacterial endocarditis. I don't know what this is, but this is not endocarditis. So it's kind of interesting, you know, you have an eye doctor telling the patient this, and she said, all right. So we did an angiogram. So the angiogram shows, if you look in the temporal periphery, infratemporal, there's vascular leakage, both venous and arterial. There's arterial occlusions. This is the left eye. Left eye, she's got some vascular events in the temporal periphery. So you have essentially a young lady with peripheral occlusions, arterial and venous. She jogs, she takes antibiotics and she jogs. She had a DVT-like episode 2 times, suspected. So I said, okay, let's start investigations. And we had a diagnosis. We recommended. So I saw Alan. And I said, Alan, you know, get the valve out. So very, very interesting, right? This patient was seen by, this is the valve, aortic valve. So this is how it went. Patient goes to cardiology. Patient goes to cardiologist 7 times. Patient goes to cardiothoracic surgeon, sees a uveitis guy in the corridor. The uveitis guy talks to the cardiothoracic surgeon. The valve is out. It's amazing how much trust he had in me. So I was glad I was right. So we published this in JAMA, and it was nice to get a publication in JAMA and talk about, this is the doctor who did it, Markovitz. The person who wrote this paper is actually the pathologist, Miroslav. He wanted to send this to JAMA. I told him, you know, I don't know, but apparently JAMA likes these type of entities that affect the heart and the eyes and can kill the patient. So just a pour. So this is APLS. We all know this, what's going on here. And it is present in a lot of patients with miscarriages, and we probably are missing it. So if you see young patients with DVTs or strange vascular symptoms, always think about APLS. Thank you.
Thank you so much, Sri. That's a fantastic case. So I think we were talking about occlusive vasculitis and vascular occlusions. And we talked about several things: TB, delayed hypersensitivity, Behçet, lupus, SUSAC. And again, Dr. Rolla as well told us about the syphilitic uveitis and viral retinitis. And here as well, don't forget antiphospholipid syndromes as well. This is a fantastic case. So Dr. Samir, any comment on Dr. Kurup's case here?
Thank you, Ahmed, for the invitation. Really, it is very nice and interesting case. I think it's very rare, but we have to put this in the differential diagnosis of vasculitis. So as you mentioned, when I see a case of retinal vasculitis, here, at least in our region, I think of TP, sarcoidosis, Behçet's disease. So if all this come out to be negative, I have to think of the of rare cases like this. But it's a very nice case, actually.
Fantastic. Okay, Rola, any comment? Quick comment on Dr. Kurup's case?
It's a great case. I think the take-home message is we are ophthalmologists, uveitis specialists, but we're physicians, and asking the patient, how did you come here? You walked up. Okay, so probably this is not endocarditis. That's very good, and it's a lesson for us, all of us, to learn that we could save a patient's heart with these simple questions. A patient's life.
Excellent.
So I have to thank AUB for a lot of my present publications, because I worked with Manzoor.
Yeah.
Yes.
It's a great university with Rola and Dr. Mansour there. It's just it's a fantastic university, really.
Yeah.
So I think maybe the message as well: spend more time in the corridor, because then you can diagnose cases and get jam-up application. So with that being said, we'll move to our next speaker, Dr. Armando Oliver. Armando is the head of the department at Puerto Rico, and he's a uveitis and surgical retina specialist. So Armando, thank you so much for being here.
Thank you so much, Ahmed, and thank you, Dr. Mohamed Al-Amri, for the invitation. Good morning to my friends in America, and good afternoon to my friends in the Middle East. This case, we're going to call it shotless vasculitis. These are my financial disclosures, which are not pertinent. This is a 27-year-old Hispanic female who complained of photopsias and floaters of 1-year evolution. She had a past medical history of Hashimoto's thyroid disease. Past social and family history was pertinent for a history of cancer in the maternal grandmother, and the reveal system, she had some history of hypoglycemia. Her best corrected visual acuity was 20/40 in the right eye and 20/30 in the left, and the anterior segment examination was pretty much unremarkable. The fundus exam, she had some mild vitreous debris and 2+ vitritis, and we could also notice some perivenular sheathing in both eyes, which was more evident when we did this fluorescein angiogram. And the fluorescein angiogram revealed this branching pattern of vasculitis, as well as some macular leakage consistent with her CME. We did an ICG, and the ICG did not reveal any hypocyanescence, but suggestive of choroidal lesions. We only had some blockage from the vitreous debris. And of course, the OCT showed cystoid macular edema in both eyes. We did a workup. We did, in terms of radiology, we did a whole body gallium scan, and it showed that the inflammation was localized to both orbits. However, a bone scan did reveal some arthritic changes, non-specific to the interphalangeal joints of the first finger, left hand, and some in the right ankle. As far as blood work, we did a test for syphilis. Both FT-ABS and RPI were negative, and the quantiferon TB Gold Plus test was also negative. However, she was HLA A29 positive. So how do we call this? We call this HLA A29 associated retinal vasculitis without choroidal lesions. As far as treatment, we started her on prednisone 60 milligrams per day and CellCept mycophenolate mofetil 1.5 grams twice daily. That only allowed us to achieve partial improvement. So while on prednisone 60 and CellCept, we added adalimumab, and then we were able to taper her steroids a little bit. However, when we reached the 20 milligram dose, she developed bilateral CME. We treated her with intravitreal dexamethasone implants, but she was a steroid responder. So at that point, we switched her to Actar, which is a repository corticotropin injection, which resulted in resolution of her macular edema, and we were able to discontinue the systemic steroids and the adalimumab while keeping her on CellCept. At 2 years follow-up, her visual acuity was 20/20, slit lamp exam was normal. However, she did have some low-grade recalcitrant inflammation in both eyes, which we're still dealing with and consider other immunological agents. As you all know, Birdshot retinochoroidopathy was described in 1978 by Ryan and Momini. It's characterized by multifocal choroidal lesions, cream color white dots scattered through the fundus. It can have retinal vasculitis. It usually, patients go blind either by centripetal visual field loss or macular edema, and usually requires quite aggressive immunosuppressive therapy. And the HLA-29 class 1 antigen conveys a very high relative risk for this disease. HLA-29-associated retinal vasculitis without choroidal lesions is an entity that we believe shares many of the clinical features of Birdshot, as vitritis, macular edema, optic disc swelling, visual field constriction, and it also usually requires aggressive systemic immunosuppressive therapy. We reviewed 4 cases between our clinic and Minnesota, and we found that the average median age of presentation was 40 years in a range of 14 to 71. Most patients were female at presentation. All 4 patients had a visual acuity of 20/50 or better. All the eyes had mild vitritis, 3 eyes had cystoid macular edema, 2 eyes had optic disc swellings, and all patients required treatment with systemic steroids and aggressive immunosuppressive therapy. To give you an example, figure A is our patient, and figure B is a patient with Birdshot. This is the angiogram of both patients. And based on the angiography alone, it is really hard to tell which one has HLA-A29-associated retinal vasculitis without choroidal lesions and which one has Birdshot, typical Birdshot with the choroidal lesions. So to conclude, HLA-A29-associated retinal vasculitis without choroidal lesions appears to share many of the clinical features of Birdshot chororetinitis, including the need for aggressive immunosuppressive therapy. Whether this entity represents an early form of Birdshot or a more localized variant of the disease is a topic for further studies and my very intelligent friends who can probably figure this out better than I can. Timely identification of HLA-A29 genotyping in patients with retinal vasculitis may allow you to make this diagnosis and prevent peripheral further visual loss, either from the chronic cystoid macular edema or visual field constriction. Thank you so much.
Thank you.
Armando, this is a great case. Armando, can I show you? Can you go to the ICG picture?
Yes.
The second one, I think there are small choroidal lesions there.
You think so? Let's see.
But again, I'm not sure really. Here,
are those? Those are
floaters.
Yeah, the ones in the macula. Yes.
Yeah, in the right eye, I think that's blockage from
floaters.
The floater.
Floaters.
Are they, okay, so when you looked at the color picture,
if you look at the late ones, they're not there, and it's moved. So,
and it's blocking the vessel, right?
I wonder on the left in the macula if there are some as well. It just sometimes if you have Heidelberg, sometimes you actually get better with the ICG, but even if they are present, it's like very minimal, not what you expect to see.
Mm-hmm.
Yeah. I have a case like this. If you haven't published your series yet.
Yeah, I
was submitted last week. It would have been great to include you, but yes.
Hopefully, it doesn't get declined. If it gets declined, let us know.
We'll add you. Thank you.
Yeah. So I have a case, Armando, where I saw a patient who has come in with what looked like a granuloma in the macula, and had one nasal birdshot lesion, one lesion in the other eye. So the patient was sent as a macroaneurysm, to give you an idea to me.
Mm-hmm.
So I asked the guy's history. His father has birdshot. His father is getting treated for birdshot. So there are some people, when you think of all the immune conditions we have in the body, how can it be that everybody with A29 will only present with lesions in the choroid and lesions? It's just impossible, right? And how can you say everybody's going to need treatment? There'll be many people who have very mild disease too. Like Susan Lightman talked about that, I think.
Yes.
I believe it's probably a spectrum. And if you look at PubMed, you'll find that half people call it retinochoroiditis, the other half will call it chororetinitis. And they're probably both right. In some people, it may be a chororetinitis. Right. In other people, it may be a retinochoroiditis. And some people, it may just stay predominantly as a vasculitis. So probably we have a Birdshot spectrum, and we don't know it because many people just don't check for HLA-A29 on patients with retinal vasculitis. That's probably,
Yes.
What about the rest of the panel? Do they have any cases like this? Because we can put it together.
Yeah, I was going to ask Hassan, Dr. Hassan, if you're here.
Yeah, I'm hearing you. Yeah, it's really,
Yeah.
and for us, it's very rare to have birdshot in our area. Maybe Dr. Hamaki knows that. It's too difficult to have these cases. When I look for the case, oh, this is typical case of, fluorescent angiography of jet disease as you have it. Diffuse leakage, like with the macroedema. So that's my thinking, And when I saw that the HLA-29 is positive, I'm starting to get drawback for that. So really, I don't have a case like that. And I did a lot of HLA screening for my patient, and actually we don't have this entity.
And one last comment that if you look at the old literature, I think it's probably a little bit racist because they thought that this was something that would only happen to white people. And I've seen papers that say this is a predominantly Caucasian disease. But then we had two cases by Debbie Goldstein, one in a Mexican, another one an African-American patient, that they were being treated for something else because they thought just because he was Mexican and the other one was African-American could not have birdshot, and they were HLA-29 positive. And then we just published a series in Puerto Rico. So it's, it could be, it's disease has no racial boundaries, but.
Roland, do you have a quick comment before we move on with Dr. Samir presentation?
Yeah, a couple of quick things. One, because it's, probably it's uncommon everywhere, but because it's uncommon, unless I see the typical fundus picture, I don't order A29. So I might be missing some. My question is, what about the visual field and the ERG? Do you use those in your Dr. Armando, did you check those and they were normal in this patient or?
No. My first patient ever, she had very mild vasculitis, but she had visual field constriction, which led me to treat her. And that was like 12 years ago. So they do have visual field constriction as other patients with birdshot.
Yeah, great points. I'll summarize, Dr. Hassan, go quickly. If you...
Just only to look for the treatment response, how it was.
It's very bad treatment response, just like birdshot, very hard to treat. They're recalcitrant to probably prednisone and Celsep. I think they would probably do great with an intravitreal fluocinolone implant plus another immunosuppressor, but this one was a steroid responder, so that's a path we could not follow. I'm probably going to change to tocilizumab and see what happens. She was a law student, so she was finishing that, and she didn't want to try new medications while she was finishing. So we'll probably do tocilizumab. I think she started that recently, this particular case. But the others, same story from my friends in Minnesota. One of the patients who was a child, she required anti-TNF agent to be able to be weaned off the rest of her medication. So it's very aggressive.
That's great. Yeah, it's as you say, it's a spectrum. Our next speaker is Dr. Samir Shauki from Egypt. Samir, thank you so much for being here with us, and we look forward to your talk.
Thank you very much, Ahmed. I think it's okay now. It's working.
Please go ahead. Go ahead.
Okay. Thank you so much. I would like to thank Ahmed Salam, my friend, and Dr. Amri for the kind invitation. Today, I will talk about two interesting cases that were initially misdiagnosed, if the time allows. The first case, I'm sorry, it's not working. Just. Sorry, it's okay now?
Yes. If you can make it bigger, if it's possible to make it bigger.
Yeah,
presentation mode.
Presentation mode down there. I think it's down. It should be down. The icons down next to focus there, like down.
Sorry. Seems.
Can you please press on slideshow? It will be okay. Slideshow.
Or a slideshow.
Where is it? Available on the top. On the top. No, not in the presentation. Yeah. On the left side. On the top left side. Over the maximum over of here. Yes. Go to the right side. Little bit. No, to the right. Yes, this one. No, it was there. Slideshow.
No.
There was a slideshow.
Please accept the request, sir. You might be seeing a request.
Can you accept his request? He will arrange that very fast.
Sorry? Yeah.
Accept the request.
Okay. Okay, that's fine.
There you go. Fantastic.
That's fine. Okay, thank you. Thank you.
Fantastic.
Sorry for that.
Yeah.
So this is a 37-year-old male patient who presented on 18th of April. He was complaining of severe headache for 2 days and blurring of vision and floaters in both eyes. His vision was 0.1 in the right eye, 0.05 in the left eye. The intraocular pressure was almost normal. Examination of the anterior segment of both eyes showed 2+ cells and 2+ flare with irregular pupils. Fundus examination revealed these findings. It showed this vitritis and hazy view and this foci of retinitis. Fluorescein angiography showed this hot discs. He was seen elsewhere and was diagnosed with optic neuritis and panuveitis. Review of systems at that time revealed history of recurrent oral ulceration and genital ulcers. So putting these things together, the panuveitis, optic neuritis, oral ulceration, and genital ulceration, the patient was diagnosed as having Behçet's disease. He was given steroid injection, oral steroids, 40 milligrams, plaquenil, azathioprine, and cyclosporine. He was heavily immunosuppressed. However, there was very poor response to this systemic therapy, and they were considering him to start biologic therapy. However, despite this heavy immunosuppression, the response was poor. The patient has optic neuritis, panuveitis, and was suspecting of having Behçet's disease. So in this case, we have to think of other causes. We have to revise our diagnosis. So I started to think of infectious etiology when presented to me. So I asked him, did you have any fever before presentation? He admitted that he had a fever before the development of the eye manifestations. I asked him the question that Ahmed and Rula were discussing. Did you have any sexual history outside marriage? He admitted that he had a sexual relationship. So I asked him about skin lesions. He didn't mention anything, but when I put him on the slit lamp, I noticed that he has this characteristic lesions in his hands, and I asked him to show me his legs, and I saw this skin lesions. So I suspected syphilis, and I asked him to do syphilis serology, HIV antibodies, and also to rule out other important causes. I asked him to do quantiferon, ACE, and CBC differential. Laboratory workup was almost normal. The CBC differential was fine, the quantiferon was negative, and the ACE was within normal. However, HIV came out to be positive and syphilis serology was negative. He was referred to Alexandria Fever Hospital to start antiretroviral therapy. However, he came after 3 days and his condition worsened with the development of hypopyon now. So I started to think again of syphilis. So the condition is worsening. So I called one of my dermatology colleagues and he asked me to repeat the syphilis serology again because of the sometimes when the patient had high antibodies against syphilis and co-infected with HIV, there is the prozone phenomenon. And I ordered it again and came out to be reactive. So that our diagnosis was HIV positive and syphilis positive patient. This is very interesting case in our region because as Ahmed and Rola were discussing, this is relatively rare in our region, especially here in Egypt. But I saw 3 cases in 1 month. So I think we have to put syphilis serology again in our patients. So I have another case, Ahmed, if you like.
Yeah, I think we're good. Yes.
Okay. The second case is a 23-year-old male patient presented on 15th of February. He was complaining of blurring of vision in the left eye since 2 months following fever. His best corrected vision was 0.4 in the right eye, count fingers at 2 feet in the left eye. The anterior segment of the right eye was normal. In the left eye, there were only trace flare. Fundus examination revealed this bilateral disc edema, and this in the left eye, there is a macular star configuration. Fluorescein angiography showed this disc staining, and he was diagnosed elsewhere as having papilledema, and they didn't pay much attention to the macular star configuration, and they asked for the OCT retinal nerve hyperlayer, and the report came out to be bilateral severe papilledema and left-associated macular scar. His treating doctor, as usual, and it's a normal thinking, He's ordered MRI of the brain, and unfortunately, he did lumbar puncture. MRI of the brain was normal, and lumbar puncture showed normal opening pressure of the CSF, and it was normal. So again, when he presented to me, I started to think again. He has optic neuritis and macular edema, so he has neuroretinitis. So I started to think of the important causes of neuroretinitis. And I asked him to do the visual fields. The right eye showed enlargement of the blind spot. The left eye showed altitudinal visual field effect. I ordered the essential lab workup. CBC was normal. The quantiferon was fine. And interestingly, Bartonella antibodies were positive. The take-home message in these cases is to think of infection if there is poor response to conventional immunosuppressive therapy in cases of uveitis, and not every case of disc swelling is edema, and careful history is mandatory, and we have to ask a patient about sexual history. This is very important, and always be ready to change your diagnosis. Thank you so much, Ahmed, and my colleagues.
Samir, thank you so much. Samir, do you mind putting your slides of the syphilis case, the fundus photo? It just would be good to get some conclusions about how to manage retinitis. I've just heard from Dr. Amri that we have a few more minutes, and I think the discussion is fantastic.
So this one?
Yes, I think these are fantastic. So, Rola, what we've learned from those cases, the two cases, is reverse sequencing testing, like we do in the States here, but not in Europe and the Middle East, or maybe order the two tests together, like antibodies and RPR. Anything else you want to say on this point?
No, I think it was mentioned before. I think it's very important to test for both together. And the other thing is we have to test it on every patient. Almost every patient who comes to us needs to be tested, especially in this case. I mean, this is an HIV patient, and it just makes sense to test it immediately. And I think the infectious diseases doctors who are taking care of the HIV, you would think they would have done that automatically with the diagnosis of the HIV.
And I think also ask about sexual history and social history, sometimes embarrassing, especially on our side of the world or on the Middle East side of the world. But it is important because, I mean, I first establish a relationship with a patient and then ask them the personal questions. And you can maybe give them a warning shot that will ask you personal questions. We're not judging, but we
even if they deny it. Even if they deny it, you have to test it.
Yes. Yes. Yeah. Okay. So so Dr. Hassan here, this is patient with these lesions there. Some of them are retinitis and some of them are vitritis and the papillitis. So what's your differential diagnosis of retinitis? So how would you, for example, if you're teaching your fellow, what are you going to tell them about
initially that
retinitis?
Infectious causes should be ruled out, especially in young patients, as usual in uveitis. Syphilis test, I would like to stress over not just doing just RPR or VDRL. Usually we have to have, both tests, to look TBHA and VDR or RPR is an essential to do it. In this patient where I'm so that temporally in the left eye, I'm seeing some sort of like placoid lesion temporally, and that could be suggested. But in these cases, usually syphilis is an important, we have to rule it out. The papillomacular rash that I saw, it might be, one of the means of transmission of the disease, especially when it's starting to be dried up. This is an important. This could be one of them of the transmissions, apart from the sexual contact.
So I have a comment, Ahmed, please. This patient was diagnosed and treated elsewhere as having Behçet's disease because of the retinitis, and he was given immunosuppression. So that's why when we ordered the test, it came out to be HIV positive and syphilis negative, and then we repeated the test. The question now is for our colleagues in the Arab region. So traditionally, we ask the patients in our region to substitute, and also our colleagues, our young colleagues, to substitute syphilis serology with a tuberculin test, as it is more common here, and it is a great mimicker. I worked in Saudi Arabia for a long time with Professor Khalid Tabara, and at that time the syphilis was not common. My question to Dr. Dibi, do you see many cases of syphilis in Saudi Arabia now?
Yeah, let me too. That's a good point that you mentioned. You know, in Saudi Arabia before 2018, mostly we don't have a lot of syphilis cases. After the COVID, we start to see these cases. In the past, as a rule and baseline in our tertiary hospital, we do syphilis. Although we never had cases except for endemic syphilis, vigils. You know about vigils, yeah, vigils. But this is usually doesn't have this picture or evaluations. So syphilis for us is one of the essential lab investigation. We do it, even though that in our communities we are little bit society that restricted a bit, but after COVID we have a lot of search of cases.
Exactly.
Now I have more than 12 cases over just the last 2 years.
Also, Dr. Hassan, those drug abusers also have the HIV and more liable to have this, and this is increasing. Rola, what about the cases of syphilis in Lebanon?
Yeah, it's similar, I think, everywhere, although it's, you could see it increasing or decreasing, but it's a very small percentage of our uveitis patients. I think this is everywhere. But I have one comment about your case, that the photos you showed us of the rash on the palm of the hands and the sole of the feet, that's typical of clinically, that's typical of syphilis.
Exactly. Yeah, agree with you.
Irrespective of the video.
So, Samir, can you show the pictures, and can maybe Rola tell us what's really typical again?
Okay, which the skin lesions, you mean?
Yes, if you can, would be fantastic.
Yeah, sure. Yeah. So this is the hands.
It says a maculopapular rash with the scales, and it's at the palm of the hands, exactly, and the sole of the feet. And this is a text. These are textbook pictures of
exactly.
Was it itching? Usually, the classic teaching that are itching. Were they itching, or Samir? Do you remember?
Sorry.
Were they itching? Like were they?
No. He didn't show me this. I discovered them while I was putting the patient on the slit lamp. I noticed this lesions in his hand, so I asked him to show me his legs. That's why but he didn't complain. It was not itchy.
It's not itchy, and now it is now there is 2 parts. The erythema and the dried part of the lesion itself.
Yeah.
And this is why important at the examination, your gloves and taking care. It's important.
But exactly. Let me tell you something also. When I tested him for the first time and he came out to be syphilis negative, I looked at the literature. I saw that sometimes HIV can cause some similar lesions, some skin lesions, which could be mistaken for the syphilis. So we have to put this in consideration also.
I had a question for the panel here. I have a patient who got injected with steroids, bilaterally, intraocular steroids, with syphilis and HIV. It's a long story. Patient came to me. I rescued the patient, but he had steroids still in the eye. And I was contemplating, should I take it out or should I not take it out? So now you think you treat this with antibiotics, you don't need to take the steroids. But the interesting thing is, once the steroid went away, he started getting uveitis. He started getting inflammation in the AC as well as retinal vascular inflammation. Have you ever seen that? I mean, I've never seen syphilis act. It's a non-immune trigger, essentially, right? But in this case, I thought it was, and he's immunocompetent, like he's not, obviously is producing enough cells to create an inflammation. Has anybody seen this where syphilis, like TB, syphilis behaving like TB?
Yeah, I've seen something like this. It's the other way. So we had patients with syphilis who after treatment had significant inflammation that did not go away with anything except intravitreal Ozurdex. And
we need to write about this.
Pardon?
We need to publish this because
we've published that. We published there were 2 cases. So and I think the take from that, once you treat syphilis, as long as you can in a way guarantee that they don't have reinfection because of their lifestyle they may have reinfection. So at least maybe before doing it, just retest the RPR.
Yeah, we
And
did all
they
that.
do very well actually with steroids, as long as they have been treated. The problem is untreated patients.
Yeah, this
And
guy
to
is
answer
negative. We tested him.
To answer Sri's question, there's an entity called syphilitic autoretinopathy, which I suspect is probably mostly autoimmune. I did a review of the literature for syphilitic autoretinopathy. In many cases, actually had received steroids, systemic steroids, prior to being treated for syphilis. And there was some improvement. It's just that the workup came back positive, and then they ended up treating them. So there certainly is an autoimmune component to the syphilis spectrum of diseases. However, I would not advise someone to treat syphilis with steroids. Of course, you need penicillin.
Yeah. So
I think
if you have the panel has cases, please send me an email or something. Maybe we can write.
Yeah, I think this is again one of the function of these talks really is connection and communication and collaboration. So I can share the email of all of us. I think I've sent an email with all of us on it, but I'll do that again. I think we'll have to conclude for the sake of time to keep Dr. Al-Amri happy and the meeting going well. And maybe as a conclusion, it's important to ask history for uveitis patient. So social history and sexual history needs to be asked in all cases. And we talked about reverse sequencing. And Dr. Adibi told us in any retinitis, you have to rule out infection first before concluding that this could be Behçet, or maybe later on along the line, it could be a lymphoma. So retinitis, rule out Behçet. So I just want to finalize here by thanking our panel. This is a great discussion, and I've learned a lot personally. I would like to thank Dr. Hassan Adibi from Saudi Arabia, Dr. Rola Hammam from Lebanon, and Dr. Kurup from Ohio, USA, and Dr. Armando Oliver from Puerto Rico. And last but not least, Dr. Samir from Egypt. Thank you so much all for a great session.
Thank you. I learned a lot.
Thank
I really
you.
appreciate this.
Thank
Great
you.
friends.
Thank you so
Let's be in
much.
touch.
Back to you, Dr. Amri. Thank you.
Thank you very much, everyone. Thanks a lot. Dr. Hassan, مساء الخير.
مساء النور، حياك الله. تسلم دكتور محمد، يا هلا وسهلا، يا حياك
أهلا
الله.
مرحبا دكتور.
شكرا لكم جميعا.
Dr. Armando, nice to see you again. Dr.
Good to see you.
Samir also. Sherry,
Thank you.
thanks for
Thank you,
everyone
Dr. Amri.
participating.
Thank you so
Dr.
much.
Ahmad,
Thank you, Ahmed.
Thank you. Thanks a lot.
Thank you. Thank you so much.
Thanks a lot.
See you next time.
Thank you.
Goodbye.
أهلا دكتورة، كيف الحال؟ أنت ميوت؟ Can you unmute yourself؟
زي حضرتك كده اوكي يس
أهلا بك.
اهلا
Okay, can you just
كمان
confirm with
دكتورة
others?
مي برضو مي اوكي يس
They will allow everyone in a few seconds because still we are having 5 minutes. So it is now a break. If you want to try or to do something, it's okay. So for all those they are
can I share?
They can just join us after 5 minutes, or they can continue listening to us. We are going to start in a 5 minutes. Thank you.
Okay.
Assalamu alaikum.
عليكم السلام.
Assalamu alaikum, everyone.
Thank you very much. It was very interesting, Dr. Asma, with many interesting points in that. So we can go through Dr. Valley for the interesting case with multiple internal pulses.
Yes. Yeah. Thanks for your result. Very interesting case, and we have a very good result. In my experience.
Assalamu alaikum, Dr. Muhammad.
Salam, Dr. Fatma. You can start the session. Okay, you are in time.
بس هذا
Yes.
الفيديو.
Sorry.
الفيديو closed by the host.
Okay, it's already working, Dr. Fatma. You can go ahead. Just introduce the first presenter, and everything is working. They are with you.
Okay.
Okay.
Assalamu alaikum, everyone. Good evening. My pleasure to be with you today, and I like to thank everyone who participated with us in our Al-Qasmi International meeting, and special thanks to Dr. Muhammad Al-Umari, who is head of the scientific, and he arranged all these events. Thank you, Dr. Muhammad, for your effort. And also my pleasure to be among the young ophthalmologists. And I want now to ask Dr. Fairuz.
Assalamu alaikum.
Yes, Doctora.
Okay, I start to share my screen. Okay.
Yeah, please.
Okay. Okay. Is my screen shared now?
Yes.
Okay, so I start. I am Fairuz Azaim, lecturer of ophthalmology at Al Shiraini Cairo University. I will discuss the topic when the lens subluxation is associated with traumatic hypotony. What can we do? My first case is a 10-year-old child that had left blunt trauma, and he presented with visual acuity of counting fingers, 50 centimeters, and he had traumatic cataract with 5 clock hours of subluxation, and the IOP was 2 millimeter mercury, and he had vitreous in the anterior chamber with fundus showing picture of hypotony, disc edema, and choroidal detachment. The patient was given topical and systemic steroids as well as subtenon steroid injection. However, the IOP remained very low, 3 millimeter mercury. Intravitreal sec gas injection was tried, but also failed. UBM was ordered for the child, and it showed the presence of 3 clock hours of ciliochoroidal detachment. And it was strange that the area of the ciliochoroidal detachment was opposite to the area of lens subluxation. At that time, I reviewed the literature and I found some case reports of trying to apply cryotherapy to the cilicoidal detachment to form to make some sort of cryopexy. So cryotherapy was applied in a double freeze thaw over the area of the cilicoidal detachment, together with intrathecal non-expansile gas injection just to form the globe, opposing the detached ciliary body to its original place after performing some sort of inflammation using the cryotherapy, hoping that it got attached to its original place. 1 month later, the patient has complete resolution of the choroidal detachment and the ciliary body detachment, except in less than 1 clock hours, and the IOP was 16 millimeter mercury, surprisingly. And the patient was scheduled for cataract extraction. And this video shows the operation. The idea was to fixate the capsular bag to the sclera and doing irrigation aspiration and IOL implantation. So I started to do baryotomy at the area of subluxation, and then I did a groove, scleral groove, to embed the 10O proline sutures. I did dry anterior vitrectomy, preventing more vitreous prolapse in the anterior chamber, and then I did the anterior capsulorhexis. It was not an easy job because the child was 10 years old, the capsule was extremely elastic, the vitreous was adherent because he had this problem about 4 months ago, so the vitreous was attached to the anterior capsule, but I was able to perform it successfully, and I was trying hardly to centralize it, to be able to centralize the IOL later on. Then I did support of the capsular bag. I didn't have capsular hooks at the time, so I used iris hooks to pull the capsular bag and stabilize it during irrigation aspiration. And then I did hydrodissection gently, and then irrigation aspiration. He was a 10 years old child, so irrigation aspiration was not difficult, it was easy. Using the bimanual. Then irrigation aspiration is finished. And then I tied a 10O proline suture over the eyelet of a Sayuni ring. Then I started to insert the Sayuni ring inside the capsular bag, keeping the eyelet anterior to the anterior capsulorhexis to pull it to the sclera. And then I started needle docking of the 10O proline sutures, keeping in mind to exit inside the scleral groove, which was created at the beginning of the surgery. And then I tied it inside the groove, keeping the knot embedded inside the groove. And then I implanted 3 pieces IOL to add more support to the capsular bag. I inserted it first in the anterior chamber, and then gentle manipulation using micro forceps. I pulled it to insert it inside the capsular bag to add more support to the capsular bag. To leave a perfectly centralized intraocular lens, and then irrigation aspiration and closure of the conjunctiva. After 1 month, the patient had best corrected visual acuity of 0.8. His intraocular pressure was about 17 millimeter mercury. He had only 1.5 diopters of astigmatism with perfectly centralized IOL and flat retina to leave a happy patient and a happy doctor. The other case, the same scenario, but in older patient. He's 40 years old patient, had left bound trauma with hypotony, visual acuity 165 clock hours of subluxation with vitreous in the anterior chamber. After performing cryotherapy over the area of the cilicoidal detachment and the IOP was controlled, the patient was scheduled for a flange technique for cataract extraction and fixation of the bag. The subluxation here was superinasal, so I set on the temporal side to be away from the area of subluxation and from the prolapsed vitreous. Then after anterior capsulorhexis, I did viscodissection of the lens matter. Then fixation of the bag. I was prepared at time with my capsular hooks. So I centralized the bag and supported it using the capsular hooks. And then I did phacoemulsification. He was 40 years old patient, so he had the nucleus, so I have to use the phaco probe. And after finishing lens removal, I prepared my Sayuni ring again, type 1L Sayuni ring. And at that time, I used the 5O proline suture, creating a knob, and then passing it inside the fixation eyelet, like in the video. And then I inserted the Sayuni ring, taking in mind that the first part touching the capsular bag should touch the subluxated part, because otherwise, if it is inserted the other way, it would induce subluxation. So we have to choose the type of the Sayuni ring we insert prior to our surgery. Then keeping the eyelet at the area of the maximum subluxation, which is the soperonasal, with the aid of a microforceps, and a Sensky hook. Then I used an insulin needle, forming a tunnel 2 millimeters from the limbus, and then passing it inside the globe to dock the suture inside the needle, and then externalizing it inside to the sclera to perform another knob and embedding it inside the tunnel, like we use in a Yamani technique in cases of scleral fixation of ILs. After docking it inside the insulin needle, I externalize it to the scleral surface. And notice here on pulling the suture, the bag got centralized. And again, I inserted 3 pieces IOL to add more support to the capsular bag, implanting it first in the anterior chamber, and then in a controlled way using a forceps inside the capsular bag. To leave a perfectly centralized IOL. And then I cut the remnant of the suture, and by the cautery created a knob and embed it inside the tunnel. Then irrigation, aspiration, and closure of the wound. This patient had about 2 weeks now, and he's doing very well. So my take-home messages is that you have to put your plan before your surgery and be prepared with all your equipment to try to provide the best for your patient. And please don't let these eyes with hypotony to pass into phthisis bye-bye. And thank you for your attention.
Thank you, Dr. Fairouz, for this very valuable presentation. And that right now, Dr. Hanan Sadiq, please.
Hello, can you hear me?
Yeah, Hanan.
Hi. I'm here.
Yes, Hanan, go ahead.
Okay, hello, hi everyone. My name is Hanan Sadiq Al-Hakimi, first year ophthalmology resident from Yemen. It's really a pleasure for me to be part of this great conference, and I'm really grateful for this great opportunity. Can I share my screen, please?
Yes, Hanan, please go ahead.
Okay, can you see my screen?
No, still nothing there.
Can you see it?
Yeah, it's okay now.
Okay, I'll start. Okay, today I'll present to you a very interesting case of a female that was presented to us in Al Jamhuri Hospital Ophthalmology Department clinics under the supervision of Dr. Abdullah Al-Baham. Okay. Our case is about 35-year-old female patient presented complaining of sudden paleness, progressive loss of vision in the left eye for 3 weeks. The patient can recall the exact date of symptom beginning, which was Ramadan 15th. So we started to think what may cause unilateral sudden paleness, progressive loss of vision, which may include central or branch retinal artery occlusion, non-arteritic ischemic optic neuropathy, retinal detachment, central branch vein occlusion, vitreous hemorrhage, optic neuritis, brain tumor, and lastly, the diagnosis of exclusion, which is malingering. So we'll proceed with the first step, which is history, in order to narrow down our differential diagnosis. As we said, the chief complaint was sudden paleness, progressive loss of vision in the left eye for 3 weeks with no other complaint. There was no history of any chronic diseases, including hypertension, diabetes, cardiac diseases, hyperlipidemia. No history of any medication use, no history of recent or old trauma, no history of ocular surgeries or other surgeries, no history of irradiations, and lastly, no history of any similar family incidents. So unfortunately, the history was clueless in helping us narrow down our differential diagnosis. We'll proceed into the next step, which is examination. Patient examination, the visual acuity in the right eyes was 6/9, and in the left eye, it was counting finger less than 20 centimeter. It was bilateral, normal ocular muscle movement, no proptosis, normal IOP bilaterally. Slit lamp examination showed normal lids bilateral with no abnormalities, normal interior segment, including clear conjunctiva with no congestion, clear cornea, normal lens, normal iris, normal AC depth, no rapid and regular reactive pupil. We tried to do a visual field of the left eye by confrontation test. However, due to the severe decrease in the visual acuity, that wasn't possible. So we dilate the patient pupil in order to examine the fundus. Fundus examination showed bilateral flat fundus with bilateral optic disc, normal, no cupping, no swelling, normal macula bilaterally with normal foveal reflex. So again, the examination was clueless in helping us narrow down our differential diagnosis. And for a moment, we thought maybe the patient is malingering. So we, as a last choice, we sent her to do a brain MRI that included the orbit, optic tract, optic chiasm, and cavernous sinus. And sadly, as you can see here, that is the patient's MRI, images and report. It showed a mass that is extraaxial, measuring 5.8, multiple 5.4, multiple 5 centimeter in diameter, showing vivid enhancement with dural tail, encroaching the orbital apex, engulfing the internal carotid artery, with crossing the midline, compressing the left ventricle with midline shift effect, with most likely diagnosis of left stenoid bridge meningioma. So our final decision was to refer the patient to a specialist, which is a neurosurgeon, to decide what's the best way to handle the tumor. In this particular case, the decision was to do a debulking surgery because total excision wasn't possible due to the engulfing and encircling of the internal carotid artery. Overview of meningioma. Meningioma is a tumor that arises from the meninges, which is the membrane that cover the brain and spinal cord. Their location may cause severe morbidities and mortalities. Epidemiology of meningioma, it is considered the most common CNS tumor, accounting for 1/3 of all primary tumors. Its incidence rate varies according to many things, including the race. It is more common in Black American. Age. It increased progressively with age, with median age of presentation is 65 years. It is very rare in children and usually associated with neurofibromatosis. Lastly, gender, it is more common in women with female to male ratio of 2 or 3 to 1. And the female predominance is highest in the middle age, as we can see in our case. Risk factor of meningioma, according to many studies that was done, it include ionizing radiation, genetic predisposition, hormonal factors, low estrogen and progesterone, others such as breast cancer, head trauma, and obesity. Pathology of meningioma. WHO classified meningioma according to the morphological criteria into 3 grades. WHO grade 1, which is benign meningioma. WHO grade 2, which is specific subtype, including the clear and the choroid meningioma. Lastly, WHO grade 3, which is malignant meningioma. Now, this WHO classification is important because it correlates with the outcome and it has a major impact in treatment plan decision. Patients with WHO grade 2 or 3 are more likely to have invasive disease, local recurrence after initial treatment, and overall shorter survival rate comparing with the WHO patient grade 1. Meningioma location. Meningioma can arise anywhere from the meninges in the dura. As you can see, this table showing the different location of meningioma with the percentage of prevalence, with the parasagittal being the highest and the multiple being the lowest. Now, for us as ophthalmologists, the most common 2 sites we see is number 1, sphenoid ridge meningioma, which is further subdivided into the lateral, which is petronial, middle, which is alar, and lastly medial, which is clinoidal. The clinoidal meningioma can encircle the internal carotid artery, affect the optic nerve and other cranial nerve. The second side is optic nerve sheath meningioma, which is uncommon benign tumor arise from the meninges covering the optic nerve, usually in the intraorbital or in the intracanacular part. It should be differentiated from a secondary intracranial meningioma extending into the optic nerve. It is usually considered the second most common of optic nerve tumors, with approximately 1 to 2% of all meningiomas. Clinical presentation of meningioma, it depends on the location of the tumor and the time course over which the tumor developed. Like usually they are slow growing tumors, asymptomatic, and instantly discovered during autopsies or neuroimaging. Meningioma can produce its symptom by different mechanisms, including irritation, compersion, and stereotypic symptoms, which is characteristic focal deficit caused by a tumor in a specific location. For example, visual change if the meningioma affects the optic pathway, which can be presented either by progressive unilateral visual loss, as in our case, or optic atrophy in one eye with bubble edema in the other eye, the so-known as Foster-Kennedy syndrome, or mild weakness of the extraocular muscle, and lastly, visual field effects. Other non-ophthalmologic symptoms, which is loss of hearing or smell, mental status changes, extremity weakness, and obstructive hydrocephalus. Neuroimaging of meningioma. Usually meningioma has characteristic features in both CTs and MRI. They are usually extraaxial dural masses showing iso-intense to hypo-intense signal in T1 weighted and iso-intense to hyper-intense signal in T2 weighted images. They are showing characteristic feature of marginal dural thickening that tapers periphery, the so-known as the tail sign. Now, diagnosing whether meningioma is atypical, benign, or malignant, depending purely in the neuroimaging, is very difficult and need histological confirmation. Management of meningioma, it differs according many factors, including the patient age, symptoms, comorbidities, location of the tumor, size of the tumor, and facilities available. It may be either observation, surgeries, which has so many different approaches, or radiation. Take-home message. Be systemic in every patient you see, take a full history and detailed examinations. Meningioma can be presented by different presentations and symptoms. Always keep brain tumors, including meningioma, in your differential diagnosis. Choose the best investigation that would help you to reach the diagnosis. Never say malingering to a patient before you exclude all other important differential diagnoses. Those are my references. This is my email if you have any questions. Thank you very much for your attention.
Thank you, Hanan. Very nice, interesting case, and very nice review of the case also. Thank you very much. Now I will
stop sharing my screen.
Nice presentation.
Nice presentation. Really good luck. And I like to invite now Dr. Ubaid Al-Rahman. Ubaid, you are ready?
Am I audible?
Yes. Go ahead, please.
Okay, Assalamu alaikum and good evening to everyone present here.
Walaikum assalam.
Is my screen visible to everyone?
Yes, but not full screen.
No, now full screen?
Yeah,
Yes.
yes. Go ahead, please.
Just 1 minute, please. Yeah, so I am Dr. Ubaidur Rahman, and I'm going to talk today on intraosseous venous malformation of the orbit. But before I start, I want to express my sincere gratitude to Dr. Muhammad Al-Amri and all the organizers for giving me this opportunity. So I'm an adjunct consultant currently at Department of Oculoplasty and Ocular Oncology at Dr. Shroff Charity Eye Hospital in New Delhi. I have no financial disclosures to make. So I'm going to talk about a series of patients who presented to us with different presentations. So the first one, she is a 40-year-old female and who presented to us with fullness of the malar or the cheek area. So if you see on the left side, there's a fullness here which is not present on the right side, which is flat totally. So on this side, another thing you can see, there's a little dystopia. The globe is moving up. So on clinical examination, there was a hard mass palpable on the lateral part of the inferior orbital rim. Otherwise, her ophthalmic examination was within normal limits and her vision was 6/6. So a CT scan was ordered for this patient, and on the CT scan, a round bony mass was seen, as can be seen here. And this mass had certain internal trabeculations in a honeycombing pattern. So we were in a dilemma. We thought whether it could be an osteoma or maybe an orbital intraosseous venous malformation. So a digital subtraction angiography was also ordered for this patient, and it showed feeder vessels arising from the branches of external carotid artery. So this was a vascular mass. So we went ahead with exploration of this mass, and you can see there's a transconjunctival approach which has been converted into a swinging lid flap, and this mass was isolated, looking very vascular, bluish, and a safe margin of normal bone was marked all around the mass. And this is a piezoelectric cutter being used to excise the mass. So this was the defect left behind by the mass. After achieving hemostasis, a titanium plate was molded in this particular configuration and secured with titanium screws. And this particular wound was closed. So now we move on to the histopathology of the mass. On gross examination, in the first image, you can see there's a round mass, bluish discoloration, blue-red in color. And on cutting the mass in the image below it, we can see there are venous channels, there are blood channels there, and there's a honeycombing pattern seen. On H&E staining, we can see here, these are endothelium line spaces, single line of endothelium. And within these cavities, there are red blood cells, and there are fibrous septa, which are dividing these channels. And here you can see this is the bony structure. So a diagnosis of intraosseous venous malformation was made, and this is the patient at 3-year follow-up. And you can see, as compared to our first image, the malar prominence on the left side is gone. Both sides are comparable now. So coming to the second patient, this was a 21-year-old female who presented with proptosis and dystopia of her left eye, which can be seen, which she had since childhood, and it was gradually progressive. There was no pain to the patient. The visual acuity was 6/6. Ophthalmic examination was within normal limits. So again, CT scan was ordered for this patient because a hard mass was palpable along the superior and the lateral orbital rim. And in the CT scan images, you can see there's a mass arising from the bone. This is a bony mass which is pushing the globe outwards, and it has several channels within it. There's a trabeculated pattern. Digital subtraction angiography revealed feeder vessels from branches of external carotid artery. So again, we took up this patient for debulking because she was a young female, cosmetically concerned, and here orbitotomy is being performed, and debulking of the mass was done. Since you can see in the CT scan, this mass is involving several bones, the frontal bone, zygomatic bone, the greater wing of the sphenoid, and it was again a vascular mass. And just to inform you, embolization of the feeder vessels was performed in both the cases, in the first case also, this case also, and after that the surgery was performed. So maximum debulking was done as much as possible for this patient. On histopathology, again, we see this is the bone structure, and within the bone structure, there's an endothelial lined cavity which contains lots of red blood cells. So again, a diagnosis of intraosseous venous malformation was made. And now this is the patient at 3-month follow-up, and you can see there's a reduction of proptosis. So when she initially presented, she had a proptosis of 12 millimeters, and currently she has a proptosis of 5 millimeters, but the patient is cosmetically satisfied. And we can see below, these are the post-operative CT scans compared to the pre-operative CT scan. So we can see the mass, a lot of portion of the mass is gone now because debulking has been performed for this patient, and proptosis has also reduced. So this was our third patient, a 28-year-old female. We can see there's a proptosis of the right eye here. She had history of 1 year gradually progressive proptosis. There was intermittent pain, but no other complaints. Vision was 6/6 again. So a CT scan was performed for this patient because we could not delineate the margins of the mass. And on the CT scan, we see this appearance. And again, several bones are involved here. The frontal bone, again, the zygomatic, and the greater wing of the sphenoid was involved in this particular patient. So we made a probable diagnosis of a polyostotic fibrous dysplasia. And in this patient, on DSA, there were feeders from ophthalmic artery. Now, in this particular case, we could not do embolization because embolizing the feeder artery from the ophthalmic artery carried a risk of vision loss. And since vision was 6/6, this was a young patient, we performed an incision biopsy just for diagnosis. And on incision biopsy, you can see this is the bony structure. Within it, these are endothelial lined cavities containing lots of red blood cells and a lot of fibrous septa in between. So we were surprised on the appearance of this mass on CT scan and histopathology not correlating. So the final diagnosis based on histopathology was intraosseous venous malformation. For all these patients, immunohistochemistry was also performed, and immunohistochemistry was positive for CD34. That confirms endothelial origin. So all this brown structure you see, this is positive for CD34. That means the origin was endothelium. And it was Ki67 negative. So Ki67 is a proliferation marker. So negative Ki67 means that there was no endothelial cell proliferation or proliferation of the cells. So in our case series, we could find 6 patients with average age of 30 years. The duration of symptoms was from 6 months to 10 years. And there was equal distribution between the left side and the right side. The most common symptom in the patients was proptosis. And we followed these patients right from 6 months to up to 4 years. The most common bone involved in these cases was frontal bone and zygomatic bone in 4 cases each. So there was a female predisposition. Out of 6 patients, only 1 was male and 6 were females. In 3 of the patients, complete excision was performed after embolization. In 2 patients, we could not excise, so incision biopsy was done for diagnosis. And in 1 patient, who was case number 2, partial excision was performed for debulking. So this is the data of all our 6 cases. I've already discussed 3 cases. I cannot discuss all 6 cases because of paucity of time. But case number 4, I'll just brief you. In short, was a 20-year-old female, again with proptosis and a superiorly displaced globe. Maxilla and zygomatic bones were involved, and total excision with reconstruction was done. In another case, which was a 23-year-old male, he had an expansile lytic mass involving the frontal and ethmoid bones. Again, in this patient, there was embolization done, followed by complete excision and reconstruction. And the last case was a 48-year-old female who had an expansile lesion showing ground glass appearance. This patient refused surgery, so an incision biopsy was done for her. In all of these patients, we maintained follow-up from 1 year to 4 years. There has been no recurrence in any of the patients and no increase in proptosis in any of the patients. So now coming to the discussion, venous malformation is known by a very famous misnomer, that is cavernous hemangioma. But this is a wrong term. So amongst tumor and tumor-like conditions, venous malformation forms the most common soft tissue pathology of the orbit. But when we talk about bones, this pathology becomes very rare. It constitutes for less than 1% of all bony tumors. And out of these cases also, more than half of the cases are seen either in the vertebra or in the calvarium of the skull. So venous malformation of the orbital bones is very rare. The first case was described by Rowbotham in 1942. And since then, 80 years have passed, but only 72 cases have been described. There's a female preponderance noted in these cases and a peak in the 5th decade of life. So typically, yes, sir.
Doctor. 1 minute, Doctor.
Yeah.
Continue. Still 1 minute for your lectures.
Okay, so typically these are slow benign lesions and symptoms can vary from proptosis to swelling to diplopia and even epiphora in some of the patient depending on the site. So these arise from the intradiploic veins within the bones, and after any trauma or any angiogenic accident, these masses start growing in size. They gain feeder vessels from surrounding vessels, and then these masses grow in size, leading to bony enlargement. So a honeycombing pattern is the classic appearance seen on CT scan. Other appearance can either be sunburst that shows radiating trabeculae, a radiolucent appearance, or lytic lesion. So it has several differentials such as fibrous dysplasia, meningioma, bony osteoma, or aneurysmal bone cyst. But the two closest differential diagnosis, one is fibrous dysplasia and another one is meningioma. So fibrous dysplasia typically has a ground glass appearance, and it is very difficult to differentiate clinically from an intraosseous venous malformation. But an MRI can show signal voids and strong contrast enhancement, indicating towards a vascular lesion. But definite confirmation can only be done on histopathology. Similarly, meningioma is a very close differential, but in meningioma, the striations are vertically aligned, unlike the venous malformation in which there's a sunburst pattern. Also, meningioma shows a reactive sclerosis and erosion of the inner bone table. So these are highly vascular lesions with several feeder vessels, and preoperative embolization reduces the risk of intraoperative bleeding. After embolization, vascularity decreases, but surgery should be done within 48 hours. Otherwise, the vessels can again grow into the mass. So treatment of choice remains complete excision with a normal bone margin and reconstruction of the defect. But there are other options also depending on the patient, such as partial excision, observation in certain patients. Certain authors have also described sclerosing injections and radiotherapy. Then there are certain upcoming modalities such as ultrasonic knife aspirator, which can excise the mass with much safety. On histopathology, we can see dilated endothelium line vascular spaces, as was seen in our patients. And according to the International Study for Vascular Anomalies 2018, we should call these lesions as hamartoma instead of a hemangioma, because there is no endothelial proliferation in these lesions. So to summarize, this lesion is very rare, but clinicians have to be aware of this lesion. Presentation can depend on the site, and radiological appearance can be suggestive of a venous malformation. For management, there are several factors that have to be kept in mind. And since this is a highly vascular lesion, preoperative embolization is recommended. Otherwise, there can be intraoperative bleeding. So these are my references. And at the end of the talk, I want to acknowledge my mentor, Dr. Kasturi Bhattacharjee, who was my mentor during fellowship. And I want to thank you all for your kind attention.
Thank you, Dr. Ubaid Rahman, for a very nice presentation. And I would like now to invite Dr. Emil Faqih to go ahead for her presentation.
Thank you.
Okay, good evening.
Yes, Dr. Reem.
Share your screen, yes.
Full screen, please.
Is my screen apparent to you?
Yes.
Show him, please, full screen.
Yes.
Yes, go ahead.
Okay. Good evening, everyone. I would like to express how happy I am to present in front of you and to have that good chance to take you in an interesting 10-minute journey, as I hope in an interesting case that we have. My name is Rima Al-Faqih. I'm a general ophthalmologist from Yemen. Our journey will start with meeting our patient at first, then we'll take a deeper look at the patient's case, our clinical approach and management, and then we'll discuss the case in general briefly. Before everything, this is a declaration of the patient's consent that we have all appropriate consent forms to present his case today. First, let's meet our patient, the hero in our story. This is our patient, a 60 years old male patient who presented to the clinic complaining of protrusion of the right eye in an insidious onset for the last 1 month, progressive in course, and it was associated with no pain and no visual complications that he's complaining of. His eye history, to that eye, he has no relevant history, no major complaint before, no surgery or trauma. As for the other eye, the left eye has decreased vision over the last 20 years. He had a cataract surgery at that time. His general medical and surgical condition is good. He has no present chronic disease as diabetes or hypertension, no relevant surgical or major health issues, and no allergies to food or drugs that he can remember. By his examination, his general eye examination showed a visual acuity of 20/30 in the right eye, corrected to 20/20, hand movement in the left eye that was not improved by correction, and an IOP normal in both eyes. Extraocular examination showed normal movement and no limitation in any ocular movement. As for the mass examination, in the right orbit, as we can see, it's a palpable mass, firm in consistency. It was not pulsatile, and there was no ocular bruit, no tenderness, and the skin overlying it, as we can see, showed no significant mark. The regional lymph nodes were free too. Our proptosis examination showed an axial proptosis in the right eye of 22 millimeters and normal in the left eye. Slit lamp examination also showed normal structures except for mild redness of the conjunctiva in the right eye with early nuclear sclerosis. In the left eye, the pupil was irregular, sluggish in reaction, and he was pseudophakic. His dilated fundus exam showed no abnormality in the right eye, but optic disc pallor in the left eye. So our clinical workup was first to send him to radiology. We sent him for magnetic resonance. As you can see here in the images, the eye is compressed and pushed forward by an infiltrating mass that's occupying only the right orbit. As you can see here, it's engulfing the muscular cone and extraocular muscles and the optic nerve inside. This is the size of the mass as the report mentions, 4×3×7×2. So our list of differentials was hemangioma, orbital lymphoma, optic nerve meningioma or glioma, orbital lymphangioma, or metastasis from any other site. Next step was the surgical workup. The patient was scheduled for elective planned excision. Our aim was mass exploration and mechanical decompression and obtaining an incisional biopsy. This is the biopsy that we have taken. It's about 3×2 centimeters, firm in consistency, fibrous and relatively avascular, but there was no distinct plane between it and the orbital fat. As lymphoma was one of our main differentials in the list, the specimen was sent for histopathology in saline. No formalin was added. This is our patient, day 1 post-op. Those are the histopathology slides. As you can see, it reveals sheets of undifferentiated cells with scanty cytoplasm and multinucleated. Next step was immune histochemistry, which shows diffuse positivity for CD20 and negative CD30. So the diagnosis was a high-grade large B-cell non-Hodgkin's lymphoma of germinal center type. Our management plan was discussed, of course, with the oncologist. We both worked to take the patient to the safe side, The process of management first was to do the staging to make sure that the lymphoma is only confined to the orbit, and if there is any systemic involvement. The second is to choose the best treatment method that we can do for this patient. And the last is to treat and follow up the patient. So as to have the correct staging, the patient had full blood work, neck, chest, and abdominal ultrasound and CT scans, liver and kidney function test. All of them revealed no abnormalities. So no systemic involvement was found. And second, we had to discuss with the oncologist the treatment options. The first option was surgical excision, but as we have seen before in the MRI images, the location of that tumor would prevent us from completely excising it without altering the function of the eye. Other treatment options were chemotherapy, radiotherapy, and immunotherapy, which we don't have in Yemen and still under research as the relapse rate is very high. As for radiotherapy, many authorities say that it's the most preferred treatment modality, but for this patient, he is a single-eyed patient. We could not risk the radio complications that might be vision debilitating as retinopathy. Chemotherapy may not be the best choice for most lymphoma cases that are confined to the orbit, but in our case, which is a high-grade diffuse large B-cell lymphoma, it was the best choice that we have. So with the oncologist, we decided that the regimen for treatment would be the R-CHOP regimen of combined chemotherapy. The patient started receiving vincristine of 2 milligrams and doxamprin of 60 milligrams for 6 cycles in Al Jamhouri Oncology Center under the supervision of the oncologist. After 6 months of chemotherapy and follow-up, the patient had complete remission and no significant complications. Talking a little about lymphoma. Lymphoma is a general term that refers to cancer that arises in lymphoid tissue. It can arise from any organ or be disseminated to any organ. Can be classified into Hodgkin's and non-Hodgkin's lymphoma. An orbital lymphoma is a lymphoma which is found in the orbit or orbital adnexa. It is said to be primary if it's arising from the orbital structures themselves, or secondary if it's part of a disseminated disease. They are considered very rare among all types of lymphoma or cancers in general. But to the orbit, they are the most common primary malignancies, especially for patients above the age of 60. As we can see, the range is about 55% of all malignancies in the orbit. Their clinical presentation is usually non-specific. It depends on the location. The vision is usually preserved, as we have seen in our case, as the infiltration for the globe itself or the optic nerve is rare. Why early discovery is very important? Because 30% of all patients will develop systemic disease within 10 years. So early discovery might not be only vision saving, but life saving too. And follow-up should be lifelong if possible. So my take-home messages. First, early discovery might not only be vision saving, but life saving, as we mentioned. The right list of differentials. The right list of differentials would lead us to the right next step. So we have to pay attention to put the right list of differentials. Immunohistochemistry is a very important tool in diagnosis and should not be ignored. The treatment plan must be multidisciplinary. A one doctor management plan, it might not be the best choice for the patient. And the last piece of advice is that the plan of management should be put in count of individuality. Each patient is different and specific. We should not just only follow the protocols, but we should look at the patient's case in a specific way and put a management plan that suits him individually. Those are my references, and thank you for your valuable time. This is my email. I would welcome any questions.
Thank you, Reem Al-Faqih, for a very nice presentation. And now I want to invite Dr. May Abdul Qadir to give her talk. May, you are with us? May. Thank you, Reem. May.
Nice presentation, Dr. Anir.
Hello. Hello, Dr.
Hello.
Fatima.
Yes, May.
Can I start sharing my screen?
Yeah,
Yes.
please.
Okay. Good evening, everyone. I'm honored to be invited to share in the Young Ophthalmologist session of this prestigious conference. It's May Abdul Qadir, Assistant Lecturer of Ophthalmology in Cairo University Hospitals. So let's start with our case today. She was a 26 years old female patient who presented to us with 2 brownish masses that were cosmetically annoying her. She also complained of pain and drop of vision for 1 year duration in her left eye. She also gave us a history of trauma during her childhood and a poor vision in this left eye since then, but this drop of vision has increased in the past 1 year. On examination, the right eye was normal and unremarkable examination. The left eye had no perception of light vision. The intraocular pressure was elevated, was 36. The anterior segment examination could not be assessed well as there was a retrocorneal blackish membrane, but there are a picture of the patient showing the 2 masses that annoyed her. Also, the posterior segment examination, of course, wasn't feasible. We made a provisional diagnosis that this is an anterior staphyloma, and we sent the patient to do an ultrasound that came back with a tractional retinal detachment. Also, we performed the UBM, and we found the retrocorneal blackish membrane that may resemble an old hyphema, the anteriorly dislocated lens. Also, there were iridociliary cleft, and that was quite compatible with her history of trauma. But also we found another thing in the UBM. We found 2 masses of medium echogenicity. Here, as we find the sclera adjacent to this mass, it was thinned, but overlying this mass, there was no sclera, and this is only a hypertrophied conjunctiva. That was really suspicious for us, so we decided to perform to send the patient for PET-CT scan. That came back confirming our suspicion that there is a metabolically active left eye neoplasm. Since this is a blind, painful eye with high suspicion of malignancy, we decided to do enucleation and pathological examination. Her pathological examination confirmed the presence of ciliary body melanoma with optic nerve margin infiltration. It's worth mentioning here that the optic nerve margin infiltration in cases of uveal melanoma is rare, not as much as we see in cases of retinoblastoma, for example. So to exclude any intracranial spread and to assess the remaining part of the optic nerve, we did MRI brain and orbit, and it was free of any remaining tumor. Our further management, since there is an optic nerve infiltration, we need to do further management. Enucleation wasn't enough. After consulting the ocular oncology service, they confirmed that it's better for the patient to do external beam radiation, and this is the new recommendations, rather than exentration. So the uveal melanoma is the most common primary intraocular malignancy in adults. It represents 3 to 5% of all the body melanomas, with the highest percentage for the choroidal melanoma being 85 to 90%, then the ciliary body melanoma 5 to 8%, and the iris melanoma 3 to 5%. The risk factors include the white race, light-colored iridis, patients with nevus of Utta, patient who has multiple iris nevi, xeroderma pigmentosum, and also a positive family history. Regarding the histopathology, the uveal melanoma arises from melanocytes of the uveal tissue. It's either de novo or on top of a previous nevus. The histopathological types, the original calendar type had 6 classes, but now we tend to classify them into spindle cell melanoma, mixed cell, or epithelioid cell. The epithelioid cell carries the worst prognosis, and the spindle cell better prognosis.
here's the difference between both types, the mixed cell type, as we see both components, and the spindle cell where the cells are tightly packed together and there's no indistinct cell boundaries. Regarding its spread, it's well known that they do not spread with lymphatics. It's only local spread, transcleral or to the orbit, or hematogenous spread. The most common site, of course, is the liver, and this is the autopsy of a patient who died from liver metastasis from choroidal melanoma. And as we see, the black patches resembling the primary tumor. Also, there were many cases, case reports. It's rare, but there case reports talking about that brain metastasis, and skin or lung metastasis as well. So the common signs for the ciliary body melanoma include the presence of sentinel vessels, lens manifestations including lenticular astigmatism, subluxation, or localized lens opacity, also extraocular erosion or retinal detachment if there's a posterior extension. After reviewing the literature, we dig more to know about the unusual presentations of the uveal melanoma. We found many case reports talking about that the uveal melanoma may present or manifest as staphyloma, like we see in this case. Also, this is another case who presented to the emergency room with partially eviscerated lobe. She gave history that she has been treated as an anterior staphyloma for 3 months in another hospital. The doctors decided to complete the evisceration, and intraoperative, they found that the uveal tissue is thickened and very adherent to the sclera. That was suspicious for them, so they proceeded to do enucleation, and the pathological examination confirmed the choroidal melanoma. Also, another unusual presentation is the ring melanoma, which present with a refractory glaucoma that's difficult to treat, and it's even difficult to recognize or diagnose unless you do very careful gonioscopy. Although it's a relatively small tumor, but it has a bad prognosis, and the life expectancy is low due to high incidence of distant metastasis. This is another patient, also speaking of the refractory glaucoma, who presented with asymmetrical cupping, field changes, the open angle in gonioscopy. He was diagnosed as primary open angle glaucoma. He started timolol and latanoprost. 9 months later, the patient developed heterochromia, and that was referred to the latanoprost he used. But actually, the pigmentation was suspicious for the doctors. They consulted the ocular oncology, and they took a biopsy that confirmed that there was a diffuse ring iris melanoma with infiltration to the angle that caused the glaucoma. And that gives us the importance of very careful examination of any patient and the picture documentation. I'm not going to talk about the treatment or any further management plans because this is beyond our scope and time, but I'd like to emphasize the importance of UBM in those cases, because most of the ciliary body tumors, the small ones, are difficult to be recognized, and they cannot be seen by slit lamp examination, gonioscopy, or indirect ophthalmoscopy. Also, the UBM helps to detect the tumor extension into the iris and the ciliary body and assess the lateral tumor spread. What can we find in the UBM if there's a ciliary body melanoma? The first important feature is loss of the normal acute shape of the angle. It's either, as we see in the first picture on the left, it's a convex, or it's a linear, as we see in the second picture. Also, we may find tissue with medium echogenicity in the angle. It's important to detect posterior extension in the lens equator or the surface, as we see in the first picture on the left side. And this is another ciliary body melanoma extending to the lens surface. And this is important to decide the management, because if there's an extension, we may not be able to do a local resection. Also, it's important to detect a scleral invasion, as in the second picture. And lastly, the serous retinal detachment if there's a posterior extension. So also, the UBM is important to differentiate if this is a staphyloma or this is an invading melanoma. As we see in the picture on the left side, this is a thinned but intact sclera and there is no mass. So this represents a staphyloma. But as we see on the right picture, this is our patient who had a thin sclera adjacent to the mass, but above the mass, there is no sclera, and this is only a hypertrophied conjunctiva. So my take-home message is that ultrasound and UBM are very important in examination of such cases. The UBM provides useful information about tumor morphology and growth patterns. However, the definitive diagnosis is best reached by histopathological examination. Trauma can distort the eye anatomy, but the malignancy also does the same thing. So there is always a place for double pathology. The ciliary-choroidal melanoma can present by a staphyloma or mimic it. I'd like to thank the Ocular Oncology Service in Cairo University under the supervision of Professor Dr. Hani Hamza. Thank you for your valuable time.
Thank you, my very nice presentation. Dear panelists, any question to our speaker? Anyhow, our time is over. Thank you very much for everyone sharing with us this session. Thank you for our speakers and for their great and very nice presentation. Thank you very much for everyone.
Any discussion for speakers?
السلام عليكم. السلام عليكم.
Hello, السلام عليكم حسن.
السلام عليكم، كيف الحال؟ ألو.
Hello, السلام عليكم
السلام
حسن.
عليكم. السلام عليكم، كيف الحال؟
الحمد لله, how are you?
الحمد لله. We already began.
Yeah, I'm fine.
Assalamu alaikum, everyone. Welcome you in this Arabic session in the Al-Qasimi meeting. It's my honor and pleasure to introduce our valuable speaker, Dr. Arfan. He will be with us, pediatric consultant from Sheikh Khalifa, Abu Dhabi. And also it will join us later, Dr. Mariam Al-Fikki. She's a social consultant at Ain Shams University, Egypt. And also we have a recorded presentation, sadly, Dr. Peter Campbell. He is an associate professor in Oregon University. He can't join us live, so he will send his recorded, we have his recorded lecture will be with us. So I think, Dr. Arfan, you can begin your lecture.
Okay, let me share my screen.
Yeah.
All right. Hassan, can you see my slides? And here we are. Okay, everybody.
Yes,
Hassan, can you see them?
I can see it.
Okay, great. All right. Okay. Thank you very much. Thank you for Al-Qasmi for this honor. And thank you very much again, Hassan. He's a good friend, and I deeply it's always nice to hear Hassan from Hassan. So I'm going to talk about retinopathy of prematurity and laser and anti-VEGF. So as a part of SKMC, we do screening for ROP in Cornish Hospital. It's quite a busy unit. It's about an 85-bedded unit, and we screen about almost more than 800 cases a year, and we treat roughly between 32 and 40 cases a year. So I'm going to start straight into clinical cases. So this is a case So this is a case who was a 24-weeker, 670 grams, and he was seen at 34 weeks. At this time, he is in vessels are in zone 2. He has significant stage 2 in both eyes. He has plus and P plus in both the eyes. And at this point, we decided that we're going to go into do an anti-VEGF for him. This is his retinal pictures. A lot of plus disease, good bit of stage over here. Again, the left eye is more worse than the other eye. So he was injected with anti-VEGF, and this is now 34 weeks, just a few days. So he had a good response with the anti-VEGF. Those who do anti-VEGF, within 24 hours, you can see a incredible difference. So moving on, the patient is now 4 weeks post anti-VEGF. He is now 38 weeks. He still has some hemorrhages coming up. There is some recurrence coming here nasally in both the sides. Temporally, he's still all right. He still has thin retinal blood vessels. Now, moving on to 8 weeks, now he's developed more tufts of NVEs at the edge of the vascular and the non-vascular area in both the eyes. There's a bit of P plus coming here. He's now 42 weeks, and this is 8 weeks post anti-VEGF. So at this stage, he underwent laser. So he was booked up for laser at SKMC. So this is 8 weeks post anti-VEGF. Now looking at the second case, this is again a 23-weeker, 500 grams. Zone 1 and zone 2, stage 2 with P plus. Pictures are not the best, but it's because the vitreous was quite hazy. If you look, the blood vessels are very tortuous here. He's a bit of an edge here coming here, and nasally it is more as compared to the temporal side over here. There's some area of between stage 2. Cannot see if there's any NVEs, but looks as if he will progress to it. So he was opted for anti-VEGF, and anti-VEGF was given, and at this stage. Now moving on, he is now the same case. He is now 42 weeks now, and 42 weeks now he's developed recurrence, significant disease over here in the temple, a lot of NVEs, a lot of elevation there. The posterior port doesn't look that bad, but temporally there was a significant disease. So this patient then underwent laser after that. So recurrence after anti-VEGF, in our experience, babies receiving Lucentis, the recurrence of RP is seen after 5 weeks. I generally tend to avoid the second anti-VEGF because I'm always scared about the systemic side effects that we don't know of as yet. And the other thing is that if the vessels are midway in zone 2 or zone 3, and they've passed the zone 2 and just entering zone 3, with stage 3, we I kind of offer laser as a first-line treatment. This is as in this case, this baby was a 26-weeker, 790 grams, now 37-week, and some tortuosity over here. The more in the periphery is developing some NVEs. The blood vessels are branching, so we opted for laser, finish off the disease once and for all instead of seeing the patient again. Case number 4. This is an interesting case. A 27-weeker, 800 gram. He received anti-VEGF quite late at around 40 weeks, just before the baby was about to discharge. This is quite a long, about a while ago, about 3-4 years ago when the baby was seen. So when I saw the baby had a very large fibrous ridge here temporally. The other eye was fine, and there was also some straightening of the blood vessels here. There was this area was all empty. So I opted for laser all at the avascular retina, and as a prophylactic, she also underwent a scleral buckle just in that eye. I'm pleased to say that I'm still seeing her for now, and the retina is flat, and she is doing really well. Case 5 is a twin, 26-weeker, 850 grams, and so posterior pole looks good, and but at the periphery there's a large avascular area. Again, we kept on monitoring her, and now at 45 weeks, then she develops a more like a vitreoretinal tuft with some like a fibrous proliferation over here and some elevation of the blood vessels. So at this stage, she underwent laser. Sometimes if I see some of these cases, I do sometimes laser anterior to the area, just in a flare up if they develop some traction or fibrosis. I want some kind of strengthening effect here, just anterior to the fibrovascular area. So far, anti-VEGF intervention is better if it's done earlier. I offer laser if vessels they pass beyond anterior zone 3. And if anti-VEGF is done, then job is not done. You still have to look for recurrence, very, very important. And delayed vascularization, large avascular zones, you have to always look for signs of NVEs, and you have to laser them. About delayed vascularization, this is a case which, again, let me pass on the video. She is now 3 years of age. She was quite a young individual, and she came to me that should we do anything or not. But this is a fundus fluorescein angiogram which we did, and look, it's just completely avascular. There's no NVEs, nothing at all. So strangely, I haven't done anything to her as yet. I'm just following her. She is about -3, -4 myopic, but so far she hasn't developed any signs of neovascularization. And just to note, she did not underwent any treatment, laser or anti-VEGF. Okay, so I just have to, this is just a summary for now on. So current RP guidelines are good for low-risk babies. Screening interval may have to be shortened. I do that sometimes if I'm a bit concerned. I do see the babies earlier on. And this is also a very important point. If you don't do RP rounds every week, then it's better to familiarize yourself with the images. And American Academy has a very useful test, and it's a good tool to do it. And also think about the safety profile for your patients. Is it anti-VEGF or is it laser, whichever you are comfortable with. I just have 2 last cases to finish off. Then this is a very interesting case because the patient, this is 33-weeker. This is the right eye. This is the left eye, and she's a 23-weeker, 490 grams. Now 33. She underwent anti-VEGF at 33 weeks, and then at 8 weeks, that's what we see. She developed recurrence, and at that point, she was booked for bilateral PRP. But in the right eye, she underwent laser. In the left eye, we had an equipment failure, so we could not do anything. So because of the recurrence, I had to give her another anti-VEGF in the left eye. And this is her post-laser, 2500 shots posterior pole. This is the peripheries, all laser done. This is the left eye with only anti-VEGF. Posterior pole looks pretty much the same as the right eye. some peripheral neurovascularization of peripheral vascular changes over here, and over here she has a like a demarcation line. We're still following her. She still hasn't developed any NVEs, but I think probably at some stage she may develop something, and she may require a laser in this eye. So this is the right eye which underwent laser, and this is the left eye which underwent 2 anti-VEGFs. There's a little bit of more tortuosity in the left eye as compared to the right eye. One more case. This is a 28 weeker. This is the last case. 1,300 grams and had 1 ROP screen done. The parents didn't like the ROP screen which was done, so they were worried about the speculum. So unfortunately, they did miss the screen. And when the baby came to us, she had a lot of hemorrhages, a large hemorrhage over here, a lot of fibrosis here, this large area of the retina elevating with, and also over here in the other eye, she has some fibrotic changes over here with some vitreous and kind of fibrous bands over here. She was booked for laser. It was too risky to do an anti-VEGF over here, having this large fibrotic band. So she was lasered over here. Again, in these cases, I get a bit worried. So I do some prophylactic laser just anterior to it. This is only in cases in which there's a very large fibrotic ridge. So it's similar to the other eye. And this is her recently. Everything is now settling down. She does have some vitreous condensation, some vitreous bands over here, but there's no blood vessels here. Previously, there were literally blood vessels coming up into the vitreous over here. So yeah, this is these hemorrhages have all cleared, and she only underwent 1 session of laser, and she's doing good now. So in summary, laser is my preferred choice. Anti-VEGF does give buy some time, but this is an article which came out in an editorial about talking about bevacizumab and the for ROP and the neurodevelopment. So it's a very important read, and it just gives us some insight that what happens to these babies in the future. Do they develop some neurodevelopment problems or not? Thank you very much. Just stop sharing here.
Thank you, Dr. Khan, for this valuable information and very good, excellent cases. So just for us that for you use the anti-VEGF in the zone 1, and you don't use it in the zone 2, and you go for the laser and the recurrence. So about the zone 2 posterior, do you prefer the laser or you prefer the injection, the anti-VEGF to begin?
I would, my personal choice, I would prefer the laser, because I'm slightly worried about cases who especially don't have any insurance coverages. So it's easier for me to bring the babies to SKMC. So I bring them there and I finish off the laser. And so at least even if they miss a follow-up, I'm not worried about any delayed recurrence with the anti-VEGF.
In spite of the UK guidelines, they mentioned that zone 2 posterior, they advise even to use the anti-VEGF, because according to the ICROB 3, they mentioned the zone 2 posterior, even they give the definition for that, maybe they open the gate to use the anti-VEGF in this zone, because mostly the patient, if he underwent the laser in this zone, mostly he will end by high myopia, huge visual defect. Maybe if we consider that as zone 1. So what's your opinion? You prefer still you use it if the patient can do follow-up with you? Do you prefer to go by laser, or you can try for him on injection to avoid these refractive maybe errors or visual fields?
I mean,
because this is the debate around the real life practicing. There's guidelines, and there's most of the people, they try to do the laser to finish the follow-up, but it could be the solution for the children, especially when the patient is between 45 weeks, 60 weeks, and generally here, if you underwent the laser, mostly he will end by -6, -7, -8 sometimes. So still there's, what's your advice?
My advice in these cases, I think probably zone 2, okay, maybe zone 2 anterior, zone 2 posterior. I think I would wait, like the picture that I showed in which the baby was in zone 3, and there was some avascularity area, and there was a vitreoretinal, like a fibrovascular ridge there. I mean, if the vessels go up to here, then definitely laser. But if and probably in zone 2, like mid zone 2, or even probably if they're reaching anterior zone 3, I would try an anti-VEGF. My only problem because again it's the recurrence, and most of these cases, and what I've seen with the Avastin, I end up with a good avascular area here. It's pretty much. And yeah, I mean, I follow them up till about 45 weeks, but then again, after 45 weeks, then booking them up for EUAs, and it kind of, for me, it does cause some burden on my waiting list. So what I've recently done is that, yeah, I wait up till 45. If I still have an avascular area post anti-VEGF, I laser them. And yeah, primary laser procedures, anterior zone 3, I would laser them and just finish the job. Surprisingly, I haven't had many large myopias there. I've had -3 up to -2 so far, but I haven't had a very large myopic area.
Why even we chose, before we was using this one, the recurrence, even we have it like in holy sentence. If there is recurrence, we are going to do the laser, but we review our literature. We have cases since maybe around 8 years. So when we saw that the patient has ROB in the zone 1 or ROB, aggressive ROB, and he has recurrence, and we go for the laser, and mostly it will be the zone 2 posterior. Mostly the patient will be end by -6, -5. So we said for ourselves, why, if the patient is in zone 2 posterior, still in zone 1, we can give him another chance to do the laser, then the eye will grow more. It will be, even if you do the laser for this zone, after the babies grow, the eye grow, maybe at least you avoid some ischemia for the anterior segment. The anterior segment will be better growth. So you can avoid the high myopia in this situation. Why I ask you. Another question just to come to my mind, because there is some questions. Which kind of anti-VEGF you use in your facility?
We only use ranibizumab, Lucentis.
If you have the access to the bevacizumab, you can do it, or you would prefer to avoid it?
I think I'd prefer to avoid it, especially with the neurodevelopment. I mean, I'm not quite sure, but I still feel that even with the anti-VEGF which I give, I always see there's a bit of optic disc pallor, which I've realized is that most of the babies, they get some kind of it. And I'm actually looking at our results in which some of the babies have ended up who are very, very like premature 23-weeker who've had an anti-VEGF and then laser. I was looking at like we have 2 twins. One of the twins did really bad, a lot of neurodevelopmental delay, and the other kid was kind of like perfectly fine. So again, I'm not quite sure, is this the anti-VEGF or not? So, but again, I think probably with a safety profile, I'll stick with ranibizumab.
Let me then begin my lecture because Dr. Mariam will be the last on the list, and I'll try to explain something about maybe literature about this. I hope that it will be beneficial for the audience. Just let me share my presentation. You can see my
yes, we can. Yeah. Nice.
I'm Hassan from Dubai Hospital, VR consult, the surgeon and consultant, and I'm responsible about the ROB service in Dubai Hospital in the DHA. There's no financial disclosure. Just understanding this, I like this slide and I use it always. This summarizes the life of the ROB from the beginning until the eye crop, the classification of the ROB, then the randomized control studies, which used to treat this disease from different modalities, from cryo or from the laser, and even beginning by the BET study, which used the bevacizumab, then the CARE study, which used 2 doses of ranibizumab, which compared the anti-VEGF different doses by the laser, and then the ICROP 3, which give us huge definitions for something which we debate around it, and Firefly, which give the approval for the aflibercept use in the ROB, and we are waiting the 5 years ranibizumab extensions. Understanding about the comparing between 2 modalities for laser or cryo, that they are looking after the better anatomical outcome, and the laser approved better. When we are treating the ROB, generally we are looking for better anatomical outcome, better visual function, considering that ROB has ophthalmic complication, but on the other side, there's developmental and neurological complication for the prematurity itself. And in the end, when we treat and we use any medication or any treatment, we are looking for less side effects, which we sometimes the safety issue we speak it. You speak about the medical treatment for the ROB. This means that we use the anti-VEGF, which are valuable and now in the market, and there is underwent randomized controlled trials. We have the bevacizumab, ranibizumab, aflibercept. And we compare it, the most important, we compare between the molecular weights, and the bevacizumab have the highest, and the ranibizumab the lowest, and even the half-life, because the half-life of the bevacizumab is higher than the ranibizumab, and the aflibercept in between these medications. Understand that, put in your mind that these premature babies, they have immature blood retinal barrier. This is mean that this is not like the adult's eye. So from pharmacokinetics, elimination from the eye is 50% faster in the premature eye than adult. On the other side, from the elimination from the serum, it's threefold lower in the premature eye comparing by the adult. This is mean that the medication will be less in the eye, but it will be extended in the serum comparing by the others. From the Rainbow study, which compare between two doses, and when they measure the free ranibizumab in the serum, they found that when you give the baby 0.2 milligram injection, he has free ranibizumab 16-fold more than the adult who received 0.5 milligram in AMD. And the other side, when you use half dose, 0.1, the baby has around 7-fold free ranibizumab comparing by the adult who received 0.5. So from this, you know that even when you use lower doses, still you have more exposure in the serum for this anti-VEGF. Why we speak about this? Because these prematures, they have multi-organs still under growth, the brain, the lung, the kidneys, and we use this VEGF suppression because this vascularization need in all these organs. So for that, they speak about the systemic effect for this medication is the main part in all of the studies. So for that, if you go for the BETA study, which investigate and compare between bevacizumab and laser, and they use 625 microgram. How they reach this? Because according to them, when they choose this dose, they depending on the experimental trials on the animal models, they found that this is the largest molecular, so it will be escape less from the eye, and it will be effective just inside the eye. But this is not in the real, because according to the real life evidence, this is not correct, because the bevacizumab has systemic effect more than all of the others. So even in this study, they found that the death rate in the anti-VEGF group is higher than the laser. So if we go even to investigate the laser from the older study, because we have the ETROP, which compare between the cryo and the laser, this study, they didn't mention that if you do the laser earlier for these babies, you will have higher mortality compared by delay. This means that the laser still wasn't the reason for, at least from this study, when they compare that pre-threshold baby who underwent prompt laser and the other who conventional observed, they found that the mortality, the permanent morbidity between two groups the same. This means the laser, the rate of the death in the laser wasn't mentioned before. But when the anti-VEGF enter, then we face this problem. As Dr. Arfan mentioned about the editorials, what mentioned about wrong dose, maybe this affect the normal vascularization for the retina and for the others. So even the evidence came that when you use the anti-VEGF, the bevacizumab, you suppress the VEGF in the blood, in the serum from 8 to 12 weeks. This is have potential systemic and neurodevelopmental effect for this anti-VEGF in the ROB treatment. Reviewing all of the data, if you go to review this meta-analysis for about the neurodevelopmental impairment for this baby who underwent the anti-VEGF compared with the laser, they found that there is increase in the risk of the cognitive impairment. But on the other side, there is even meta-analysis and reports, they found that there is no risk for severe neurodevelopmental impairment. In spite, it could be some minor difference in motor performance. So still the profile for bevacizumab in this dose is still debate. So if we go back to the BETA study, we have some follow-up for this one of the site which use the bevacizumab, and they look after the neurodevelopmental. They don't found any difference between the two groups. But in spite of still around the world, somebody's afraid from this kind of dose. So in the pediatric eye disease investigation group, they used low doses and very low doses. They reached the 4 microgram of Avastin, and they found effective. But when they reduced the doses, they found that in the very low doses, you have reactivation earlier, because in the bevacizumab, generally the reactivation come after 8 to 10 weeks with the half dose of the adults. But when you reduce the doses, you will have reactivation earlier. But the recurrence not related to the dose. If we go further by the ranibizumab study, this is compared between two doses, with the 0.1 considered 20% from the adult dose, and 0.2 is 40% from the adult dose. They found there's systemic effect for this medication is around the same in the VEGF suppression, and the efficacy was the same. But they mentioned that there is kind of evidence that using the low dose could have complete vascularization, but this wasn't clinically significant. And we have another evidence from the Rainbow study, which approve against this. So the Rainbow study, this is, I think, the most important study in the now between our hands, because this is compared between two doses and the laser. And through this study, they approved that the superiority of 0.2 milligram to the laser, but there wasn't clinically significant between the two doses of the anti-VEGF, 0.2 or 0.1. And about the safety of the systemic effect, the VEGF suppression continue until 1 month in both doses. It's around the same. Even here, if you go for the ranibizumab free, you found that after there is reduced from around 7-fold reduction in the concentration of the ranibizumab from the first day to the last day. And you find that even if you use lower dose, still you'll find traces of ranibizumab. And when you increase the dose, you will have increased the free particle of these medications. Again, the free VEGF between these three modalities. And we have the extension when the result for 2 years for this study, which approved that the good result, which was available in the first primary outcome, is continue. Reactivation in both doses is the same, 30%. Peripheral vascular area is 30% in the two doses. This is mean that there is no superiority for the lower dose in this study, for the higher dose and in complete retinal vascularizations. So through this study, the ranibizumab got the approval to be used in the 0.2 in Europe for the ROB treatment. But few countries like the Switzerland, they give the approval just the 0.1 to avoid any systemic effect and about safety issue, because according to the literature, the 0.1 is effective as an 0.2. And this is even the extension from Rainbow. They look after the behavior of these babies after 2 years. They found when you use the ranibizumab compared by the laser, you have reduced high myopia, better vision related to the quality of life, and even there is about the behavior, neurodevelopmental, they don't found any difference between the three groups, the motor function, the health status. So even there is no difference in the measuring of the skull or any difference in the body structures. So just to compare between, because for us still we compare between Avastin, bevacizumab, ranibizumab. When this is a review about the data between the literature, the studies which was there, according to this, reactivation post anti-VEGF related to the aggressive of the ROB. When you have aggressive ROB, you will have reactivation in spite of use any dose. If you use the anti-VEGF in the zone 1, the reactivation is higher. Ranibizumab and lower dose, yes, have maybe earlier than the others reactivations. But could this related to the systemic effect of this medication or to the intraocular? Still, because when we compare between ranibizumab and lower dose of the bevacizumab, they found that the activations around the same, and the same, it will be earlier. So it could be for us, maybe this is the serum effect for this VEGF on the patient. We don't know. And in the last here, I want to mention the Firefly study, which got the FDA approval for the aflibercept to be used in the ROB. And the aflibercept here it's used in the 20% of adults, 0.4 milligram. They enter in the the ROB stage 2, zone 2 with the plus, which was avoided in the rainbow study. And even according to the investigation here, the higher free and bounded aflibercept in the plasma is high compared by the adults who receive it in the AMD. Reactivation in the aflibercept 30%. Death rate, the death cases was 3 cases in the aflibercept group, but according to the investigator, it was related for the prematurity complication like bronchitis, distress, and it happened between 6 to 8 weeks after the injection. Pre-serum aflibercept, a number of the patients continue until 8 weeks. So even after that, after they get the approval, they enter the Firefly next, which will be extension for this follow-up more to look after the safety of these medications. Just I want to mention the ICROB3. This is the most important maybe paper came for us to ROB last year. They mentioned here the reactivation, which when we use the anti-VEGF is higher, and the peripheral vascular area, which will be higher if we use the anti-VEGF. So according to this Taiwan study, they mentioned they look after the patient who received multi-medications. They found that the peripheral vascular area could be found from 50% to 100 of the patient who receive by the anti-VEGF. Then it related maybe to the dose, according to the which we found it in the rainbow study, or even the medication. So when you use the anti-VEGF, you put in mind if the baby, it could have continuous vascular area, you should follow up this. And for that, I think the most important thing when you treat other ROB to put the plan how you are going to look after this patient, where especially if you have like Dr. Arfan mentioned that sometimes the patient come as a visiting patient, not is already resident in this country. To conclude, it could be that 20% of adult dose, the ideal to use be in the ROB. Still, we are waiting the clear evidence. Earlier retreatment, earlier reactivation. Sorry about this. Earlier reactivation mostly will come with the low doses. Systemic safety for this medication is still under debate. We don't know a real because we are waiting still the 5 years, and we don't know. We can't just say that this is safe until we see clear evidence for that. Thank you for listening, and if there is any question, I am.
That's great, Hassan. Thank you very much for such a great scientific in-depth. It's really good to have a look at that. Now, I just had a comment, because the anti-VEGFs, they came out in 2005. They started with Macugen, and then they were using in diabetic macular edema, if you remember, Hassan. And then in 2009, people were just using it in ROP. So now, if you do the calculation, these kids, whoever are out there, they're like 14 years of age. It's been like 14 years. Now, it would be interesting to look at their other end organs. So retina is like an end organ. The blood vessels has an effect. If someone has a look at their kidneys, or probably their heart, probably we may see some kind of thinning and all that stuff. So, the only thing which worries me with the anti-VEGF, yeah, it's a fantastic treatment. It buys you time, and yeah, it reduces the effect of myopia. But I mean, what's going to happen to these kids, with our lifestyle changes, sedentary lifestyle, diabetes, hypertension coming in more? Are these kids developing? Are they going to develop strokes at an early age or not? So, and again, with the recurrence thing, So now my gold standard is whenever I do the injection, I make the laser a part of the treatment. I don't say that, yes, your baby will not need laser. I always include it. I tell them that we're going to do this. After a couple of weeks, we're going to have a look. There will be recurrence, and we'll finish off the treatment with the laser. Because if you do the first one, then they get confused. You say, oh, why are you doing it again? What happened again?
Yeah,
then you have to explain them the whole thing.
Yeah,
so this is my approach has changed now.
Yeah, but for us, yes, we know that before when the anti-VEGF came, there was conflicts. But when you see compare between the results between the zone 1 and the zone 1 aggressive ROB between the anti-VEGF and the laser, the superiority of the anti-VEGF is clear. visual visual acuity.
There's no doubt about that. You're
For
absolutely
us,
right.
we approve that the medication. Now our problem is the dose because the reactivation. For me, even before for me, it's holysynthesis. When you do the injection, recurrence laser with any zone. But when we look after patients who has aggressive ROB, when develop the recurrence after 7 weeks, when they will be in the zone 1, when you do the laser, the patient end by -8, -7, -5, depending on the patient when you do the laser. So we compulsory go for the re-injection in a few cases. And surprisingly, we found that there is babies, we re-inject them, they reach the zone 3 by the vessels. Even if you do the laser for them, it will be less myopia, less visual acuity. If you ask me, I think that going for lower doses, it could be the solution sometimes for us to avoid the safety, and it will be, then we can have the benefit of this medication if the patient has recurrence in zone 1 or zone 2 posterior. But if the patient zone 2 and 3, I don't even give the choice for the injection. Directly, I'll go for the laser. We don't discuss it with the patients. I don't know. I have I want to avoid missing the time. Can you please, we have the lecture from recorded lecture from Dr. Peter Campbell. Fatima?
Hi, my name is Pete Campbell. I'm an associate professor of ophthalmology in Portland, Oregon at the Oregon Health Science University. I'm sorry I couldn't be there live, but I'd like to present to you some of our group's work on artificial intelligence applications in retinopathy prematurity. This slide shows my acknowledgements and disclosures. In terms of acknowledgements, I work with a large group in the IROP Research Consortium, which was started by Michael Chang, and really privileged to work with this group of people. In terms of disclosures, some of the technology that we've developed in terms of AI algorithms and cameras, we are trying to bring to the bedside. And so we've started a company, which I'll tell you about later. So there is that conflict of interest to disclose. The history of ROP has changed over the last 100 years. And to summarize it quite quickly, we've moved from a disease of mild premature babies going blind to only really the most premature babies going blind in most high-income countries. That said, in many regions of the world where neonatal care continues to improve, we continue to have a large problem with oxygen exposure and with advanced ROP causing blindness, even in babies where it should be preventable. Every year, approximately 50,000 babies go blind around the world. Most of those cases could be prevented with timely diagnosis and appropriate treatment. When we talk about ROP blindness prevention, there's 3 levels of prevention. Primary prevention is reducing the incidence of disease, and that's primarily through improved neonatal care and oxygen monitoring. Secondary prevention is performed through ophthalmic ROP screening, either in person or via telemedicine. And then tertiary prevention is providing appropriate treatment when severe ROP is diagnosed. AI actually has applications at all 3 levels of prevention that I've talked about before. Today I'm going to focus primarily on secondary and tertiary prevention. Secondary prevention, again, is providing timely and accurate ROP screening. And so the question is, can AI be used to improve ROP screening, diagnosis, monitoring, or risk prediction? And what are the potential advantages of AI-based ROP screening? In other words, there are 2 potential use cases. One is in place of the ophthalmologist or improving the efficiency of the ophthalmologist in regions where there may not be enough providers. And then secondarily, in regions where there are enough providers, are there advantages to providing objective diagnosis by an AI algorithm? I just want to acknowledge that there have been several groups that have worked in this area, and each group has taken a slightly different approach to applying machine learning to ROP diagnosis. What I'm going to focus on today is what we call the IROP Deep Learning Vascular Severity Score. And that is, you take an image from a RetCam or another camera, get a vessel segmentation map, and you output a score from 1 to 9. 9 represents severe plus disease, 1 represents very normal and thin vessels. It turns out, we've known for a long time that as you develop more peripheral disease, you get more dilation and tortuosity in the posterior pole, as evidenced by this figure from 15 years ago in the UK ROP guidelines. When we looked at 5,000 ROP examinations, we found an association between the score provided by a single RetCam photograph in zone 1, and the corresponding stage and extent of disease in an eye. As a result, a single photograph providing a single score from 1 to 9 corresponds quite closely to the overall level of ROP in an eye. In other words, it's a surrogate for the overall level of disease. Higher in more posterior zone and higher with more stage and more extent of stage 3 disease. As a result, because it corresponds to the overall level of disease, as you follow eyes through ROP progression between, say, 30 and 40 weeks post-menstrual age, you see some eyes that progress and develop more stage, more extent of disease, and some eyes that don't progress. In fact, in a typical screening population, approximately 90% of eyes will not develop severe ROP or require treatment. These figures show in two different data sets the idea that we can follow eyes progressing either through the normal course of disease with spontaneous resolution or to the point where they need to be treated. The other thing that we noticed is that eyes that progress towards treatment requiring ROP do so before they need to be treated. That is, even at 32 and 33 weeks, eyes that progress and will eventually need treatment look different. That is, they have more dilation tortuosity than eyes that do not progress towards treatment requiring disease. And so we asked the question, could we use this sign of disease progression to identify progressors from non-progressors, with the idea that of creating a risk model that would improve the efficiency of ROP screening. On the right, you see symbolized 90% of babies don't require treatment or don't develop severe disease. Could we screen a much smaller pie, but identify all of those who develop severe disease and subject babies at low risk to fewer examinations? Work published in the journal Pediatrics by my colleague Aaron Coiner a few years ago demonstrated, based on a single examination, so a single photograph at 32 to 33 weeks post-menstrual age, and with knowledge of the gestational age, we were able to identify with 100% sensitivity eyes that were not progressing towards treatment requiring disease. That is, we didn't miss any babies who screened negative based on this risk model. In the two populations that we looked at, we found between 50 and 80% specificity. That is, eyes that screened positive could be followed closely for disease progression. But in concept, the vast majority of eyes could only need to be screened one time and then not subjected to further examinations, which reduces the stress to those babies and reduces the workload for the ophthalmologist. We evaluated this separately in low middle income countries. So in India, Nepal, and Mongolia, we trained a slightly different risk model, but the same concept. A single point in time, usually at around 3 weeks of life, identified a photograph and then knowledge of gestational age, and developed a new risk model, tested then in 3 separate populations, and again, did not miss any babies progressing to severe disease. And if applied with weekly examinations for positive screens, we could reduce by half the number of babies requiring screening in these populations without missing any babies with severe disease. Well, as you know, to do digital-based screening or telemedicine, you need a digital ROP camera, and these can be quite expensive, ranging from $50,000 to $150,000 US. We recently explored using some of the available smartphone adapters, the MII RetCam from MII RetCam made in India, and the MIO, which is made by Keeler, and trained technicians to take images in the back of babies' eyes. We then adapted an AI algorithm to use on these images and showed in this paper published a few months ago that in concept, this could work for AI-based ROP screening without an expensive digital fundus camera. So in summary, for secondary prevention, we've talked about how AI-assisted ROP screening could improve the efficiency, objectivity, and accuracy of ROP diagnosis, provide an earlier diagnosis of severe ROP, including aggressive posterior ROP, potentially reduce the number of examinations required, including in low-middle-income countries where it's most important. But there's a critical need, which is low-cost cameras. Smartphones may be able to help address that, but I think all of us really want a wide field, low cost camera. I'm going to transition now to talk about applications of artificial intelligence algorithms for tertiary prevention, that is providing consistent treatment and identification of complications. One of the most pressing issues in the days of anti-VEGF is identifying eyes that are going to recur or reactivate requiring treatment. There's nothing worse than providing effective treatment primarily and then have an eye go blind, which does happen. These are data published in JAMA Network Open, work with colleagues in Germany. Andreas Stahl was the senior author here. We looked in the CARE-ROP dataset at eyes treated with ranibizumab, who then reactivated. And on the right, you see eyes that were treated initially improved in vascular severity and then reactivated at some time later requiring retreatment. These data were independent of the clinical decision to treat, but the arrows indicate where the clinician decided to treat these babies, suggesting that eyes that are reactivating can be followed with a vascular severity score, and eyes that have a higher vascular severity score at baseline are more likely to reactivate early. So this has important implications for monitoring post-anti-VEGF. There's much more I could say, but for the sake of time, I'm going to stop there and just mention that for tertiary prevention, AI-assisted diagnosis could provide objective treatment thresholds and standardized treatment between clinicians. One thing I did not talk about today, but is an important problem in ROP, is the consistency of treatment, given that it's subjective. The second is it can identify treatment failure and reactivation. And in theory, in the future, and I didn't talk much about this today, AI could help us identify the most appropriate timing and or method of treatment to reduce adverse outcomes from ROP. So I'm going to transition now a little bit towards work that's being done in our lab with my colleague Yifan Jian here, looking at next generation ROP imaging devices. So on the left is a baby image taken with a RetCam, and you see by montaging it, you can see both the posterior pole and the peripheral disease, although it does get kind of hard to see towards the edge of the image. On the right is that same baby taken with an OCT camera. So this is an en-face OCT image that provides volumetric information and provides enhanced contrast of the vascular-avascular junction and the stage lesion seen there. Here are a few other examples. You can see on the left where you can see almost the entire vascularized region within one
Fatima or Soraya, can you just please stop the recording, because we want to take Dr. Mariam with us for the last presentation, please.
And provides volumetric information about the neovascular activity at the stage,
Soraya?
at the peripheral stage, and in theory can provide OCTA data in the future. And last, what I'm hoping to work on in the future is if we can adapt a smartphone to provide wide field imaging, that I think would be the holy grail, because then not only could we adapt AI algorithms, but we could provide a camera for every NICU in the world to improve screening coverage. Well, in the last few slides, I'd like to transition away from sort of academic research and focus more on practical barriers to implementation. The first 5 or so years of my career, I was focused on developing algorithms, developing imaging devices, and demonstrating
Hello, management. Sorry, please
can
you stop this presentation now?
Perspective
recording.
Really,
okay. Thank you.
Yeah. Thank you.
Dr. Hassan, can you unmute yourself, please? Unmute yourself. Nobody here.
Yeah.
Okay, now, okay.
You can hear me. Let me just welcome Dr. Mariam with us. Dr. Mariam Al-Fikki. She is from Cairo and from Egypt, Ain Shams University Social Consultant. She is a vitreoretinal surgeon and consultant. Dr. Mariam, now just if you can share you can hear me, yeah?
Yes, I can hear you.
Yeah. Please, can you just share your presentation with us?
Yes, and I'm so sorry for this inconvenience.
No problem, no problem. We can understand, no problem.
So yes, I will be sharing now. Share screen. No, not this one. I'm sorry, not this one. stop share. I'm sorry for this. Yes. Mama. Okay. Yes. Yes. Okay, so I will be speaking about ROP recurrence. So can you hear me? Yes?
Yes, we can.
Yes, ma'am, we can hear you.
Yeah, okay.
To start and understand what the meaning of ROP recurrence, we have to understand what is the regression. So regression of retinopathy prematurity post-treatment means that the plus regresses and the new vessels or the changes at the periphery also regresses. Like this case with laser, this is the baseline. We have extensive plus. This is after 1 month, the plus disease is decreasing. The new vessels also here are regressing. And finally, the fibrous tissue completely is separated from the retina. Can you see my cursor?
Yes, doctor, we can see.
Okay. So this is another case. Again, we have plus disease. We have a very high fibrovascular ridge here. And this is after 1 month. The vessels are not as engorged as before. And you can see that the fibrovascular proliferation regressed and has been separated from the surface of the retina. This is a picture when you are doing an injection. So after injection, by 1 week, you will have the plus disease also regressing, as we can see here, and then you will have progressive regression of plus disease and progressive vascularization of the retina. So if you are doing an injection, you need the blood vessels to grow further. This is the complete regression when the blood vessels reach the periphery of the retina. But if you have just regression of the plus and regression of the new vessels, which we can see here, and they have regressed over the next visits, this is incomplete regression. Complete regression means complete vascularization of the retina. So at any time when you don't have complete regression, you can have reactivation or recurrence of the pathology. This is another case, again, aggressive posterior retinopathy prematurity as baseline. At 1 week, plus is regressing, new vessels are disappearing, and then the vessels start to grow until you have near complete vascularization. This is still under observation. So reactivation happens more common with laser or with the intravitreal anti-VEGF. No, with the intravitreal anti-VEGF, because we have still a vascular retina, which can take up to like 6 or 7 months to completely vascularize. So at any time you can have reactivation of the disease. When would you have reactivation after laser? It will occur within 2 weeks to 1.5 months by maximum. Why? Because reactivation with laser happens because of one of two causes, which I will show later, which is either you have skip areas you did not treat. This is why the disease reactivated. So you have still a vascular retina that was missed in the primary treatment. And if you find this in the first follow-up visits and you treated, usually you would not have this reactivation. The second cause, which is the worst cause, is that the disease can be very posterior, very aggressive, with fibrovascular proliferations very extensive, that the pathology is you don't have just a VEGF high, you have a transforming growth factor beta. So when you give a treatment for the VEGF, which is the laser, it initially regresses, and then the transforming growth factor beta will take the upper hand, and you will find the retina is detaching. So this is in the very aggressive cases I will show later, not in the very early cases. Usually when you do laser in an early case, like the cases very beginning, it will completely regress, it will not reactivate. What about with the intravitreal anti-VEGF? If you are giving bevacizumab, the instance of reactivation is variable in the literature between 4 to 14%. Ranibizumab has a higher instance of reactivation. Aflibercept is the least. Why? Bevacizumab stays in the circulation for a very long time. That is why it will suppress the VEGF for a long duration, decreasing the instance that you will have a reactivation. Ranibizumab, the fastest to disappear from the circulation, and thus you will have a reactivation. Aflibercept will close multiple VEGF receptors. That's why it has the least instance of reactivation, and it has also a delayed response. So you will have the response maybe after 1 week or 2 weeks delayed, but you will have a long-standing response with the aflibercept. If you are giving an intravitreal anti-VEGF, as I said before, at any time you have still avascular retina, you can have a reactivation. Early reactivation happens between 1 month after the injection to 4 months after the injection, while the late reactivation can happen starting from 4 months up to 1 year after the injection if you still have avascular retina, and the postmenstrual age most active period is up to 60 weeks or 70 weeks postmenstrual age. Again, if you have more posterior pathology, instance of reactivation is higher. If you have more avascular retina, the instance of reactivation is higher. Now let us go to some cases. This is my first case. This is at the baseline, we have plus and we have new vessels. And after 1 week of the injection, the plus is regressing and the new vessels disappeared. And the last picture is after 1 month, and I have the vessels are growing further away, still avascular, but you have what we call persistent plus. This is different from the other eye of the same patient. I have plus disease, new vessels, ridge is high a little bit. I injected, this is after 1 week. The plus is regressing and the ridge is, the activation is decreasing. And then again, after 1 month, I have reactivation of the plus, it is increasing. So the first sign of reactivation or recurrence is that you will have the plus initially regressing and then starting to appear again. So you'll have to keep an eye on this patient. And also we have here new vessels at the old ridges. They are still there appearing, although that the vessels already crossed the ridge and they went to a further point. So you can have reactivation at the old ridge or you can have reactivation at the new ridge. This eye was injected and it went fine. This is the second case, an aggressive posterior ROP at the baseline, extensive ischemia. After injection, it went fine. And then after 7 weeks from the injection, I have re-plus again. And we have those small tufts of new vessels, which are like popcorns, but they actually are very red. So I decided to re-inject. And then it went fine. And again, after 2 months, I have again recurrence of the plus. And I'm sorry, I want to do this. And I have new vessels here over this area. And at this time, I had again to re-inject. So this eye was injected twice. And then after like when it reached 70 weeks or 60 weeks postmenstrual age, I still have a vascular retina. I decided to go for laser, and then I found this. There was still new vessels at this point, which I would call a late reactivation. This was actually not a new plus, it was the persistent plus. She always had a plus. When you have an extensive plus at the baseline, usually it stays, and we call it a persistent plus. This is my third case. This is a very interesting case. I have a bilateral aggressive posterior ROP at the baseline. So I injected, and this is the picture of the case after 1 month from the injection. I have the plus regressed OU, but still the avascular retina is extensive. Only thing happened that the plus disease regressed and the new vessels disappeared, but there's no vascularization whatsoever for up to 1 month. So another month later, I followed up the case, and I follow up weekly actually, but this, I take pictures when I have changes. I find that the plus disease started to reappear again. And actually in the right eye, I started to have here new vessels, as you can see. So I injected this one. This one had plus, but no new vessels. So it's not yet indicated for injection. So I followed up the other eye. And this is the picture after 1 week. The right eye completely regressed. And now I have full-blown picture of new vessels in the other eye, which is now for injection. And you can see that the plus also increased. Again, after, I think that was, sorry. So 1 week later, I have the regression in both eyes and everything is stable. And 2 months later, I still have reactivation, but in the form only of plus. I don't have actual new vessels, just small popcorn lesions. I decided to follow up weekly until after another month later, I have vascularization going further away. This area is query for me. I didn't know if this is new vessels or not, but the other eye is completely quiet. So I did a fluorescein. Yes, the left eye is completely quiet. The right eye have just those pinpoint lesions, or maybe they are small new vessels. So I just decided to follow up this case. And this is a picture after 1 month of a follow-up. And I have a stable picture in the right and the left eye slightly increasing these areas. And I'm planning to do a laser for this case because now we reached like 62 weeks and it's not vascularizing. So I'm planning to laser the rest. This is another case. We have this picture at the baseline, aggressive posterior ROP and a ridge 360 degrees vascularized, eye injected, and then this is the picture after 1 week plus regressed, and the new vessels are regressing. So now we are doing fine. After 2 weeks, I have this contraction of the fibrous tissue, which some of them either call it crunch or call this reactivation in the fibrous component. So we decided to do a vitrectomy, and this is the picture, 2 weeks post-lens sparing vitrectomy and 2 months post-lens sparing vitrectomy, and the traction is regressing. I think this is my last case. It's a case that was done outside, again, aggressive posterior ROP, extensive plus, and you have this fibrovascular proliferation 360 degrees around the central area. And the doctor who did him, he did him a very good laser over all the ischemic retina, no skip lesions. And then he had initial regression. He did not take photos of the initial regression after 1 week, but after 3 weeks, the patient presented with this picture, extensive recurrence of the plus disease and the fibrous component contracted, which we call it a crunch phenomena. And we did him again a lens sparing vitrectomy. He initially went fine, and again he recrunched after 2 weeks. So this is to summarize the idea of the reactivation. When you have a case that you did an injection or laser initially, and then you have an improvement of the picture, you will keep following up this case. I do the follow-up weekly until the vessels pass the mid-zone 2, and then I can start to increase the follow-up periods to 10 days and 2 weeks until we reach zone 3. So this is the first part. This this algorithm I got from a paper which is making a very good summary for how to manage those cases. So this is not mine. The second idea is you have an initial regression, the blood vessels, new vessels regressed, and the plus disease regressed, and then you have a reactivation. Reactivation also will start with a new plus disease. So you have a new plus disease developing. You will check the case. Either you have new vessels, just new vessels, and you don't have traction on the retina, so you can just re-inject. The injection was mentioned in the literature up to 4 times. I have cases I injected 4 times. That was my maximum, but there is one paper that mentioned that they re-injected the same case like 9 times, which is too much. And I will say why. Or either either it will go well after the re-injection, or you will find it worsening, or you will have a traction or something like this, so you will have to go for vitrectomy. But if you have the reactivation, as I said, showed in the last images, in the form of a traction on the retina, then you have to go for a vitrectomy. You cannot go for re-injection again. So you will go for a vitrectomy. What if you did a laser? If you did a laser for a case and you find that it is not completely regressing, first you have to check in the first follow-up visit that you don't have skip areas. If you have skip areas, you have to enter the patient again within this 2 to 3 days and do those skip areas, or you will have a reactivation. Or maybe no complete regression. The second, if you have initial traction, as you saw in my previous cases, that you have after the laser traction, you have to go for a vitrectomy. Don't wait, or the traction will cut the laser marks. So let us go back to why I don't like injecting a lot, or why the cases which we inject a lot will not do well, because injection every time delays the vascularization of the retina. So you will always have a persistent avascular retina. So if you are injecting a case 1 time, 2, and 3 times, and then you just passed like mid-zone 2 or something like that, you can laser the rest, because if you keep injecting, you will have settlement of the disease activity, but you have a persistent avascular retina that you will initially laser. So you should go just for laser now, not keep injecting and then go for laser later, because it will not vascularize from the repeated injection. Thank you. So this is the final of my presentation.
Thank you, Dr. Mariam, for valuable and excellent presentation. There is one question: which medication you are using in generally in your practice? Avastin or ranibizumab, which medication you use for the anti-VEGF?
So when I started doing the ROP, we had the Avastin abandoned already in Egypt because of a bout of endophthalmitis. So I did not try Avastin except once. It's it's tremendous. It's actually causes a very instantaneous effect, and in a very and it will stay for a long duration. What I'm used to use now is the ranibizumab. The ranibizumab is the effect may be a little bit delayed, so it will appear within 2 days, maximum 1 week in some cases, and usually they have a higher rate of recurrence. I did not try aflibercept actually.
But about the dose, generally, which dose you use for the
I use the half the adult dose. 0.625.
Yeah, for maybe for in the previous presentation we said that now the trend in the using for the anti-VEGF not go for prolonged exposure for the serum VEGF suppression. It's for less, like in the aflibercept they use the 20% of the adults, and in ranibizumab they use around the 20 or the 40. And the problem with the bevacizumab, they have to go even for lower doses to avoid any systemic effect for the medication.
So I tried once to lower the dose, and actually I had no regression of the disease after 1 week. So maybe I'm a little bit afraid to lower the dose, but I have a colleague who does this, Dr. Ahmed Abdelhadi here. He does the aflibercept, the 25% of the other dose actually, and he says it's good. But maybe my experience was not so good. It was an aggressive ROP case, and I injected, and after 1 week, I found no response. So I entered again and re-injected, and I did not try it again.
Because according to the Firefly, they use it 20%, and the recurrence are around 30%. But before they use the half dose, 1 milligram, and this is maybe it will be huge for the babies. So as the Avastin, when they use 625, they found the recurrence is less. But when they go for the lower, to avoid the systemic effect, they found the reactivation has become easier from that. And depending on the zone which they use indication. And in the end, I want to thank all our respectable speakers for the presentations. And I think now we have another symposium in this hall. I want to thank Dr. Arfan for presentation, Dr. Mariam to be with us.
Thank you, Dr. Mariam. Thank you.
Thank you so much.
Thank you, Dr. Mariam. Thank you.
Thank you so much.
Assalamu alaikum.
الو
السلام عليكم.
اسمعني دكتور.
سامعك دكتور احمد، سامعني انت؟
اخبارك كله تمام؟
الحمد لله.
انا حاسس ان الصوت بعيد شويه ولا عادي، لان عندي السماعه مش شغاله. ثواني. I want to best check my
الصوت عندي كامل.
الو.
الصوت تحس شوي بعيد، شوي صغير، تحتاج تزيده اكثر شوي.
ايوه بعيد. الميكروفون لا انا عندي، لانه المفروض انه انا
we can begin, Dr. Ahmed, or there is.
Sir, please you can, sir.
Hello.
Hello. Yes, sir, you can start, sir.
Fatima.
Check my best audio, لأن the audio is not working properly.
Dr. Ahmed, can just until you adjust the audio from your laptop. Today, Dr. Ahmed Al-Bar'i will present for us his experience in diabetic macular edema treatment, and he will give his experience in the medication. The symposium is sponsored by Novartis. Thank you for the invitation, and we hope it will be beneficial for everyone attend this symposium. It will be summarize the treatment and the difference between the two medication, comparing between the kite and kestrel study, which approved the rule of brolizumab compared by aflibercept and treatment diabetic macular edema. And Dr. Ahmed?
Hello?
I can hear you. I can hear you.
Okay, Dr.
Fatima or Shaira?
Yes, sir.
Should we be already? We are on. We are live, or we should begin now?
We are already live.
We are live. Yeah. Dr. Ahmed, already I introduced introduce you for the audience, and we about the symposium from Novartis. Thank them for the sponsoring, and stage for you now, please. Can you hear me?
Hello?
Dr.
Can you hear me? Can you
Yes,
hear me now?
I can hear you. I can hear you. Can you hear me?
Yes, now I can hear you.
Can you share your presentation, Dr. Ahmed?
Yes, sure.
Yeah, please. Already we introduced you to the audience, and I hope that.
Oh, okay.
Yeah.
So thank you, Dr. Hassan, and thank you for Novartis for inviting me today for this symposium. Today I'm going to share my experience with brolizumab in DMA cases. I'm going to share two cases. The first one, it was a resistant DMA. That's why I call it the journey. And the second one would be naive patient. So to start my first case, the patient is a young patient, actually 43 years old. He is male, and he's also in the same time PhD student, so you can expect a high visual requirements. Type 2 on insulin. HbA1c was fluctuate between 7 to 5, not that much controlled. Also, he is small but could smoke a couple of years, and he coming from complaining decreased vision in the left eye a few weeks ago. So, an examination, the visual acuity right eye was 20/20 and the left eye 20/80. Intraocular vision was normal, clear lens, and the retina showed that somehow severe number of diabetic retinopathy in the left eye with DME, and some really minimal number of diabetic retinopathy without DME. If you look at the fundus photo of the patient, the right eye, you can see almost normal, just few very small dots here. But in the left eye, you can see here the hard X-rays around the macula, which indicated significant macular edema. And also, if you look at the vessels, it's a bit tortuous compared to the other eye. So this is the OCT at the baseline. You can see in the left eye significant steroid macular edema with subretinal fluid also, and hard X-ray and other reflective dots there. In the left eye and the right eye was almost normal. So the plan, this patient actually has a long journey. So the journey started in 2015 and then to 2022, including the COVID in the middle. So I will show you now, this is just to highlight the journey of this patient, how it's goes. So he has a lot of no-shows, traveling to Spain in the middle to give another opinion, and then COVID happened, and this all the medication you use in the journey. So this is, as I told you, this is the baseline of the left eye. So when he came to us, we start with him ranibizumab. So we give him 3 monthly injection, and this is the image after 3 monthly injection. You can see that the subretinal fluid disappeared, but still we have big cyst here together with intraretinal fluid and some hard X there. So as I mentioned before, the patient was actually very, very anxious about the vision. So he go for no show for a few months. For sure, he was. I expect that he's looking for another opinion because he was expecting better improvement in the vision. So when he came back, actually I decided to do for him FFA. As you remember, if you look at the first image, fundus photo, there was some tortuosity of the blood vessel. So I want to highlight if there is any other coexisting pathology like impending vascular vein occlusion or something like that. But actually the FFA showed that there is nothing there. There is some focal leakage here. So we decided to do focal laser on this area just to fix. So 1 month post the focal laser, you can see that the subretinal fluid disappeared, and also, but still the cyst there and the intraretinal fluid there also. And then he go no show again for a few months, and then came back. So at that time we switch to aflibercept, since the results with ranibizumab was not that much. So we said we'll start with you a new medication, which is active at that time. So we give him 3 monthly injection of aflibercept, and you can see here still the same, no subretinal fluid, but still the cyst there and intraretinal fluid here and also there. So exactly, so the result or the outcome was not that good. Then the patient traveled to Spain, seeking for another second opinion there. And in Spain, he was received another injection of aflibercept, and he did also another session of focal laser 10 days only after the injection. When he came back to me, this was his image after focal laser again and one more injection of LA, almost the same, but you can see that the intraretinal fluid is switched from the nasal or the temporal side to the nasal side, but still the cyst there. So I tell him, okay, let's start with the full course of aflibercept again. So we give him a 4 monthly injection of aflibercept. And again, almost the same, still the big cyst in the middle, vision does not improve much, and intraretinal fluid. So at that time, we discussed with him that despite the age and the clear lens, we should try the dexamethasone implant or steroid, other family of the pharmacotherapy, to trying to get, hoping to get a better response. So after discussion with the patient, with the risk, everything, he agreed. So we give him Ozurdex, and this is 3 or 4 months after the first Ozurdex. You can see this is till now the best outcome till now in terms of resolution of the whole intraretinal fluid, except for some cystic change here, but the subretinal fluid is still there. So we discussed with the patient again that, okay, since is the best result we've achieved now, and the patient was actually say that the vision is improved. So I tell him we need, let's say, another injection of dexamethasone implant to complete the result or the outcome we reached. So we give another injection of dexamethasone implant, and this is 3 months after the second injection. So interestingly, the subretinal fluid disappeared, but the intraretinal fluid appeared again with this huge cyst again. Then the COVID happened, and the patient disappeared for a long time, a long period of time. And when he came back to the clinic, this was his OCT after this COVID. So almost exactly the same intraretinal cyst and the fovea and intraretinal fluid on the side, and the vision was not improving a lot. So I tell him, okay, let's start. He was hesitant again to actually to get another dexamethasone implant. So we decided to have another course of aflibercept. And he was committed actually in compliance. So we give him 5 monthly injection of aflibercept at the protocol. And this is how it looks after the fifth. This is the fifth injection. The cyst decreased, but still cystic changes in the fovea. So he was not too much happy about the vision. And this is 2 months post the last injection again, so it's almost increased. So at that time, we go back to the history. I tell him, okay, we have the best results so far with dexamethasone implants, so let's try another injection of dexamethasone implants. And patient agrees, and we give them another dexamethasone implant, and this is 3 months post the third dexamethasone implant. And you can see here again, the cyst is not there, but there is a cystoid changes here and intraretinal fluid. And the result was not as expected. So actually we stuck at that point. So we tried again, let's go back for the first medication we used, maybe it can work now. There's no basis for that, but we tried all the available pharmacotherapy in our hand at the time. So we gave him another just 2 injections of ranibizumab monthly, and this is 1 month post the second injection, which is not improved at all, just a changing the morphology of the edema, but the edema never goes away. Then at that time, we disappeared for a long time, and when we came back this 6 months later, you can see this is the image without any medication, still almost the same. So, but at that time, the pembrolizumab was available. So we discussed with him that we have a new medication. Let's try it, since we tried all the pharmacotherapy we have and no problem. Let's try the medication. And I didn't give actually a big hope for him because it seemed one of the most resistant diabetic macular edema. So regardless of the medication you use, it might not be the outcome might not be good as you expected, and the patient also. we start with him with the first intravitreal pembrolizumab, and this is just 1 month after the first injection. Vision actually improved, and the edema start to resolve. And if you look here, this is the first time we can have just the reconstruction again of the foveal contour, starting the foveal contour to appear again. So we go ahead with the second one. This is 1 month again. The foveal contour is more intact, still some edema there, but the central cysts disappear, and then the vision improved to 20/30. And after the third injection, as you can see here, the vision improved more. The foveal contour become more anatomical, and also the retinal fluid disappeared, just blue fluid here, but still no edema. The thickness of the macula was okay, so the vision improved. And actually, this is the best result we have got. And this patient now is in, we are extending him on pembrolizumab, but he disappeared, but I think he was okay. So this first case was very resistant diabetic macular edema, and this gave me the trust of that if you have a drug that work in resistant cases, I think I told myself, let's try it in a naive patient and see how it works. Because as you know, for any new drugs came in the market, usually most of us, or let me talk about myself, usually I use it first as a second line. So I use for the look for the resistant cases, and I try to use this new indication to check how the efficacy of the drug. But this is not, I think it's not the proper way to judge a drug, a new drug, because you know in the trial they choose all the patients should be naive. So really, if you really want to test the efficacy of any new drug, you should try it on a naive patient. You can try it in resistant cases, but if it does not work, does not mean the drug is not good or not efficient enough, because this is maybe related to the pathology of the disease on this specific patient. So when I came new patient who's new patient DME, fresh patient never received any injection before, like this patient, I tried the pembrolizumab with this patient and see how it worked. So this old man, 65 years old, a lot of comorbidity, cardiac hypertension, and also some decrease of both vision more in the right eye. Like 1 month ago, he never, as I told you, received any treatment, either laser or injection in the eye. So his first time to complain about his eye since he's diabetic. In the visual acuity, the right eye was 20/50, the left eye 20/30. Pressure is normal. He did cataract in both eyes. And if you look at the OCT of the right eye, you can see here cystoid macular edema, typical form with subretinal fluid there. And in the left eye, you have the cystic changes also, but not like the right eye. It's partially involved in the fovea. So the plan, we decided that I might go for the right eye, which has more edema. I will try intravitreal pembrolizumab, and after 1 week, I give him the left eye ranibizumab, because it's still very minimal edema. So that's my plan. So the patient received 1 injection in the right eye of pembrolizumab, and he asked me to come for the next week to receive the injection in the left eye, which will be ranibizumab. So he received the injection, and he came 1 week for the left eye. But when he came, they did for him OCT. As a routine, any patient come to our clinic, usually for injection, he has to do OCT. No, in this patient, actually, he shouldn't do that because he already booked for injection, but he did OCT for him. So let's see how it looks like after 1 week only of the injection in the right eye. This is how it looks like after injection in the right eye. So 1 week, you have all the edema disappeared, fovea contour reconstructed again, restored again, but very minimal subretinal, and the vision improved greatly to 20/25. Just to show you, this is how it looks like 1 week ago in the right eye. But what more interesting for me actually is the left eye. If you look at the left eye after 1 week injection in the right eye, you can see here the small cystic in the left disappeared completely, and the vision back to normal. Actually, and I did the patient was happy about the vision, and actually I didn't give the injection for him. The planned one I canceled. And I know that most of us know about the effect of anti-VEGF in the fellow eye. There is this is how it looks like before injection 1 week ago in the left eye. So there is just contralateral or effects of the anti-VEGF on the fellow eye. You know that there is some study about the effect of anti-VEGF on the fellow eye, like this study in juvenile retinal disease. they are noticed that if you inject one eye with, regardless the anti-VEGF are going to use, it have some effects on the fellow eye. And another eye also with ranibizumab in eye also show that in this was in Avastin, it showed that injection of one eye could have effect on the fellow eye, but it's never been tested for sure in ranibizumab. But it's a common, I don't know, we can open discussion with Dr. Hassan if you have seen this before or not, but this was an interesting case. So the patient is now eligible for another injection after 6 weeks in the right eye. And I will keep eye on the left eye. I see how it's worked. Does it need injection or recurrent edema or not? So maybe in the next coming meeting, we can discuss this and then show what happened in this case. Thank you so much for your attention. Thank you.
Thank you, Dr. Ahmed. Thank you for the really very interesting cases and many lessons can we learn from this really. That's how it looked like. From the first case, I like how is that the patient got the foveal contour in spite of the use few medication and the vision improved. So using the new medication, maybe for us sometimes we are worried about using this medication. Generally, how you choose the patient for like the brolizumab, which they are in the diabetes, because in diabetes maybe the for the even through the studies that there is, if you compare, there is no intraocular inflammation which come for this medication, the AMD. So generally, how you practice for the diabetic macular edema? If you are going, because even in the second case, you approve for us that you use this medication, you touch the two eyes by one injection. This is something very interesting for me, really. So for you, when you choose the patient for the brolizumab, how you can advise us to look after what, or we can use it for any patient and.
You know, yes, thank you. I think, as I mentioned, usually if you have a new drug, usually we, whatever I'm doing at the beginning, I use it as a second line usually. So I wait for the other drug. That's what happened in the AMD. I start using the brolizumab as a second line or a third line after using the other anti-VEGF, and just working, I switch. And when I find the switch, the switching to brolizumab in AMD, it was have a better response. So now I build my confidence. Now I'm using brolizumab as a first line in AMD. DME, it was the same. I start with resistant cases. As you mentioned, there was some, I know most of the people concerned about the safety profile, but if you look at the DME studies, Kite and Kestrel, the overall inflammation rate was not that high. So it's a bit, the safety profile was much more better. So it gave me more confidence. So I started with the resistant cases, and then I will find the results. So I said, as I told you, as I said in my cases, that why not trying in the first line in naive patients? I think this is the best candidate to judge any drug. I'm talking about generally, not about brolizumab. If you really want to study the efficacy of any drug, you should give the best atmosphere, let's say that. So it should be the naive patient, controlled diabetes, like in the trial. So as long as work in the resistant cases, I was expecting to work better in the naive patients. So, and that's what's happening in the next year. And I think by time we are going to learn more and more and see the efficacy in our practice.
There is Dr. Ahmed, you opened something for me when you said that in the AMD, I will give him the first choice. I remember the first case, I used the brolizumab. Really, I don't discuss with the patient. The patient was visiting one doctor in the private, and he told him that he has polypoidal choroidopathy and diagnosed by the Indocyanine. He said for him, you are for the brolizumab. So when the patient visit me in the hospital, even we don't discuss the others, we don't discuss anything for him. He said, doctor, if we can get this medication. And really, the patient has a huge subretinal hemorrhage, BED, and intraretinal fluid. And from the first injection, you find that he become 0.7. Then the patient, after the third injection, he received 1. So in the AMD, in the diabetes, and for us, we have chronic cases. We try the brolizumab. Before we try many injections, but I think the brolizumab need to use the 5 loading dose, because we have one patient we use for her maybe steroids in spite of the other anti-VEGFs. But after the 4th injection for brolizumab, we found that there is beginning of response, because this is a chronic case was. For me, still diabetes because issue of logistic issue in the hospital. Sometimes you can't get the medication as you want. About when we use the brolizumab, there is now they said the efficacy for the subretinal fluid or intraretinal fluid. From your practice or from your even cases, you found that the medication is very nice in the subretinal and intraretinal. When we compare it by the other medications, especially on the kite crystal, they approve even in the late. They say that according to the study, from the 32 weeks when you use the medication until 52, it's better than the aflibercept and the intraretinal fluid, subretinal fluid when you use this medication. Not just as for us in the acute or in the primary loading dose, even in the late, you can notice in the beginning sometimes head-to-head these medications together, but maybe after post 32 weeks, you found this medication is better than the aflibercept and the subretinal fluid and intraretinal fluid.
Yeah, I think from the evidence-based medicine, based on the trial you have mentioned, and there is another independent trial, not sponsored by the company. I think it's also check the efficacy of it was a head-to-head trial. I think it was published in Eye, and it looked at the efficacy of the drug on subretinal each compartment. They separate each compartment, intraretinal, subretinal, and sub-RP, and I'm talking about the MD also. And you look each compartment which drug works better, and they found that and also they use artificial intelligence to analyze the data, and they found that yes, it's have a higher upper hand on all compartments, and specifically in the sub-RP, which is the most resistant one. Second is sub-RP. So in my practice, I've seen the efficacy of the drug generally. Yes, it's especially in AMD, it's a very, very good effect on the sub-RP and subretinal fluid. In DME, as I show you in my cases, yes, it has effects. All other drugs does not work, even the focal laser. But again, I want to highlight that we don't have, till now, it's my opinion, pure opinion, that we don't have magical weapon that can fit in all our cases. We were going to face a case that does not respond even to brolizumab or another medication, because the pathology is different from patient to patient, and also the level of control blood sugar, the other comorbidities. So we have, but at the end of the day, you build up your experience with the drug, and after a proper time, you can judge properly which one is the best, and you can choose which one is first line and second line, depending on your personal practice.
Dr. Ahmed, generally when you use the medication and treat and extend, because I know that in diabetes, you generally use treat and extend. Yeah. And when they compare between the medications, and according to the approval for the brolizumab, and they mentioned around more than 50% of the patients who got the loading dose, they receive going to be on the every 3-month injection. Generally, when you extend, how you extend in real life, because sometimes the real life different than the. Yes. And this is one of the points which brolizumab was better than the other anti-VEGF in the approval study.
Actually, what I like more about the loading dose in DME in brolizumab, it's not every month; it's every 6 weeks. So it gives me that's like more confident about the durability of the drug. So because not like other study that it's given monthly. So they give him every 6 weeks, not monthly. But personally, I start treating and extend.
I can't hear you. Can you hear me?
You can hear me now? Can you hear me? Hello?
Yes, sir, we can hear you, sir.
Can hear you.
Yeah, now we can hear you, Dr. Ahmed.
Okay.
Now we can.
What I'm saying that in real practice, I start extending after complete drying of the macula. I will not wait for 5 or 4. If it is dry after the 3rd injection, I start directly. Like what happened in my last case. My last case with the patient, he's almost dry after 1 week of the first injection. So I was expecting when I see him on the next injection, it could be dry. So it's very early dryness. So I cannot give him a full monthly, not monthly, a 5 loading dose every 6 weeks. So if the patient responds well from the beginning and the dry macula vision is normal, I can see there's no point to load him more. Just try and extend it from now, because the main aim of treat and extend is to have a dry macula with the least number of injection, especially in the first year. So if this happened before the 5 loading dose, I can start extending from now. If this, I hope you're answering the question. It's not, yeah, the study is okay, but the real life is different.
And the follow-up, you know, when you treat and the follow-up, you give the patient every 6 weeks, then you find him that's dry. You give him next appointment after 6 weeks or generally 8 weeks. How you, if he's dry?
Usually I extend by 2 weeks only, not more than that, until I reach the moment that start the fluid to recur. So this patient will be dry for 3 months or 12 weeks, whatever. So I extend just we step 2 weeks by 2 weeks, not big. I got it for next month. No, just 2 weeks by 2 weeks.
About the inflammatory reaction for this medication, which were reported in diabetes, according to the study QOIC Kestrel, the percentage of the intraocular inflammation or even retinal vasculitis was less. And maybe because this is for the nature of the disease, diabetes, most of the patients, they receive the metformin, and this medication always have reduced the inflammatory reaction according to the literature. I don't know, maybe even the medication is different, because there is difference between QOIC and Kestrel. They said depending on the patients. For you, that generally, if the patient did receive the first injection, did you are looking for this? How generally you try to keep follow up regularly? There is no worry as after the injection you see him regularly after 6 weeks, or
yes,
put him after the loading dose?
Yeah, at the beginning, very early beginning, when the drug launched, there was a concern about the safety in AMD at that time. So there was some recommendation that you bring the patient 1 week after injection to check for any vascular sheathing or vasculitis or something with inflammation. I was doing that at the beginning, but by time you start to know, okay, I just instruct the patient, if you have any pain or any floaters, any decreased vision, you can come anytime. But if nothing happened, just come to the next injection, next visit.
The same for us, Dr. Ahmed. When we use the medication, the first we was about that, we bring him the first week. Then now the patient receives the medication, we see him after the second, maybe after the injection, before the second dose, just to document the response.
And for now, talking about our local experience with safety, we in my hospital, actually, we are now, I don't know exactly the number of injection, but it's for DME, for example, now we have more than 150 vial, not patient injection, and maybe almost the same in AMD, or a bit lesser amount, but I don't have the exact number, but it's range about this figure. We don't have any single case of inflammation. So that's also by time, as I told you, you get some confidence by time and by practice. And I know also one of my colleagues that he have some patient that he developed some vascular sheathing, not vasculitis, not affecting the vision, and he's still using the medicine because the efficacy actually. I think there's no doubt about the efficacy. The drying effect is really very evident.
In spite of this, maybe this is the smallest molecular available. I think the half-life of this medication is the longest. The half-life of this medication until now is the longest. So this is give the chance for treat and extend. Even as you said, that the patient will receive the injection every 6 weeks. This is something for us really give us.
But what about your experience, Hassan, with the drug in DME? Because you already know about DME.
Yeah, for us,
agree with me, but
we use this medication for mostly, as you said, in the beginning, we use it for around 4 or 5 patients who was weak responder or respond is not well. And for us,
cases,
really fantastic case. Even it was in the beginning, maybe that we worry about the medication, but when we practice in diabetes, we encourage now to use it. Even as you said, we wanted to compare this medication by the others and naive patients, especially through our practice. Maybe we have one patient of AMD. I will not speak the DME now. We have one patient in the AMD. He's supposed to receive another anti-VEGF. Then we explain for this medication, and the patient's refused to get the medication when you speak of that there's some chance that some inflammatory reaction. So he received another medication in the market, and the patient developed bilateral uveitis in both eyes in spite of he used other medication. So from that we noticed that the inflammatory reaction can happen in any one of these medication, and for us this is give us maybe encourage us to use it more in the diabetes. Until now we use around 40 vial, I think 6 patients until now we use it, and we hope that we will try it and more naive patients. We hope this medication, because for us, at least as all according to the study, this is give you better dryness and lower number of injection, longest maybe treat and extend more than 50 patients. They will receive it every 3 months, and it will be better for burden.
Can you conclude, please, the sessions? We are already
done.
Okay.
Yeah, I want to thank Dr. Ahmed, and I hope it was the information valuable for everyone. And see you later, inshallah, Dr. Ahmed. Thank you.
Thank you, Dr. Muhammad. Thank you for all. Hope to see you soon. inshallah. Dr. Muhammad Al-Amri.
Thank you, Dr. Muhammad.
دكتور احمد
وحشني
حبيبي
كثير والله، وحشني كثير.
والله انت وحشني بس مبتعد عني. يلا نشوفك عن قريب.
نشوفك اكيد ان شاء الله حبيبي. شكرا.
السلام عليكم.
مع السلامه.
Feeling better automatically in the first 1 to 3
دكتور مجدي سامع.
Take more time to talk about iatrogenic dry eye. This is just a representation of how we use diagnosis. And accused vision.
دكتور مجدي ممكن انا انت مش connecting to audio. You are still not connecting to audio. Okay, connect again.
Take-home messages: dry eye disease, the complex multifactorial medical condition, the understanding of the fundamentals of dry eye disease, to diagnose tests are needed to evaluate some aspect of the disease, such as, for example, the presence of nerve dysfunction, and individual patients should be subcategorized in terms of
ولا انا سامعك انت الان برضه لسه مش مسموع. خلينا لحظه شوي، خليني اشوف هاي. لا 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 خلاص اوريدي مش شغاله. تمام. دكتور مجدي سامعني؟ Okay, can we conclude please, Dr. Karina? Thank you very much. Thank you very much, Dr. Karina. Okay. أسامة الناس منتظرين. اوكي. It will take 2 minutes. Okay. Shall I ask them to start? Okay. Okay. دكتور مجدي ممكن تسمعني؟ أنا مش سامعك. دكتور مجدي. أنا مش سامعك. دكتور أمين سامعني؟
ايه صديقي سامعنا كثير كويس.
اوكي دكتور. الآن سامعنك. اوكي. خلاص دكتور مجدي you can start please. The mic with you please. The session
just a second. Because can you hear me now? No, you cannot.
Yes, we can hear you, Doctor. You can go ahead, please.
Using the AirPods to filter the voice. If not, I will cancel the AirPods. Can you hear me now?
We can hear you, Dr. Majdi. You can start, please.
Okay. Do we have Dr. Amin with us? Dr. Fahd is not there yet, right?
I'm here now, inshallah. I'm joining.
Okay.
I've joined.
Okay. Thank you, Dr. Muhammad, for the kind invitation for the CUSME international meeting. Today, I have the pleasure to moderate the imaging session, which will be presented by Dr. Fahd Kohail from Moorfield Eye Hospital, United Arab Emirates, Dr. Amir Marashi from Syria, me, myself, Magdi Musa from Egypt, and Dr. Patricio from Spain, and I think he will join us soon, if he's not joining us already. Shall we start by the first presentation, please?
Okay, I think I am the
Amin,
first speaker. Yes.
Yes, please.
See my screen right now?
Yes, we can see it. It's good.
Okay, very nice. I will start. My presentation is not long. It's relatively short. It's not a mystery. It's more like an interesting case. It's a 67 years old phakic lady known to be hypertensive. And her intraocular pressure is in both eyes 17. Her best corrected visual acuity in the right eye is counting fingers, in the other eye is hand motion, and this segment unremarkable for both eyes. However, the fundus examination on the right eye, I saw an old laser burns along the inferior retinal vein that is a bit dilated with blunt foveal reflex. The left eye shows thinning of both retinal arteries, and retinal tissue at the macular area looks relatively thin. Patients reports history of retinal vein occlusion in right eye and being treated with a laser 1 year ago, but the other eye, which is the left eye, she said that she's been diagnosed by retinal artery occlusion. So by looking at the fundus fluorescein angiogram, we can see how the right eye, we have a slight delayed venous filling in the inferior arcade with the laser marks and leakage at the area of the macula with small window defect. However, the left eye shows us only ischemic changes and non-perfusion at the center of the macula. So when looking at the OCT, we can see the right eye shows a lamellar hole that with intraretinal cystic changes that simulates somehow a burst of a retinal cyst that being not treated adequately. On the other hand, the other eye shows us a thinning of the inner retinal layers, which makes sense with the fundus fluorescein angiography, the ischemic macula. So After consulting the patient of a possible treatment, I offered her to do a suprachoroidal injection of triamcinolone because simply I was a bit afraid of interfering with the vitreal macular interface because of this ruptured cyst. So I told her, let's go for the suprachoroidal triamcinolone and let's see the results. Well, this is 8 weeks post the injection. The vision has improved to 2100. Then after 16 weeks, there was a small cyst developing, but no changes on the best corrected visual acuity. So I didn't treat. The same after 20 weeks. The cyst still there, no changes on the vision. However, at the 32 weeks post injection, she came with reduced vision to 2300, and there was again cystoid macular edema. But please, if you pay attention, you will see that the OCT scan has reduced in quality. Thus, because the patient developed a posterior subcapsular cataract. This is 8 weeks after the injection. And you can see not only there was the lamellar hole, there was a small areas of photoreceptor defects as presented here and here. So the results of treatment and follow-up were improved of vision because she restored the vision of 2100 after the second injection. No intraocular pressure spikes was registered during follow-up, and there was a formation of posterior subcapsular cataract. So my take-home message is lamellar hole can be due to neglected cystoid macular edema treatment. We all know that, but we always form our thinking toward a traction or a tangential traction or degenerative reasons. But the neglected cystoid macular edema can form this burst cyst. The treatment attempts can be tried after patient consultation, as this patient has improved vision from counting figures to 2100. The suprachoroidal route can be promising route of treatment, and it won't let us worry about the interfering with the vitreomacular interface. The suprachoroidal injection here helped to resolve the cyst and can be repeated safely. Still, cataracts and increased intraocular pressure should be kept in mind, but they are more in a predictable manner. Now, I just want to ask the panel here their opinion about the real pathology of the underlying the left eye. Is it retinal artery occlusion? Personally, I think the patient is only an old ischemic retinal vein occlusion. So thank you very much.
Thank you, Dr. Amin, for the nice case. So your message is you can use the triamcinolone suprachoroidal in cases with lamellar macular hole, just in case if you use anti-VEGF, it might increase the traction. But in this case, your diagnosis was lamellar hole with a rupture cyst or due to epiretinal membrane?
No, due to rupture cyst.
Rupture cyst. So if it's a rupture cyst, is it still safe to use anti-VEGF or it's better to use steroids?
For me, I was afraid. But I think the suprachoroidal route showed us that it was an effective and safe method. But personally, I don't have an experience with a burst cyst and the usage of anti-VEGF.
Yes, I have some kind of experience when cases doesn't really show an epiretinal membrane or any traction. Intravitreal anti-VEGF is not contraindicated, but once we can see that the hole is due to tangential traction, this is very unusual to use anti-VEGF. But still, anti-VEGF can do some of the improvement, as you showed us with the triamcinolone. The problem is with triamcinolone is you develop cataract, as you showed us, and sooner or later she will need a cataract extraction. But again, the message is good. If you are, not sure of the diagnosis, if there is any epiretinal membrane, we should start using triamcinolone. And the other eye, you said
Yes.
it's a central retinal vein occlusion, ischemic type. But again, if it's a ischemic type, would it be hand motion? You said hand motion in the other eye, right?
Yes, yes.
And
Because the
still
macula
debating.
is
It's very thin. I've seen that. It's very thin. It could be combined artery and vein because hand motion is a very, very low vision. Even in ischemic RVO,
maybe.
sometimes you get counting finger. Sometimes you still end up with a counting finger. But anyhow, it sounds like the vascular element or the ischemic element in this case is very, very high. So it's a good choice to use triamcinolone and prepare the patient for the complication like cataract, which can be done later on. Thank you so much, Dr. Amin, for this nice case. Any question from Dr. Fahd or any of the panelists?
No, just if Dr. Amin could let us know how he goes about making the needle for the suprachoroidal. People want to consider it.
It's very easy. It's just you can do what method you want. The principle only letting 1,000 microns of the 30 gauge needle out from the out and be utilized for injection. I developed my own stopper. It's a combined from the rubber of the plunger of the insulin injector and the head of the lower lip. So I combine them together and I just insert the needle, letting only 1,000 micron out. I remove it. Then I, after sterilizing it with the steam, I inject. Then I remove the 30 gauge needle. I insert another one. Then I send it again back to the steam sterilization and I can use it as a fresh. If you are interested, I can send you a full video how to manufacture it on WhatsApp later.
I really appreciate that. Thank you very much.
You're most welcome.
Thank you, Dr. Amin, again for the this case presentation with a very good message. Shall we move to the next presentation? Dr. Fahd Kohil from Morpheed Eye Hospital, United Arab Emirates. Please, Dr. Fahd. I can't hear you, Dr. Fahd. Can you hear me? Dr. Amin, can you hear Dr. Fahd?
Sorry, can you hear me now?
Yes, now I can hear.
I do apologize. So I'll start the presentation again.
Please, please.
This is an interesting case that I came across when I was back in the UK. A 37-year-old female who presented with a 2 to 3 month history of persistent photopsia within the infranasal field of the left eye with associated unilateral nyctalopia. So she volunteered all this herself with a previous history of blunt ocular trauma in the left eye 18 to 19 years earlier. She was otherwise fit and well with no other relevant ocular history. And as you can see, the fundus looks to be pretty normal, except in the supratemporal area. You can see there's a significant area of chororetinal atrophy. And this is where she was saying that she was experiencing the flashing lights. The right eye was healthy. And this was her Goldman visual field. So the right eye was full, but the left eye had this area of infranasal scotoma, which kind of corresponds with the supratemporal change in her left eye. And this was her electrophysiology. So this was the electrophysiology from the right eye. And so on the left-hand side of the screen is the right side traces, and on the right side are the left eye traces. So on the right side, you've got normal A wave and B wave, but on the left side, you've got a reduced B wave, which kind of gives you, so the photoreceptors are okay, but there's a problem with the transmission of information across the inner retina. And then when you, in the bright flash ERG, again, on the right-hand side is, on the left-hand side is the right eye. So the A wave and B wave is intact, but on the left eye, The photoreceptors are okay, but again, the B wave amplitude is slightly reduced, which means there's an issue with the inner retinal transmission. So it suggests that there is some form of retinopathy in that left eye, even though the biomicroscopy looked to be normal, the color fundus looked to be normal, apart from the scar in the supratemporal area. However, the patient was complaining of flashing lights. So how am I going to identify the problem? And again, the patient had the light adapted ERGs. Again, there was a slight increase in the amplitude. The pattern ERG was normal, which is to be expected. So you have somebody complaining of symptoms in the left eye. They're photopsia, so sounds retinal. There is a rod cone dysfunction in the left eye, but no evidence of maculopathy with a normal pattern ERG. OCT was normal. So what's helped us, and then we did an OCT through this area of scarring, and as you can see, the retina is very, very thin. But what helped us really crack the diagnosis about what may be going on with this patient was the autofluorescence. So when you start capturing the autofluorescence, you start noticing that there's increased autofluorescence in the supratemporal area. And that's because the retina in this area has lost some of the pigments. So you're getting increased transmission of the RPE autofluorescence. And as you can see, that increased autofluorescence extends all the way to where the scar was. And so therefore, there is some kind of focal retinopathy there that's extending towards the scar, which is not evident in her right eye with normal autofluorescence. So we concluded that this was actually some form of autoimmune retinopathy. For whatever reason, it took 20 years to manifest. And that blunt trauma was so severe that it led to chororetinal atrophy. But for some reason, 20 years later, she manifested with symptoms of an autoimmune retinopathy. But because the visual field defect was stable, because it was just symptoms of flashing lights that would be self-limiting and resolve, we didn't offer any treatment because we didn't think there was any threat to a vision function. However, if it was progressive, I may have considered systemic immunosuppression in this case, but the patient is still aware of nyctalopia. And then this is, once the flashing light settled down, we repeated the autofluorescence in that area, and as you can see, the autofluorescence is normalized. So the reason why I just shared this case, because I think it's kind of an interesting, autofluorescence sign, and just wondered whether, Magdi, you had seen this in some cases of autoimmune retinopathy, and really autofluorescence for me was what cracked the case. So we knew the symptoms was retinopathy. We could see evidence of OCT damage. We saw the visual field loss. But what really helped us pinpoint that this was retinal was the autofluorescence. So we didn't feel like we need to start investigating with a CT scan or an MRI to exclude a space-occupying lesion. I felt it was a nice, elegant way of really localizing the problem to the retina, so we didn't have to start thinking about neurological causes for this case. Okay, we didn't treat it, but it was a very interesting autofluorescence sign.
Thank you, Dr. Fahd, for this nice case. Let me chat with you. I like the case. I mean, fundus autofluorescence is one of the easy, simple, non-invasive way of detecting many lesions and it's I consider it the forgotten frontier. Sometimes we forget about fundus autofluorescence, and we have to do fluorescein, OCT, fundus examination, color, and everything, and we forget about fundus autofluorescence. But let me ask you, if it's an autoimmune disease, would it be only unilateral?
Yeah, so in this particular situation, my thoughts were, for whatever reason, because she had trauma in that eye many years ago.
Yes.
And for whatever reason, she became sensitized to it, but just in that area. What caused it, what triggered it, I have no idea. But it was really bothering to her, and it was always bothersome. So she'd come into our eye emergency department because these flashing lights were absolutely persistent. And the autofluorescence would only appear when she had an episode of flashing lights. And then it would subside, and then a few months later, it would recur again. And because it became frequent, I was wondering whether we need to consider systemic immunosuppression. But because the visual field defect didn't get worse, her ERG didn't get worse. In the end, I just said, look, it's annoying. Yes, I could give you steroid, but with all these things, it's a risk-benefit decision, isn't it? And if it's just annoying flashing lights, which are self-limiting, but that's why I thought it was autoimmune. But I think what would have clinched it is if I'd given a steroid challenge and it completely settled it, then I could be confident this is autoimmune mechanism. But that was my suspicion. Can you think of any other mechanism? Can you think of any other mechanism?
Let me chat with you. I like the case. I like the case very much, and I'm still, brainstorming with myself while you are speaking. I like the case. Let me ask you. We consider flashes of light. Traction on the photoreceptor, right? This is the explanation of photopsia, right?
Yes.
So in this case, there is no vitreal element. There is no vitreoretinal traction of any kind, right? There was no.
Yes. Correct. And her flashing lights were not like the PVD flashing light. It's the starry, it's more of the starry type of flashing light that you get with bird shots or you get with.
Yes.
So it was more of a.
This is my question. This is my question because photopsia or flashes of light is completely different from what you're saying. It looks like the migraine one. I mean, like it could be like bright light, like, annoying light, like photopsia due to severe light stimulation. It could be. But I think, in my opinion, I think trauma has triggered this because in the lesion, in the peripheral lesion you showed us, there is atrophy and hypertrophy. So it means there is RPE migration, could be RPE moving into the circulation. It could be sensitization to the RPE because it's an extensive mottling. It's not only atrophy. It is the trauma which causes migration of the RPE, and this migration of the RPE can pass to the circulation. It might irritate the or start the autoimmune process. So the trauma has triggered this probably, and it could be due to the trauma itself migrating the RPE, causing sensitization to the RPE, attacking the normal RPE in the same eye. It could be.
Yes. And it's a kind of a very mild form of sympathetic, but thankfully, never quite got to the point where she gets significant inflammation that you need to intervene. But at one point I was battling because she was really annoyed by it. But I'm grateful that I not calmed down, but because I wasn't sure about the risk-benefit ratio, risk-benefit analysis for her, I actually got a second opinion with one of my other uveitis colleagues, and he was very clear. Look, it's annoying, but there's no loss of function. There's no progressive loss of function. So the side effects from the immunosuppression is far greater than the side effects of the disease. And I think that's a good way. Whenever you're making a decision about treating any disease, what is the risk of observation versus the risk of treatment? And if the risk of treatment is greater than the risk of observation, which is like in this case, then better to leave her alone and just reassure her that it will be self-limiting. And just fascinating that when the flashing light stopped, the autofluorescence normalized. And when the flashing lights recurred, she would get this hyperfluorescent pattern. And I was quite puzzled about the mechanism. So I actually discussed it with Giovanni Starenghi at one of the meetings a few years ago. And his feeling was because you've got in photoreceptor activation or whatever, you're reducing the level of pigment in the level of the photoreceptor. So you're allowing greater transmission of the RPE fluorescence.
Yes.
And then, but who knows? A fascinating case. And it's the one and only for me. I've seen many cases of autoimmune retinopathy, but only one of these cases with this very interesting autofluorescence pattern.
Yeah, it's another explanation of the stressed RPE, because hyperautofluorescence means stressed RPE. It is not dead. It is not atrophic. It's stressed. So it means that whatever the trigger is, it stresses the RPE, it causes irritation to the photoreceptor maybe, and then the stress RPE release is relieved, and that's why the fundus autofluorescence return to normal and the photopsia is gone. That's a good one. That's a very good one. And very good brainstorming, thinking how pathology can happen, and sometimes it happens and it stops spontaneously. So no need to treat or hurry to treat, and follow up is one of the most important things in relieving the patient and assuring the patient.
And sorry, one more thing there, Professor Musa. I think for me, it was just the fact that I could do all the investigations and absolutely localize the retinal location for the problem. So I never ever requested neuroimaging for her. Whilst, you can see other specialists being quite nervous about a unilateral nerve, infranasal defect. And it's just the beauty of autofluorescence that really helped you say, yes, this is retinal and nothing else.
Yeah, that's a good point. And non-invasive and follow-up, that's the regimen for this case. Thank you, Dr. Pat. Thank you so much.
No, it's my pleasure. Thank you.
Thank you. I don't know if Dr. Patricio is here or not.
I am.
Is he here?
I'm here.
Oh, you are here. Long time no see. You
Yes.
are coming late. Why? What are you doing in Spain?
I don't know. Just having some relaxing time here, but
Okay.
I was not able to get through the Zoom link. But finally, I'm here. Yeah, with all of you. Thank you so much.
Okay, thank you, and nice to see you again. And I hope you enjoying going back to your country. And
Yes.
we are going to enjoy your case today. Please
Yes.
go ahead.
Okay. So thank you, Dr. Alanri, Professor Musa, and all my esteemed colleagues and all the attendees for having me here today. I am going to present a case of choroidal lesion. I want to thank my colleague Carmen Navarro for helping me out with this presentation too. And let's go ahead then. So this was a scared 47 years old female who had attended previously a facility outside of the country in 2017, and also attended recently a local clinic where she was advised to take intravitreal injections for her left eye. The patient presented to me with some old OCT images. So we can see here that the right eye is pretty normal, looks fine, and the left eye is pretty bizarre with something like a hollow macula, I don't know, outer layers, destruction, or we'll see. This is another of the images she had. Not sure if this is subretinal fluid here, maybe, not so sure. More images that she brought to me. So on examination, she had no complaints, and she came for a second opinion. Her best visual corrected acuity was 100% in her right eye and 0.15 in her left eye. And she said that she was like that for years. She also had a mild nuclear sclerosis in the left eye. The right eye was within normal limits for the fundus. And then the left eye presented an orange central lesion with central retinal scan. She had no previous history of eye trauma or eye surgery. So we did for her color picture, OCT, OCTA, and fundus and fluorescent angiography. So we can see here a well-demarcated orange lesion right up to the limit of the foveola, involving the foveola. And if you pay attention, we can see here something like a 3 arms star, which is just a central fibrosis. For the OCT, we can see thinning of the central retina with photoreceptor loss, subretinal fibrosis, and the lesion has areas of hypofluorescence and hyperfluorescence, hyperreflectivity, and this area of choroidal excavation. The OCTA shows an irregular vascular network between the RPE and the choroid. You can see here the branches of the capillaries. This is a mix of the OCT and the fluorescent angiography. We can see here this peak, which is the fibrosis. Through the center, again, the fibrosis, some empty spaces, but not real subretinal fluid. And this is the fluorescent angiography in the beginning at the 20 seconds with showing early hyperfluorescence. And then after 6 minutes, we see that there is only a staining, but not leakage. So at this time, and with all this information, what could be your recommendation for this patient? You would go ahead, as previously advised, with intravitreal anti-VEGF. Maybe you're thinking of PDT, just observation, or I don't know, I'm going to refer the case. So finally, did you make up your mind and you think, what do you think we are dealing with here? So the patient is under observation at the moment for choroidal osteoma with no active CMV. Conclusions, a second opinion is good for some special mystery cases. We don't know everything. And then we have several agreement possibilities. We all agree and we are right, so everybody happy. We disagree, but at least one of us is right. Or we are all wrong, either agreeing or disagreeing, which is the worst case scenario for the patient. References, and thank you so much.
Thank you, Patricia. It's a very nice case.
Thank you.
You didn't go through the OCT. I like the OCT images, and I was going to say it could be an osteoma because it's a long-standing lesion. It is not a new osteoma, because in osteoma we should see in the color picture the yellowish or grayish elevated mass, choroidal mass, elevating the retina. But this patient has a very long-standing lesion. And if you can go back to the OCT, can you show us the OCT? You have multiple line scans, which is very good. Can you show us one of them to highlight this? Yes, yes. This is a very good one. It shows the long-standing osteoma can cause rarefaction in the retina and the choroid. Why? Because of the osseous bone is absorbed by the time, and you find cavitation in the choroid, huge cavitation. As you can see here, there's almost eaten up, all the choroid is eaten up, and this is the residual degenerative cyst and the calcification. But again, it's a very nice case, and there's a choroidal excavation too. So it means it's a very long-standing lesion with a lot of degenerative cyst because of the choroid is already eaten up by the osteoma, and there is rarification and decalcification, and that's why you have a very thick choroid, but there is nothing in there except the residual osseous or bone formation. So this is a very nice illustrating, but I have a case like this. I followed up for 10 years, and I found out after a few years, the calcification started to resolve. There is no osseous, there is no bone anymore, and sometimes you find a very, very thick choroid and hollow. There is nothing in there. And this is another point. My case had a CMV, and I injected her twice. And after that, OCT angio was the only clue that there was a CMV there. And she was treated in US by a couple of injections. She came back to Egypt. I gave her another couple of injections. And after that, she's stable for years. Thank you for illustrating this case. And again, it's a very nice to have a variety of cases, but this is a long-standing osteoma. And it sounds very, very nice case.
Definitely. Most osteomas starts at the late teens or early 20s. Yes. So this is probably a 20 years plus osteoma.
Yeah. Thank you so much. Thank you.
Thank you.
Any question, Dr. Fahd or Dr. Amin, for this nice case?
No, just one question for Patricio. Whether you would have done an ultrasound as well. I don't remember whether you did that as part of your workup, or maybe a CT scan. Sometimes I think they're very, particularly when they're quite advanced like this and atrophic, sometimes it's difficult to be sure.
You can do several things. The easiest one is to do just a plain X-ray where you can see the calcification. But if you want to go for an A scan, you will see a spike. And if you want to go for a B scan, you will see something like a hyporeflectivity there, an elevated region. It all helps, but in this case, for example, for the CT scan, again, a CT scan, you can see the calcium in the eye, and for the MRI, it's hypointense in both T1 and T2. But I mean, I don't think you really need to go into, let's say, brain imaging for diagnosing osteoma. I don't know what the other members of the panel think, but I usually don't request neither CT nor MRI. And the B scan, it's helpful, but I think that just a plain X-ray will show the calcification.
Or ultrasound, as he said, ultrasound is in our field. It's to confirm the diagnosis, to confirm the presence of osteoma. You will have a remnant, you will have a spike on the A scan, and you can see it, I think, probably in this area.
But I like the plain X-ray. That's a good tip. I will try that the next time I see you. That's a good tip.
Cheap and fast.
Yeah. Thank you, Patricio. Any question, Dr. Amin?
No, I don't have any questions. Thank you very much for the wonderful case.
Thank you, Dr. Patricio, and I'm glad to see you again. And I think the floor is mine now. I will share my screen. Please pay attention to my case, because I think you can see my screen now, right? Can you see my screen?
Yes, Professor.
Okay. So this is a case I presented almost 10 years ago, and I repeated some of the OCT when I had this website. That was 2013, almost 10 years ago. I had a child with a couple of cases, but this is to get the message. I have a child with multiple matches in both eyes. He's an 8-year-old boy. His left eye is a 636, discovered accidentally during routine examination at school. They sent him why his vision is low in this eye. Right eye 6.6 and no error of refraction, no systemic illness. Anterior segment was unremarkable, and he has bilateral intraretinal mesh lesions in both eyes. And here is the right eye, as you can see, and the left eye. There is one lesion here in the center and one lesion at the periphery. Let me magnify the right eye. This is a mesh lesion, intraretinal and probably protruding over the retina. And there's another mesh lesion up there beyond the arcades. And again, it's a yellowish mesh lesion, well circumscribed. And this is the left eye. There's a yellowish circular lesion, looks like an RP atrophy, which is not, and we will show you in a minute. And this is another tiny peripheral lesion, again, beyond the superior arcade. So when I looked at the child and asked his mother about any history, nothing, was full term, had nothing at the early childhood, no history of trauma. And I looked at him and I said, what is going on? So I did, that's a spectral domain OCT at that time. And this is the lesion. It's intraretinal, protruding over the surface of the retina. But again, it is included inside the retina because you can see the retinal internal limiting mirror over the lesion. It's a very hyperreflective lesion and shadowing the underlying structure. We don't see much of the RPE or the outer retinal layers because of the shadowing. And this is the lesion. And this is a horizontal line scan through the macula. It sounds okay. But again, it's at the upper end of the lesion, this one. And this one is passing through the lesion. Again, there's a thick epiretinal fibrosis and a very dense hyperreflective intraretinal lesion shadowing what's underlying. And I did swept source OCT at that time. I had a trial, a prototype of swept source, 2013. It looks homogeneous, hyperreflective lesion occupying all the retina. And there is hyperreflectivity over the surface, which looks like a thick epiretinal hyperreflectivity or membrane. And this is, again, macula is free in both eyes. And this is the lesion beyond the arcades. Look at this lesion. Multiple hyperreflective cystic changes inside the lesion, small and large ones, and multiple hyperreflective dots or foci. It looks like calcification. And this is the lesion. And this is, as I said, intraretinal mass with loss of anatomy. There is disorganization. There is no differentiation of the retinal layers in this area. And it looks like a moth-eaten empty spaces presenting intraretinal calcification, also the hyperreflective lesions, and shadowing what's underlying, which means the lesion is full of hyperreflective tissue. When I looked at this boy and I said, let me go through the lesion again, magnified picture showing the calcification I'm speaking about, the hyperreflective foci, and the degenerative or hyperreflective cyst inside the lesion. And this is another swept source line scan through the lesion beyond the arcades. And this is another swept source OCT through vertical and horizontal through the peripapillary region. And as I said, it's homogeneous, hyperreflective, amalgamated lesion. There is no differentiation inside. There is no differentiation of the retinal layers inside this area. And this is the left eye, which was astonishing for me. Why visual impairment? The macula looks okay. It's a little bit thin, but why 636? I don't know. And I went through the eye with multiple line scans, and I magnified this to see there is mild attenuation, or what can we call rarefaction, of the parafoveal ISOS or the ellipsoid zone. But in the fovea, it's intact. And I still cannot explain why the vision is affected in this eye. And this is what brought the patient in. Is it a long-standing lesion? Is it atrophic? Though we cannot see atrophy in the RPE or thinning, but we can see there is, like, as I said, attenuation or rarefaction or thinning of the parafoveal ISOS junction. And this is the left eye, the peripheral lesion, another small, tiny, hyperreflective lesion occupying most of the retinal layers. Yes, protruding into the vitreous, but still it's intraretinal lesion. So any of the panel want to comment on this, because I'm moving. The clue of the case was the face. He had adenoma spatium in the face.
So I'm thinking,
yes.
So these are retinal astrocytomas, I think, particularly with the hyperreflective lesion and the intraretinal calcification. And the adenoma sebaceum is a feature of this condition called tuberous sclerosis. So yes, you'd want to do an MRI. I'm just thinking, you know, with the do they resolve, Professor Magdi?
No.
Can they spontaneously resolve? Could that be the
No,
explanation
they
for the
decrease in size.
macular one?
It could be in the macular one, but even if it's in the macula, it should left some atrophy. But I couldn't find anything to justify why the vision is dropped. Maybe the photoreceptor is affected, maybe, but I don't know. It's minimal attenuation, which can drop the vision to 636. I don't know. It could be a macular lesion and resolve, but I haven't seen in the literature they don't resolve that rapidly. And the boy is 8 years old. How long he had it and how long it takes to resolve a lesion like this?
And I'm just thinking. I'm thinking aloud. I might be wrong, but I'm just trying to think. Is there a particular lesion that might be paramacular? It might give you retrograde atrophy, maybe. But I'm thinking maybe not. Wouldn't affect the photoreceptor with it.
I looked carefully, but there was nothing. It could be a parafoveal lesion and it caused atrophy in this area, but I couldn't. So as you said, it's the clue is the adenoma sebaceum. It's astrocytic hamartoma. It's a benign tumor developed from the neurological tissue, which is the astrocyte, and that's why it's like amalgam. It's homogeneous. It's hyperreflective because it's full of astrocyte, and it could be purely ocular, as I showed you. And the adenoma sebaceum, or the, you know, this tuberous sclerosis or Bourneville disease is the clue. When you find a face like this, you should examine the eye, you should examine the brain, as I said, because there might be systemic association. And this is the typical presentation of astrocytic hamartoma. Yellowish intraretinal lesion can occur in the peripheral fundus or in the peripapillary area, and are typically elevated yellowish nodular calcific mulberry-like lesions sometimes. Let me go through the second case to give you another message in the second case. This is a typical astrocytic hamartoma in a 15 years old female. She had chronic headache, and listen, this is a neurological sign, with blurring of vision and transient attack of consciousness disturbance. Vision 6/6 by -1 sphere in both eyes. Slit lamp examination unremarkable, and this is the fundus picture. Multiple astrocytic hamartomas. Yellowish, translucent, or opaque lesions that might be homogeneous or might contain glistening foci of calcification like the one up there. And this is, I think, a long-standing one. And this is calcified one. And this is the fluorescein. And this is the fundus autofluorescence. And this is the fluorescein angiography, early hyperfluorescence, late faint staining of these lesions. There is no leakage. They stain, and sometimes it is due to the autofluorescence, not only the staining. And this is the central and peripheral lesion. And this is fine capillary inside network inside the lesion. And this is staining of the calcified lesions. This is the left eye, peripheral lesion. There is nothing in the center, but then I looked carefully, subtle lesions, nasal to the disc, and another lesion at the extreme nasal periphery, translucent thickening of the nerve fiber layer. And this is the calcification we see. This is from one of my cases when I have the stratus at that time, 2008 or 2009, hyperreflective intraretinal mass with multiple cystic changes and calcification. And it's astrocytic hamartoma or retinal astrocytoma. It's derived from the retinal glial tissue, as I said, and it's called astrocytic hamartoma or slowly growing neoplasm astrocytoma. Both appear white, mulberry-shaped masses when multifocal and bilateral sometimes, and isolated tumor in some syndrome. And this is my patient. Look at the extensive tuberous sclerosis, and that's why we have to consult neurology, dermatology, nephrology, and cardiac, because multiple lesions could be there all over the body. And this is what happened in this case. She had subependymal and cortical lesions. That's why she had disturbance in the consciousness, severe headache sometimes. And this is renal angiolipoma. They call it angiolipoma. They are coincident lesion with the astrocytic hamartoma. And as I said, cutaneous adenoma sebaceum, depigmented macules, as we can see here, and café au lait patches. We have to check the skin, and this patient had one café au lait patch in her back. So again, this is a multi-system affection, and the headache was the only annoying thing. She was not complaining of her vision, 6/6 vision, and coincidentally, I found that in the fundus, and this is what we call tuberous sclerosis, and this is what we call Bournville syndrome, retinal astrocytic hamartoma, cutaneous lesion adenoma sebaceum, CNS astrocytoma, and internal tumor. Could be cardiac rhabdomyoma, could be renal angiomyolipoma like our case, could be pleural cyst, could be hamartoma in other organs like the liver or the thyroid. So it could be a fatal disease if we did not do a very well systemic workup. And my take-home message, astrocytic hamartoma is a congenital, benign glial tumor of the sensory retina occurring as a part of tuberous sclerosis sometimes, as we have seen. And the great majority of retinal astrocytic hamartoma are asymptomatic, non-progressive. Sometimes they discovered accidentally, and sometimes through the neurological examination, they send us the patient for fundus examination because they already diagnosed Bournville disease. And the systemic evaluation is very important because the CNS manifestation of the CNS lesions sometimes is there. And no ophthalmological treatment is required for these cases. An ocular examination should be performed yearly in a patient follow-up for other manifestation of tuberous sclerosis and if any other complications happen. Thank you so much for your listen. I'm open for any question.
Yeah, when you see one of these children, what's your differential diagnosis to make up our mind?
Neurofibromatosis is my first differential diagnosis, like hamartoma of the retinal pigment epithelium. This is one of the most important things. Other thing is retinal nerve fiber layer infarction. Myelinated nerve fibers should be in the differential diagnosis because it's a yellowish lesion. It's in the superficial layers. Yes, sometimes it stays there. But again, neurofibromatosis is one of the most important differential diagnoses. And it also happened to have a café au lait patches and hamartoma of the retinal or retinal pigment epithelium. And I can't think of anything else, but this is the most important differential diagnosis. Sometimes retinoblastoma should be differentiated because we should not wait to prove that it's a retinoblastoma, but retinoblastoma comes in a younger age, cannot be that multiple and solitary or small lesions. Sometimes if it's a one lesion, it's huge. If it's a multiple lesions, the retina will be affected earlier than this, and the patient will come rapidly for that, especially if they have a past history of retinoblastoma in the family. So again, retinoblastoma is one of the differential, neurofibromatosis, myelinated nerve fibers, and these are the most important differential diagnosis if I'm not forgetting anything.
Yes, thank you. No, I was thinking that I've seen many children with bone marrow transplants. And for these children, I would think also maybe of ruling out lymphoma.
Sure. But lymphoma, as you see a lot of patients, it has to be with a sort of vitritis or inflammation or uveitis. I mean, it doesn't come that quiescent eye. But again, it's in the differential, as you said.
Thank you, Professor.
Thank you. Any questions, Dr. Fahd or Dr. Amin, before we conclude this session? We are 5 minutes ahead of though we started 10 minutes late. but I'm glad that we didn't, spend more time. Any questions? Or you want to conclude?
Let's conclude. No questions from me, Professor Magdi.
No questions from my side.
Thank you, Dr. Amin. Let me conclude this session and thank Dr. Al-Amri and Dr. Fatma from Qasmi Hospital for their kind invitation for us to share. And I'm inviting you tomorrow. We have another wide field imaging session tomorrow at the same time, almost tomorrow, 7 o'clock in the evening, 8 o'clock Emirates time. And I'm asking all the participants to be in Hall A now because there is a keynote lecture. Dr. Al-Amri didn't give me that time. He popped up with his picture now, and he's smiling at us, and he's checking that we are on time. You have 5 more minutes. Yeah, I mean, you can speak in this 5 minutes before the next lecture. Thank you again, Dr. Al-Amri, for kind invitation. And thank you, my participant, Dr. Amin, Dr. Fah, Dr. Patricio, and hope to see you again soon.
Thank you, Professor Magdi.
Thank you. Thank you.
Dr. Majdi, thank you very much, Dr. Patricio, Dr. Fahad, and Dr. Amin for this very interesting session, and on time, even less. Thank you very much. This is one amazing, the most amazing session, as usual.
Thank you.
You can stay with us, Dr. Majdi, here also. It will be great to have you also. We will have Dr. Rahal as a guest of honor today, as speaker.
Dinner will be served or not?
Sorry? Yeah, it will be through the Zoom. Sure.
There is no dinner through the Zoom. Thank you so much. It's very tasty.
Yeah, everything like. Okay, we will give another few minutes because still we are having a time. If anyone want to take a rest and come back, it's okay, because we are having another session not yet finished. So we will wait for them to finish, and the attendees, they can join us in this session. This is the last session and the only session at the same time. There is no 2 sessions at the same time, only 1 session. So to have or to enjoy Dr. Hala presentation as a guest of honor for the first day of QOIC conference.
Okay, we'll take a break 5 minutes and come back. Thank you, Dr. Amin.
Okay, thank you. Thank you, Dr. السلام عليكم دكتورة هالة، مساء الخير.
عليكم السلام، مساء الخير.
مساء النور، كيف الحال؟ إن شاء الله بخير. شكرا جزيلا على استجابة الدعوة، شكرا جزيلا.
I'm honored to be here. Thank you very much for the gracious invitation.
Thank you very much. Okay, so if you allow us, we will start now. So, Assalamu alaikum. Good evening, dear colleagues and friends. Welcome to the last session of first day of 8 quick conference meetings. And we hope that you enjoy all the sessions. And today we are going to have the last session in the Hall A. It will be a guest of honor for us to have Dr. Hala. She is the guest of honor for today in these sessions. Dr. Hala Al-Hilali, she's a professor of ophthalmology, Cairo University, Vice President of Egyptian Association Pediatric Ophthalmology and Strabismus, Advisory Board Member of International Pediatric Ophthalmology and Strabismus Council. She is also International Strabismus Association Board Member, co-chair of ISA Website Committee, Director of Pediatric Ophthalmology and Strabismus Unit, Cairo University, 2015-2019, Special Interest Pediatric and Adult Strabismus, Pediatric Cataract and Pediatric Glaucoma. And we are happy to have Dr. Hala with us today and to give us a guest of honor lectures or keynote lecture for us. Dr. Hala, the mic with you, please. You can share the screen. Can you stop share screen, please?
I will. So share screen. Again, thank you very much for the gracious invitation. I'm really honored to be here presenting pediatric cataract surgery in 2023. I have no financial interest to disclose. The management of pediatric cataract depends on whether it is unilateral or bilateral, as well as the age of the patient. In unilateral cataract, if the patient is less than 6 months of age, we perform pars plicata or limbal lensectomy, followed by visual rehabilitation with contact lenses or aphakic glasses. Patching of the fellow eye is carried out to treat the deprivation of amblyopia. If the child has unilateral cataract but is above 6 months of age, bimanual irrigation aspiration and an IOL is implanted. Pars plicata, posterior capsulectomy, anterior vitrectomy is performed, and then patching of the fellow eye is carried out again to treat the amblyopia. In bilateral cataract cases, if the child is less than 2 years of age, bilateral pars plicata lensectomy is performed, followed by aphakic correction with glasses or contact lenses. Between 2 and 6 years of age, phacoaspiration and IOL implantation is performed, followed by posterior capsulectomy and anterior vitrectomy. This can be either performed through a pars plicata approach or through an anterior approach via a posterior manual capsular access. If the child is 7 years or older, we perform the same procedure without anterior vitrectomy because the risk of epithelial cells proliferating across the anterior vitreous space is reduced at that age, and the child is old enough to be able to sit at the YAG machine. This is the consensus that we use in Cairo University Pediatric Ophthalmology and Strabismus. This is what we do in cases of unilateral and bilateral cataract patients. Of course, micro-incisional techniques have really helped a lot in pediatric cataract surgery, minimizing surgically induced trauma, decreasing the inflammatory response, hastening post-operative recovery, allowing us immediate optical correction and amblyopia treatment. I prefer in cataract surgery without IOL implantation to use the pars plicata approach for lensectomy because it results in minimal surgical trauma to the cornea and the iris, reducing the inflammatory response. It ensures that there is no corneal scarring related to incisions, no iris strands adherent to the corneal entry sites, and ensures the absence of vitreous in the anterior chamber or incarcerated at the incisions. You can see here the gonioscopic appearance of iris attached or incarcerated to the corneal incision. This is seen through a gonio prism. The sclerotomy site depends on the age of the patient, and it's related to the postnatal development of the ciliary body and the pars plana. So children up to the age of 6 months, in children up to the age of 6 months, the sclerotomy site is 1.5 millimeters from the limbus, but as the child gets older and the eye grows, at 3 years, the sclerotomy site is further back and it's placed 3 millimeters from the limbus. This is the regular case of pars plicatal lensectomy. Conjunctival incisions are performed, mild or cauterization, followed by the creation of the incision with an MBR blade, and the incision is carried into the equator of the lens. The irrigation cannula and the vitreous cutter are introduced. The port of the vitreous cutter is placed to the side, and only aspiration mode is activated to remove, and that's all that is needed to remove the cortex. This is followed by directing the port of the vitreous cutter posteriorly to initiate the opening in the posterior capsule, and this is then enlarged to an adequate size. When we keep the port of the vitreous cutter to the side, this is to avoid premature opening of the anterior or posterior capsules until all the cortex has been removed. After performing an adequate posterior capsulectomy, the port is again directed anteriorly to remove the central part of the anterior capsule, and this is kept until the very end. This reduces turbulence in the anterior chamber and minimizes the risk of injury of the cornea or the iris. Anterior vitrectomy is then performed, and the sclerotomy sites are closed. The parameters that we use during pars plicatal lensectomy are for cortical aspiration, a linear vacuum up to 400 millimeters mercury, keeping the cutting rate at a minimum because cutting is really not needed. Anterior and posterior capsulectomy require a linear vacuum up to 500 millimeters mercury and a cutting rate of 800 cuts per minute. Anterior vitrectomy, again, the cutting rate is kept high at 800 cuts per minute, but we reduce the linear vacuum to about 300 millimeters mercury because you don't want to be pulling excessively on the vitreous while you're performing the anterior vitrectomy. We oftentimes encounter persistent fetal vasculature cases with vascularized membranes. And if you look at this membrane, it looks like there are a lot of blood vessels on it, but most of these blood vessels are ghost vessels. There's very little bleeding that occurs from them, and there's no need to cauterize most of these membranes with vascularization. So after removing the lens cortex, an anterior capsular access or capsular opening was performed. This is the retrolental membrane that's being removed now by cutting using the vitreous cutter, but you can see that these vessels are not bleeding. It's important here to enlarge both the anterior and the posterior capsular openings to a size a little bit larger than what we use for pars plicatal lensectomy, because there's a very high tendency for these, especially for the posterior capsule, to contract in cases with persistent fetal vasculature. This is a rare case where where there was a ferocious blood vessels on the retrolental membrane. So after aspiration of the cortex with the vitreous cutter, endocauterization was introduced to occlude these blood vessels and reduce the incidence of bleeding as the vitreous cutter is used to remove the retrolental membrane. It was quite thick, required quite a bit of cutting with the vitreous cutter. This was followed by removal of the central part of the anterior capsule with the vitreous cutter. And I want to show you here an important step, which is shaving of the vitreous at the site of the sclerotomy to prevent incarceration of vitreous in the sclerotomy site, followed by closure of the sclerotomy. Oftentimes we encounter narrow pupils, especially with microphthalmic eyes. And in this case, 4 clear corneal incisions are performed. Viscoelastic is introduced into the chamber to inflate it. And I always take a good look at the angle of the anterior chamber. 4 iris hooks were then placed to dilate the pupil to an adequate size. This is really a case where a pars plicata approach comes in handy, because with the tenting up of the iris by the iris hooks, it would be very difficult to introduce instruments through the anterior chamber to perform a limbal lensectomy. After removal of the cataract, the sclerotomies are closed. The iris hooks are removed one at a time, and the 4 incisions are closed with, or are sutured with 10-0 embedded sutures. This is 2 weeks after the surgery. Patient came back for removal of sutures. There's a subconjunctival hemorrhage seen here from the injection of atropine subconjunctivally at the end of the procedure. The sutures are cut, and you can see here that there is minimal distortion of the pupil from the iris hooks that were used in the first surgery. Again, oftentimes we encounter cases with congenital absence of the central part of the posterior capsule, what we call posterior lenticonus. And the ultrasound by microscopy here shows that most of the lens matter has herniated through a posterior defect in the lens into the vitreous cavity. So in this case, again, pars plicata lensectomy comes in handy. The irrigation cannula is used to support the lens matter and bring it slightly forward to be easily aspirated with the port of the vitreous, through the port of the vitreous cutter. This will prevent any escape or of the cortex posteriorly. This is followed by activating a cutting in order to enlarge the already present defect in the posterior capsule, and then perform an anterior capsulectomy. And this is another case, but in this case, there was a defect in the anterior capsule. This is much rarer than posterior lenticonus. Again, a pars plicata approach was used. The sclerotomies were performed using the MVR blade. The irrigation cannula was introduced. Aspiration of cortex was carried out using the port of the vitreous cutter. And you can see here, as we remove the cortex, the outline of the central defect in the anterior capsule. This is followed by completing the cortical cleanup using the vitrectomy, the vitreous cutter, with again using only aspiration here. And this is followed by removal of the central part of the posterior capsule, thereby creating openings both in the anterior and the posterior capsule. This is a combined approach. Sometimes we need to use both an anterior and a posterior approach when we have what we call cataract plus, which is cataract beside other congenital abnormalities. In this case, there was congenital ectropion uvea, remnants of pupillary membrane, and an anterior polar cataract. And there was also iridocorneal adhesions at the periphery. So viscoelastic was used to perform a blunt dissection of the periphery of the anterior chamber, separating the back of the cornea from the iris. The blunt tip cannula of the viscoelastic was then used also to sever the posterior synechia that were present in all 4 quadrants, thereby enlarging the pupil. And then the remaining part of the surgery was carried out through the pars plicata in the usual manner. At Cairo University Pediatric Ophthalmology and Strabismus Unit, we studied the incidence and the risk factors for retinal detachment after pediatric cataract surgery. It was a retrospective review of cases that were operated between 2016 and 2019. 568 eyes of 372 children were included. Surgery was performed through an anterior approach in 66% of these cases, and a pars plicata approach in 34%. The incidence of retinal detachment was 8 eyes, or 1.4%. There was no statistically significant difference in the incidence of retinal detachment between eyes operated through an anterior or the pars plicata approach. The mean time after surgery for occurrence of retinal detachment was 2.14 years. Between the age of 2 and 6 years, an intraocular lens is implanted in conjunction with the cataract surgery. I'm sorry, this is not advancing. Let me see how that's going. So I don't know what to do. Okay. So I'll restart the program. I'm sorry. Can I share the screen again? I'm sorry.
Yes, please share.
Okay, thank you. I'll advance the slides. And I come back to where I want. I'm sorry about that. Okay, here we are. So 2 side port clear corneal incisions were performed, and the corneal tunnel was also carried out with a keratome. A bent tip needle was used to initiate the initial cut in the anterior capsule. This was followed by capsulorhexis forceps performing the anterior capsulorhexis using ripping rather than shearing. This is hydrodissection of the lens matter, followed by phacoaspiration, which really shortens the time that is taken in cortical cleanup. This is polishing of the back surface of the anterior capsule, followed by introduction of a single piece hydrophobic acrylic IOL into the bag. And once I ensure that the IOL is in the bag, the corneal incision is sutured with 10-0 sutures, and this is followed by introduction of a vitreous cutter through a sclerotomy in order to perform removal or the posterior capsulectomy, central posterior capsulectomy, and anterior vitrectomy. And this is enlarged to an adequate size, followed by closure of the sclerotomy. I like the pars plicata approach because it ensures that the IOL is within the capsular bag before I remove the central part of the posterior capsule. It centers the posterior capsulectomy behind the IOL in a good fashion. It allows better sizing of the posterior capsulectomy, and it ensures absence of vitreous strands in the anterior chamber and the wound. Actually, presence of the IOL in the capsular bag stretches the posterior capsule, and it becomes easier to perform the posterior capsular opening and to size it the way you want. Sometimes the anterior capsulorhexis is difficult if there is difficult visualization of the anterior capsule. And in this case, an air bubble is introduced into the anterior chamber. Japan blue stain is then injected behind the air bubble in front of the anterior capsule. And then viscoelastic is used to remove the air bubble. And then the anterior capsulorhexis is performed. It's initiated again with a bent tip needle. And you can see here that the stain has really done a good job staining the anterior capsule, allowing or improving visualization. Again, here, ripping process is carried out in order to keep the anterior rhexis at a good size. This is a small capsule. Sometimes I perform a small capsulorhexis and then enlarge it later after introduction of the IOL. This is another case where the entire procedure was carried out through an anterior approach. After removing the cortex, a bent tip needle is used to create an incision, a small incision in the posterior capsule. Viscoelastic is then introduced behind the posterior capsule to push the anterior vitreous face back, and capsulorhexis forceps are used to complete the posterior capsulorhexis. Anterior vitrectomy is then performed through the anterior approach. viscoelastic is introduced to inflate the bag or the space between the anterior and posterior capsules. The IOL is then injected into the space between the anterior and posterior capsules, dialed in place. You can see here both the anterior and posterior capsular access openings, and all incisions, of course, are closed or sutured in children. Another technique that you can use is to introduce the IOL after performing a rhexis, but leave the anterior vitrectomy till after the IOL in place. And this creates a barrier between the anterior and posterior compartments and reduces the possibility of herniation of vitreous into the anterior chamber. So this is a case where I did just that. Viscoelastic was introduced into the bag. The bent-tipped needle initiated the small hole in the posterior capsule. This is followed by a manual capsular rhexis. But you can see that in this case, there was a fibrotic plaque attached to remnants of the hyaloid, persistent hyaloid artery. The capsular rhexis was completed, but the fibrous plaque had to be severed with micro scissors. Viscoelastic was then introduced to create a space between the anterior and posterior capsules. The IOL was introduced in that space and dialed into place. After centration of the IOL, the vitreous cutter was introduced behind the lens to remove the fibrotic plate and also to perform an anterior vitrectomy. Cases where that are above the age of 7, again, we don't need to perform a posterior rhexis. In this case, viscoelastic is introduced into the bag. The posterior rhexis is performed. You can see here the viscoelastic pushing the anterior vitreous face back. The posterior rhexis is performed again manually with capsular rhexis forceps. The IOL, once this is completed, the IOL is introduced into the bag here, or the space between the anterior and posterior capsules is dialed in place. You can see the posterior rhexis and the anterior rhexis openings. In this case, the anterior rhexis opening was quite small, and I enlarged it after I introduced the IOL. Then the corneal incision was sutured. Again, in Cairo University Pediatric Ophthalmology and Strabismus Unit, we carried a study, we performed a study of changes in intraocular pressure and anterior chamber angle after congenital cataract extraction. It was a retrospective observational study that included all congenital cataract cases with a minimum of 1 year postoperative follow-up. IOP and gonioscopy were measured at 1 year and 2 years. Actually, this study is still ongoing. Every year, we call back all the patients to measure the intraocular pressure and to perform gonioscopy. But this is part of the study that has already published. 424 eyes were present in the database. 206 completed 1 year follow-up. Intraocular pressure was elevated in 23 of 201 eyes, 11% at 1 year follow-up, and at 11 of 86 eyes, or 13%, 2 year follow-up. Risk factors for elevation of intraocular pressure were age at surgery, if it was less than 2 months, aphakia or absence of an IOL, and increased central corneal thickness. Currently, we are using an enhanced monofocal intraocular lens in the pediatric cataracts for children 6 to 13 years of age, and we're comparing it to the standard monofocal IOL. So the enhanced monofocal IOL is optimized to improve intermediate vision without jeopardizing the distance vision, which is something that children really need now with the use of computer screens, and intermediate distance is becoming very important. This IOL has a sustained shift in power, progressing from the periphery to the center. The aim of the study was to compare the visual performance of the standard monofocal IOL versus the enhanced monofocal IOL. It was a prospective randomized study in children aged 6 to 13 years with visually significant cataract, whether the cataract was unilateral or bilateral. 45 eyes were included in the study and were randomized. A thorough preoperative evaluation was carried out. Calculation of IOL power was done using the Barrett Universal 2 formula. Follow-up of the cases was done 1 day, 1 week, 3 weeks, 6 months, and 3 months after surgery. Now, we used monofocal defocus curves to study the performance of and to compare the performance between the two IOLs. And this is an objective method that measures the expected visual acuity at different simulated distances. It removes the factors affecting near vision, such as the near reflex, which occurs when viewing the near chart. It eliminates the learning effects of the chart. So what we do here is for example, by placing minus 1.5 diopter lenses in a spectacle frame, that would simulate the intermediate distance of 66 centimeters. And by placing minus 3 spectacle lenses, you will be simulating a distance of 33 centimeters, which is the near distance, versus the first one, which was the intermediate distance. So to perform the monocular defocus curves, any distant correction was placed in the trial frame. Distance visual acuity was measured at 4 meters using trial lenses from +1 to -4. Negative lenses were first added in 0.5 diopter increments until -4, and then positive lenses were added in 0.5 diopter increments till +1. Contrast sensitivity was measured using a Pelly-Robson contrast sensitivity-based chart. So when we looked at the defocus curves and compared the standard monofocal IOL, which is the orange line, versus the enhanced monofocal IOL, we found that the performance of the enhanced lens was much better at intermediate distance, where you see here at the -1.5 diopters, the visual acuity was 0.3 logmar, which is 612, reasonable intermediate vision without spectacles. Again, there was a statistically significant difference between the two, both at intermediate and at near distances. Contrast sensitivity was the same in both groups. So defocus curves showed that there was tolerance to residual refractive errors in the eye-hands group. Good performance with little affection of visual acuity was present in the eye-hands group with +0.5 and +1 defocus lenses, which meant that if we targeted a slightly myopic refraction, such as -0.5 or -1, that will not really significantly reduce the uncorrected distant visual acuity, but will have the added benefit of improving uncorrected intermediate and near visual acuity. The drawbacks, however, of this myopic target refraction is a theoretical risk of myopic progression in these children. Again, there was no difference in contrast sensitivity, which means that the enhanced monofocal IOL might have an advantage over multifocal IOLs, which usually cause a reduction in contrast sensitivity and visual quality. So finally, to conclude, to infinity and beyond, newer technologies and instrumentation has improved remarkably the surgical outcome in pediatric cataract surgery. Advances in intraocular lens materials and designs have ameliorated the performance of IOLs in children. And we expect that enhanced monofocal, extended depth of focus, and accommodating IOLs will hold promise in the future. I want to thank you for your kind invitation of having me in this prestigious meeting. And on behalf of Cairo University and Pediatric Ophthalmology and Strabismus Unit, I would like to welcome you all at the unit anytime that you would like to visit. Thank you.
Thank you very much, Dr. Hala, for this very interesting and comprehensive talk. There is many questions. It came to my mind myself. Maybe there is another colleagues they will ask. Now, in the first page, your presentation, you divided the cataract surgery, those they are unilateral or bilateral. I was seeing one of them that they are in the age of 6 years, but you are not implanting an IOL. I didn't get.
No, I am. No, I do implant IOLs, of course. No, I do implant. The first slide was unilateral cataract, and these were 6 months of age, not 6 years. So below the
Yes.
age of 6
Second one.
months.
Yeah.
The second one was below the age of 2, where we don't usually implant. We can start implanting the. Yeah, but below
Why
the
you
age
are
of 2, we do.
Yeah, this is
Sorry?
the question. Why below 2
Yeah.
years you didn't implant, while in above 6 months you can implant?
Because
Unilateral.
Exactly, that's a really good question. Thank you. In unilateral cataract, you really have to fight amblyopia, because this is a very, very severe type of deprivation amblyopia. And what you want to do in this patient is to get a clear, focused image on the retina of this patient at that age, at the age of 6 months, which is the age of critical visual development. This is why we can implant an IOL in a unilateral case above the age of 6 months. But in a bilateral case, you don't need to do that, because there is the deprivation amblyopia is not that bad. Both eyes have had cataract extraction, and you can visually rehabilitate them with spectacles, with glasses, until they reach the age of 2. Now, the reason why we prefer to do that is because of a myopic shift, a large myopic shift that occurs in the first 2 years of life. But that is something that you have to deal with later if you're doing a unilateral cataract case. And this is a compromise you have to go for.
Okay, there is another question, Dr. Now, what is the age that you feel that can you give the intraocular lens implantation, and you don't need to, to remove it after a while, because as the child is increasing by age, the size, the measures of the IOL calculation, it will be changed.
Yes, at the age of 7 years, when the child is 7 or above, we place the IOL power at the correct IOL power that we're getting, because there is little change, and there's little myopic shift after the age of 7 years. But below 7 years, if it is a bilateral case, we undercorrect and we leave a residual hypermetropia. We don't give the entire IOL power. We reduce that by 2 to 3 diopters to take into consideration the growth of the eye.
Okay, and then he will use glass spectacles to overcome the.
Exactly. Yes. Yes.
Anyway, it was a great approach. Also, I don't know what is the difference. You have mentioned about if you are approaching lens approach, a corneal approach in cataract surgery pediatric, or you are doing in the pars plana or pars placta. So what is the difference between both this one?
Okay, again, thank you. This is a very good question. I just wanted to show all the techniques that are possible to use. And they all, it depends on really the surgeon and what he prefers. So by placing the IOL into the bag before removing the posterior capsule, you really ensure that the IOL is in the bag. Because otherwise, sometimes the posterior rexus can extend. You might not be able to put the IOL in the bag. You would have to put it in the sulcus. But by placing the IOL first in the bag before removing the central part of the posterior capsule, you don't have that chance. You have the IOL in the bag. You go from behind, and as I said, the IOL flattens and stretches the posterior capsule for you, and it becomes easy and safe to remove the central part of the posterior capsule, knowing that the IOL will remain in the bag. That's one way of doing it. The other way of doing it is to perform a posterior rexus anterior vitrectomy and then place the IOL. Now that carries the risk of sometimes having the posterior rectus extend or becoming too large to place the IOL in the bag. And then you would have to change your approach and use a 3-piece IOL in the sulcus. And we always, in children, try to have the IOL in the bag because that reduces greatly and significantly the amount of post-operative inflammation.
Doctora, but whenever you start and implant the lens itself, then you go to do the posterior capsule rhexis. Don't you feel maybe there is sometimes there will be an extended of or enlarged of the posterior capsule rhexis, and then there is a chance of falling down of the lens?
Okay, so first of all, you use a very low flow from the irrigating cannula when you do that, because you don't want to increase the pressure in the anterior chamber and push the lens back. But when you do a controlled cutting rate and a controlled removal of the central part of the capsule, I haven't encountered that happening.
The last question, because I'm not a pediatric, I don't have this. Okay. So whenever you do a cutter in the posterior capsule by the vitreous cutter, I don't know how you do it in this round circle very easily or without any, I mean, extended, or what is the technique you are using in this way? Yeah, I know you have to do it. Then, yeah.
Yeah, actually, when you use the 23 gauge vitreous cutters, they help a lot. They're much better than the 20 gauge. And just by practice and engaging the posterior capsule and just making sure that you're not pulling on the capsule as you cut it, that's how you do it.
I mean, it is a cut by cut, or you are just cut one area, then remove in a circle way while you are
No, it's cut all around. And I don't pull on anything, and I don't try to do anything manually except using the cutter.
Thank you very much, Dr. Hala. This is for very interesting and topics that you cover today, and we are happy that you are today with us. Today I want just to announce that our conference, glad to have you with us, and to announce that also you have been selected to be the star of this conference, and we have it for you with a trophy that it will be sent to you. I don't know if you can see.
Thank you very much.
Whenever it is.
Thank you very much. Really appreciate that. Thank you so much.
Thank you very much for your effort and for what you are doing in pediatric community for our children. Thank you very much, Dr. Hala, and we hope to see you, inshallah, also in the other session here tomorrow in a woman in ophthalmology.
Thank you.
Thank you very much.
Thank you very much.
And I would like to announce also for tomorrow for our colleagues, tomorrow we'll start at 2 o'clock. And also the CME accreditation, it will be calculated according to the time or to the sessions you are attending. At the end, I would like to thank all dear colleagues and the friends, speakers for today, for after this all around 15 sessions that we've done today, the whole of the day. Thank you and good night. Thank you. Bye-bye.